Rohan Willis and Dr. Antibo, both of which are online joining us live. Rohan, and welcome to ICAPA. Can we please connect Rohan Willis and Antibo, please? They will introduce the speakers and they will chair this session.
Hello?
Hi, Rohan.
Hello?
Hi, Anne.
Oh,
Hello.
hi, Laura. Hi. Hi.
Welcome to Cordoba.
Thank you. We've been watching the meeting. Excellent meeting so far. So I will start the session. I want to thank the Congress organizers for inviting us here. We're going to be hosting this session talking about the journey of APS from an undefined to defined syndrome. The first presenter is going to be Dr. Jason Knight. He's an associate professor of medicine in the rheumatology division at the University of Michigan in Ann Arbor, Michigan. Dr. Knight's research lab investigates the role of neutrophils, endothelial cells, and platelets in the thromboinflammatory complications of antiphospholipid syndrome, diabetes, COVID-19, and other diseases. And he's going to be talking about the cellular and molecular immunological mechanisms of antiphospholipid antibodies in APS. The presentation. Hi, good morning, everybody. I'd like to thank the organizers for inviting me to present this topic today. And what I'm going to be looking at is the usefulness of criteria and non-criteria antiphospholipid tests, and through the prism of their molecular interactions with their target antigens. So we know antiphospholipid syndrome is a multisystemic autoimmune disease characterized by the presence of antiphospholipid antibodies. And these antibodies are thought to develop when you have environmental exposure in patients to typically infectious agents with components that have structural similarity to APS antigens like beta-2-GP1 on the background of genetic susceptibility producing a break in tolerance. And then you have the production of polyclonal antiphospholipid antibodies that have a varied binding to a myriad of antigenic phospholipid and protein targets, cardiolipin, PSP, IPG, and phospholipid binding proteins like beta-2-GP1 and prothrombin. And over the years, we've had lots of researchers elucidate several mechanisms for how these antibodies work to produce disease, activating different cell types, coagulation factors, interferon.
Apologies, Rohan and all the speakers. We had a technical glitch and Rohan's presentation was streamed. So we are going back to the program as it should be. And the next presentation is that from Jason Knight. Apologies to everyone.
Hi, everyone. My name is Jason Knight. I'm a rheumatologist at University of Michigan. Thanks for the opportunity to talk to you about cellular and molecular mechanisms of antiphospholipid antibodies. Thanks so much to the ICAPA organizers. I can't imagine how much time has gone into this. Thanks also to Rohan and Anne for kind of organizing our small group. So let's get right into it. These are my disclosures. Since I was the first talk, I thought I would remind us all what we are talking about when we say APS. There's been 2 attempts at international criteria. There's a third in the way that we will hopefully hear a lot more about at this meeting. As it stands now, the clinical criteria are simple enough to understand. We look for thrombotic events and certain types of pregnancy loss, especially late pregnancy loss. But these lab criteria still remain challenging to teach to the medical student, in my opinion. And so I think it's useful to spend 5 minutes kind of reminding how we got here. How did we get to these lab criteria that we use to diagnose and classify APS? So this is a story that I would argue starts with syphilis, and that goes back to the 1940s when Pangborn taught us how to isolate cardiolipin from beef heart. Cardiolipin, of course, enriched in mitochondria, and heart muscle is a great source of that. And so this was the first effective way to screen for syphilis, because syphilis patients very consistently with high sensitivity get anti-cardiolipin antibodies. But soon thereafter, by the 50s, it was recognized that while a sensitive test, not so specific, and so many infections can give false positive syphilis test, but the classic example of a non-infectious cause was lupus. So back in the 50s, it was recognized lupus patients can get anti-cardiolipin antibodies. But it's this parallel story that, as I look back after the fact, really seems like what brought it together. And this was the business of circulating anticoagulants in lupus. So this is something you would expect predisposes to bleeding, but eventually investigators got brave enough to write up the true phenotype, which was not one of bleeding, but actually one of thrombosis. And so it turns out that these lab clotting tests contain lots of phospholipids, which is kind of an artificial cell surface where the clotting factors can find each other. And so antiphospholipid antibodies as a class artifactually prolong these clotting times. And this was eventually standardized to create the difficultly named lupus anticoagulant test, at least difficult for rheumatologists, explaining to patients that it is not equivalent to being diagnosed with lupus. So lots of great work was happening in the 80s, certainly very nice work in Mexico by Dr. Alarcon Segovia and colleagues, but the most cited paper ended up being this one from Hughes in the early 80s. So these are patients with lupus. Half of them have lupus anticoagulant and half do not. There was an association with false positive syphilis tests, so we will not forget about that. But then the compelling association was with thrombosis. The lupus anticoagulant positive patients were much more likely to have history of thrombosis. Also cool to see when we look at the fine print is other features that we still associate with APS today were present at this time back in the 80s. So I think really heralded what was to come. So by the mid 80s, we knew quite a bit. This messy issue had been cracked, and we understood that lupus anticoagulant phenotype associated with thrombosis, not with bleeding. There was often an association between lupus anticoagulant and different types of antiphospholipid antibodies, such as anti-cardiolipin. However, at least sometimes when investigators tried to work with these antibodies in the laboratory, they did not always seem to directly bind to phospholipids, so suggesting there might be cofactors present in serum that were serving as a bridge between antibody and phospholipid. And certainly that is at least part of the story. The first cofactor that was identified that is for sure stood the test of time and identified by 3 groups all around the same time is this one called beta-2 glycoprotein 1, also known as apolipoprotein H. So this dogma is being a little bit challenged, but there's one idea that beta-2 has certain forms in the blood that may not be so accessible to antibodies, but when it engages negatively charged surfaces, including phospholipids, it opens up and makes a very nice place for antibodies to bind. The antibodies likely cluster beta-2 on the surface, which can then drive signaling into the cell. So very cool, and clearly a story that has stood up. You know, the other, I think, cofactor that has had the most work is prothrombin, and this is something that was being thought about back in the 90s. But this must be the most important paper by Atsumi et al. In 2000 in ANR. And so what the authors showed here is that if you build an ELISA with prothrombin alone, it kind of works okay. But if you coat that prothrombin on the phosphatidylserine, you now have a much stronger association with lupus anticoagulant. So if you have high levels of IgG, APSPT, then you are likely to have a lupus anticoagulant. So what about pathogenesis? So maybe you would say we're some 50 years into kind of modern era, and still I think there's things to figure out, at least for me. You know, as we look back at the literature, with the early work in 80s and 90s, had a lot of focus on clotting factors, but that focus, I think, in the last few decades has really shifted to cells, and we'll look at some of that. Which cells? Is it all of them? And I guess the answer is maybe. There's kind of nice stories in a lot of different types of cells, and presumably in vivo, these conspire together to give the prothrombotic diathesis. And even other types of cells, and this is a place I think as a field we need to do better. We have not done as much immunology as other autoimmune diseases, and so going deeper into B and T cells and APS, also an interesting topic. So where can I read more? I recently worked with Shruti Chaturvedi, a very great hematologist at Johns Hopkins, on this up-to-date article, so check it out. It is a living document and will hopefully continue to evolve and improve. And then here is another review that I worked on recently. It bears some similarity to the up-to-date article because we were working on them around the same time, but I show it to show this cartoon, which is kind of too much to take in, but showing lots of different cells potentially playing a role. So in our limited time, I'm just going to hit on a classic paper from each of these 4 topics: complement, endothelium, monocytes, and neutrophils, a classic paper, and then also some more recent work to kind of give you, I hope it gives some context to where we were and where we are now. So complement, as you know, if you're like me, maybe this is about what you know, that it's been around for a long time. There are complicated pathways with lots of checks and balances, but the end game, and relevant because we're increasingly having drugs in the clinic that target this end game, is the generation of C5a, which does things like activate neutrophils, and then also membrane attack complex, which is very key to our defense against certain microorganisms. So here is our classic paper with a lot of famous people on the author line, including Pirangeli and Salmon. And so they use this model of femoral vein pinch injury, which my understanding, Dr. Pirangeli was instrumental in kind of adapting this from the cardiovascular literature to our APS world. So here's showing that mice that received IgG APS, which was from patients with high titer anti-beta 2 antibodies, have accelerated thrombosis, but that is reduced in C3 knockout mice. The same for C5 knockout mice, and the same when using drugs that target anti-C5. So, kind of paradigm shifting work here, very exciting. So here's the more recent paper by Dr. Chaturvedi and colleagues. And so the main focus of the paper was on this modified ham test. And so here cells are used that are kind of extra sensitive to complement activation and death. And then those are mixed with patient serum, and you ask how much impact that has had on the cells. And it was adapted from ham test, where we're now using, in this case, cells from the patient, which for genetic reasons, or sometimes I guess acquired reasons, they lose GPI anchored proteins, and that is a lot of the defense against complement. So in those patients, cells are sensitive to complement for a different reason. And so here are what the data look like. If you score this test as positive or negative, you can see it's more likely to be positive if you have a history of CAPS. So I think that fits with a lot of what we know about pathophysiology of CAPS. And also if you have a stronger APL profile, such as being triple positive. So those data kind of all make sense. And then the other kind of smaller part of the paper, but really interesting, is looking at rare variants in complement genes. This is something that's routinely done in the world of I guess what we used to call atypical HUS may now have more modern names, but showing that 60%, I mean, it's a small number of patients, but still, a strong percentage, had rare variants in complement genes, and that was much less likely to be present in patients who had not had CAPS. Okay, endothelial cells. Here is classic paper by Silverstein, published in JCI back in 1995, back when I guess you could purchase reprints for just $2, pretty cool. So here, the model is fairly simple. Condition endothelial cell monolayers with APS IgG. Does that make the cell stickier for leukocytes? And so here they're showing that it does, and they can reduce that with blocking things like E-selectin and ICAM1, suggesting those were upregulated on the APL-stimulated endothelial cells. And here just some immunostaining from the paper showing indeed these adhesion factors are upregulated. So kind of simple paper, but again, this was the paradigm shifting era when we start to think about cells versus the blood. Here, the more recent paper that we'll discuss, one of the fewish times that APS has broken through to New England Journal of Medicine. And so here the authors were tackling less kind of acute thrombosis, but more what I call APS vasculopathy. Maybe others have some different branding for it, but it's the idea that over time, it seems that APS wears on the vessels. You see this proliferative, occlusive phenotype that is kind of reminiscent of what you might see after the vessel's been manipulated, for example, with stenting. And so this is especially known to be a problem in the kidneys. Maybe not coincidentally a place that we often get biopsy data. So is it more prevalent in other organs that we don't biopsy as much? Possibly. Even though these data were presented at the end of the paper, I will always believe that this must be the data they kind of started the story with, at least in the lab, knowing that patients on sirolimus, also known as rapamycin, seem to have much better outcomes after kidney transplant. And so indeed, they built some in vitro systems, and they could show that rapamycin inhibits the mTOR pathway. mTOR is a pathway that drives proliferation, and so it makes some sense that you could find it in this setting. So some in vitro data, and then some in vivo data from kidney biopsies, where the data look a little more compelling if you put arrows versus not. But when they quantify, quite a strong effect. Okay, let's go to monocytes. So here's our classic paper from ANR that was focused on lipid grafts. So they treated monocytes with anti-beta-2 antibodies, and then asked what was happening from a signaling perspective. And so they found kind of at baseline that there was annexin-2 in the lipid rafts, and also beta-2, although at a bigger size than we might expect. They speculated this represented dimerization. But then here are the cool and really compelling data. So now Western blotting for TLR4, and in the presence of anti-beta-2 antibodies, similar to in the presence of LPS, you see the TLR4 recruited into those lipid rafts, like really pretty data there. And then they looked to some extent downstream of TLR4 and find things you would expect, upregulation of phosphorylated IRAC, and that can be disrupted by disrupting lipid rafts. And then some functional readouts in the paper. I'm just showing you the signaling here, but they looked at things like tissue factor expression and TNF release, and it kind of behaved as you would expect. But anti-beta-2, not the whole story. So this is a splashy paper from the first part of 2021. I think we could do like a semester-long course on this paper. There is a lot of data here, and so I can only very superficially show you what they found. So here, looking at the idea of cofactor independent antibodies. So maybe a role for antibodies that are directly binding phospholipids after all, despite the history lesson I just gave you. And so specifically looking at this association between a phospholipid LBPA and the protein C receptor. Engaging this does things like activate tissue factor, if you're talking about monocytes, also drives TLR7 signaling in dendritic cells, which can lead to things like interferon production. So I think an important point is to find these patients, you need to be using an assay that is looking for beta-2 independent antiphospholipid antibodies. This is, for the most part, not the anticardiolipin assays we send in the clinic, which are mostly adapted to be good at finding anti-beta-2 antibodies. And so the authors use their own custom assay that has minimal beta-2. So again, too much data to go through it all, but just to give you a flavor of how they approach some of this. So here they used a protein C receptor mutant that is unable to exchange phosphatidylcholine, which is kind of a structural natural part of protein C receptor when it's on the cell surface, for this more novel phospholipid called LBPA. And so that happens when cells get activated. Protein C receptor can cycle through endosomes, and that's where the LBPA gets added. And so striking data. So when they use these, mutants just completely lose cell activation. So a really cool story. Definitely read this paper if you have not. And then just a word about neutrophils, which is my personal favorite. So here, a classic back from 95 in Journal of Leukocyte Biology. So the model here was to use monoclonal anti-beta-2 antibodies derived from mice. And in doing so can show increased elastase release and also peroxide production. Now this was 95, this was the pre-NETs era. NETs first described in 2004 in this science paper. This paper is another one that is, I think, pretty well held the test of times in terms of their original description of what we know now. NETs are webs of, the backbone is chromatin that had been very densely packed in the nucleus, now spewed out into the world, taking up much more space than that original neutrophil itself. And we often say decorated with proteins derived especially from neutrophil granules, to some extent also from the neutrophil cytoplasm, but proteins that have antimicrobial functions. So early work in this field was by the microbiologists, but it wasn't long thereafter before people started looking at the other side of this double-edged sword. And so the thrombosis researchers were really out front, starting to tackle ways that when NETs happen intravascularly, that thrombosis can be triggered. And so our work has was one of the first to bring this to kind of the APS world. So this was an A&R paper published around the time of 2 ICAPA meetings ago. And so this is just an example of some of the types of data we had in the paper. So this is an assay for NET remnants in patient blood. So even between thrombotic events, you find in a subset of patients, high levels of NETs kind of smoldering away. We have consistently found that an APS neutrophil is more likely to spit out a NET when it adheres down to a plate than a healthy neutrophil would be. And then making our lives a little easier, we don't always need access to fresh patient blood to do experiments, but we can take serum out of the freezer. And if we put that on healthy neutrophils, they're more likely to shoot out a NET. I'm not showing the data, but we found anti-beta-2 antibodies are especially good at triggering this. So we've also done work in mouse models for us, partly because it was the expertise we had here at Michigan. We have focused on the inferior vena cava, and we can manipulate that in some different ways. One is to narrow it, which disrupts flow and will trigger a thrombus in about half of control mice, but in all the APS mice. And the other is with electrolytic activation. And so in these models, we have shown that things like depleting neutrophils, giving DNase to dissolve NETs, disrupting adhesion to endothelium, and also boosting intracellular cyclic AMP, which we have done through adenosine receptor agonists and defibrotide and ginger and some other things. These are all good ways to prevent thrombosis. So takeaways from this talk, we can think about these cofactor dependent APLs such as anti-beta-2 that must surely conspire with surface receptors. It may be that this clustered beta-2 on the surface is perceived as an inflammatory cell as a potential invader, and that's how we get activation of receptors like toll-like receptors. I gave you this great history showing how we moved away from cofactor independent antibodies, but I think rightfully that drum continues to be beated. And so I look forward to, us moving out of silos and anti-beta-2 intensive investigators collaborate with cofactor independent investigators to really understand how these may work together in the patient. And then a philosophical question, if we ever get to the point of understanding the complete autoantigenome, if we know every autoantibody that's there, is that going to finally unlock this heterogeneity that we clearly see in the clinic? Or maybe only part of it, other factors genetically and epigenetically in other tissues that are driving some of this heterogeneity. So I look forward to seeing what happens. Thanks for your time, and I look forward to the other talks today in this session. Thank you.
So following with the program, we are going now, I'm going to introduce Dr. Rohan Willis. He's a laboratory immunologist and head of research at the Antiphospholipid Standardization Laboratory at the University of Texas Medical Branch, and he's the technical director at Louisville APL Diagnostics in Texas. Rohan, we will have the pre-recorded presentation, and at the end, we are lucky today to have all the speakers live for the questions and answers. So if we can go with his presentation.
Hi, good morning, everybody. I'd like to thank the organizers for inviting me to present this topic today. And what I'm going to be looking at is the usefulness of criteria and non-criteria antiphospholipid tests, and through the prism of their molecular interactions with their target antigens. So we know antiphospholipid syndrome is a multisystemic autoimmune disease characterized by the presence of antiphospholipid antibodies. And these antibodies are thought to develop when you have environmental exposure in patients to typically infectious agents with components that have structural similarity to APS antigens like beta-2-GP1 on the background of genetic susceptibility producing a break in tolerance. And then you have the production of polyclonal antiphospholipid antibodies that have a varied binding to a myriad of antigenic phospholipid and protein targets, cardiolipin, PSP, IPG, and phospholipid binding proteins like beta-2-GP1 and prothrombin. And over the years, we've had lots of researchers elucidate several mechanisms for how these antibodies work to produce disease, activating different cell types, coagulation factors, interfering with anticoagulants, the fibrinolytic system, producing baseline inflammatory state that reduces the threshold for the development of thrombosis or obstetric manifestations. But I think what we know, or what is becoming more clear, is that all of these mechanisms aren't important in each APS patient. What's much more likely is that in each APS patient, you have APL-induced responses that are specific to the APL type that they have, more specifically to the epitope specificity of that antibody or those antibodies. And when we look at the antigens, the target antigens in APS, beta-2-GP1, which is thought to be one of the main APS antigens, it's composed of 5 complement control domains. Domain 1 to 4 are the typical CCP domains, with an atypical domain 5 that has this lysine-rich, positively charged loop that's important for binding to phospholipids. And domain 1 is important for binding pathogenic APL. And what's really interesting about beta-2-GP1 is that it exists in these two distinct structural and biochemical states. So you have a closed inert form and an elongated open form, as well as an oxidized form and a reduced form. And the open form, the elongated form, and the oxidized form are much more immunogenic than their counterparts. And so these immunogenic forms of beta-2-GP1 are very important for the interaction with antiphospholipid antibodies, pathogenic antiphospholipid antibodies binding to domain 1 and the domains, and the interaction with their target antigens. And when they bind to these cells, these specific forms of beta-2-GP1, the immunogenic forms actually promote clustering and dimerization of the beta-2-GP1 on the cell surface, initiating cell signaling and pro-inflammatory markers being produced. Similar to beta-2-GP1, you have prothrombin, which is also a phospholipid binding protein, and it exists in 2 forms as well, closed and open, which are the distinction is important pathophysiologically, which was highlighted by this recent study by the group of Potsy at the University of St. Louis and Pengo, Dr. Penko, where they tried to determine the antigenic binding properties of APSPT antibodies in a group of triple positive APS patients. And they found, looking at the epitope binding, they found two types of antibodies. Type 1 binding to discontinuous hidden epitope in fragment 1, which is the more proximal part of the N-terminal GLA domain, and type 2 antibodies, which bound to the C-terminal portion of the GLA domain, which is available in both the open and closed forms of the prothrombin molecule. And so when you look at it, these two types of binding antibodies were found in two groups of patients defined by their ability to be, their antibodies being inhibited by different forms of prothrombin. So they did these competitive inhibition studies looking at whether the closed form or the open form of the prothrombin would inhibit the binding of the APSPT antibodies. And group A, which had a preponderance of type 1 antibodies, binding that open, the fragment, that the hidden epitope in the open conformation, was only inhibited by the open form of prothrombin. And group B had both type 1 and type 2 antibodies, and they were inhibited by the open and closed form, because type 2 antibodies were available for binding in both open and closed forms. So this study really highlights the heterogeneity, the heterogeneity of APSPT antibodies as well. And I mean, looking forward, I'd be really interested to see how these binding differences, these antigenic differences, really relate to the clinical manifestations of our clinical outcomes in the APS patients. When we think about antiphospholipid antibody tests like anticardiolipin, I think the general wisdom, or for a long time, a lot of researchers have thought that anticardiolipin antibodies, the more pathologically relevant antibodies, were the ones that were dependent on beta-2-GP1 for binding to the cardiolipin. And Dr. Lackner's group has, over the past decade or so, been investigating cofactor independent APL that bind in the absence of beta-2-GP1. And they've really highlighted this unique novel activation pathway in monocytes, where the APL activates the inflammasome pathway through NOX2 activation and TLR7/8 TLR2 activation. But what's really interesting about this pathway is that the APL are actually internalized in monocytes, and they are activated in the endosomal compartment, which is really novel. I mean, other mechanistic studies haven't shown any APL internalization at all. And most interestingly, they had this recent study looking at COVID-19 patients, and they found that the more severe COVID-19 patients developed lipid-binding APL that targeted lysobis-phosphatidic acid complex to protein C receptors on the cell surface of endothelial cells and monocytes. And they've shown over the years that their cofactor-independent APL are actually pathogenic in thrombogenic models. And these lipid-binding APL in the COVID-19 patients were thrombogenic as well. So you hear they were able to induce large thrombi in their flow restriction model. And they demonstrated the requirement of the complex, the EPCR in the complex, using EPCR inhibitors that were binding agents that were non-inhibitory and inhibitory. And I mean, this is really interesting. I think we really need to think about looking at the cofactor independent APL as a significant group of APL antibodies in our assessments. In looking at lupus anticoagulants, in contrast to the assays that I just talked about, it's really a functional assay. It demonstrates a functional property of the APL rather than antigenic binding, even though it has antigenic binding at its base. And it demonstrates a phospholipid-dependent inhibition of coagulation in vitro. And we know that it's the single most reliable indicator of adverse outcomes in APS patients, thrombosis, obstetric morbidity. And we've known for a long time that the two main antigenic targets of lupus anticoagulant antibodies that we've studied are the prothrombin antibodies, the APSBT, more significantly, and the BIT2GP1. But there have been recent, really interesting studies looking at the prothrombin antibodies in particular, because you see those in the APSBT antibodies in LA positive people who are triple positive with cardiolipin BIT2 and isolated LA. And it seems that the antigenic binding in the isolated LA is more, it's more related to the IgM APSBT. And there were, in the isolated lupus anticoagulant category, you can actually further subdivide them, in that the group 1 patients who had both the two underlying tests being positive, DRVVT and silica clotting time, they had a lower number of negative APSBT antibodies, while group 2, where only the one or the other of the underlying tests for the lupus anticoagulant were positive, you had a higher number of negatives, indicating that these the antigenic binding in the lupus anticoagulant group is very varied and requires a lot of study to characterize these patients fully. So when we look at APL tests in our clinical assessments, we use these individual tests to provide a snapshot of what is happening in the patient, and it provides qualitative and quantitative information. So qualitatively, we know that the anti-cardiolipin assay, for example, is measuring the cofactor-dependent ACL as most commonly, because it has a source of beta-2-GP1 in it as well, and it's not just binding to cardiolipin. Anti-beta-2-GP1 assays use human beta-2-GP1 as the antigen, and the treated surface allows for the open conformation of beta-2-GP1. So you have a binding of different domains, domain 1, 4, 5. But if we want more detailed information on the antigenic binding of beta-2, we have to do more specialized tests, domain 1, domain 4, 5. Similarly for PSPT, the antigens are the PSPT complex. And like I said, the lupus anticoagulant is a functional test with the antigenic determinants underpinning it. So in our clinical assessments, when we look at these individual tests, they give us specific information, but excuse me. But what we really, when we look at the patients in general, we try to establish a profile for the patient, a risk profile, which was really highlighted in the recent EULAR recommendations for the management of APS patients. And in their overarching principles, one of them was identifying this high-risk profile, characterized by the clinical risk factors, comorbid factors, previous thrombosis or obstetric manifestations. But this high-risk APL profile, this laboratory profile of persistent APL, LA positivity as a single factor, double or triple positivity, and high titer, especially when the high titer antibodies are persistent, really gives us an indication of the likely clinical outcomes in our patients. And when we're looking at the risk profile of the patient, one of the considerations we have to keep in mind is the purpose, right? The purpose of the clinical assessment, because, even though the classification criteria are a good guide for diagnosis, the purpose is different. The classification criteria, the burden is to make sure that we identify, classify correctly the APS patient. So it's much more specific. So you have a higher burden, higher titers, persistent. The LA testing has to be quite particular. And it's not really that high threshold doesn't really have to be met to diagnose patients as APS. You have to characterize the assessment individual by individual, looking at additional tests, comorbid diseases, the type of presentations. And in patients with lower titers, for example, if they had persistence and they had a lack of other, a lack of any other factor explaining the disease, then you'd be more likely to diagnose the patient as APS. So when we think about assessing our patients, when we think about assessing our patients, we've been looking at their the qualitative. Sorry, I'm going to start that slide again. Sorry. Okay. So when we think about assessing our patients clinically, we look at their titers, persistence, et cetera. But I think moving forward, what we're going to be looking at more closely are the molecular endotypes. So the cell signaling linked to the phenotype of patients, because there's a lot of evidence that, this is so we know that anti-domain antibodies to GP1 antibodies are much more likely to be linked to thrombosis and the high-risk profile triple positivity than the anti-domain 4/5, which have a much lower risk. And actually there's some evidence that they're protective, actually. The mTORC pathway is implicated in endothelial hyperplasia, which is a feature of microvascular disease expression in like APS nephropathy, livido, and APC resistance is with anti-protein C antibodies is found in severe thrombotic phenotypes. And more recently, Dr. Lackner's group had this study where there was direct comparison between cofactor independent APL and antibodies to GP1 antibodies, and they were found to activate different pathways in the monocytes. And most importantly, the activation had targeted treatment. So hydroxychloroquine was able to inhibit cofactor independent APL, and rapamycin inhibited the antibodies to GP1, which is the point, because if we can characterize these molecular endotypes and link them to clinical phenotypes more closely, then this would enable targeted treatment of APS patients. And in identifying more clearly the clinical phenotypes of APS patients over the last couple of years, there have been several studies looking at clusters of APS patients, clustering patients by their demographic, clinical, and laboratory variables. And there were striking similarities in the studies. You had this venous thrombosis heavy, triple APL positive cluster 1, pregnancy morbidity cluster 4, asymptomatic APL, but most interesting, cluster 2 and cluster 3 here, where you had a female APS patients, and then you had arterial thrombosis with cardiovascular risk. These two clusters were characterized by the presence of a lot of non-criteria manifestations: valve disease, nephropathy, thrombocytopenia, hemolytic anemia. And in study 3, Scasia et al., that there was this interesting link between cluster 2 and cluster 3, where one cluster had this early autoimmune secondary disease profile with ANA positivity, but it was negative for the other more typical, the more specific SLE antibodies, while the cluster 2 had the much more mature SLE profile. So this link, this transitional thing between two clusters was extremely interesting and requires further study. to more clearly, characterize these patients. And the idea that serological clusters can relate to clinical outcomes is not new. We've seen it in SLE. And I just want to highlight here in SLE clusters, cluster 3, you had the more typical, which is very antiphospholipid, antibody heavy ACL-LA. You have the thrombotic manifestations of APS, but also the microvascular type, the diseases, the skin manifestations, livido, photosensitivity, malar discoid. And it would be really interesting to do this type of thing in APS patient cohorts to see how these molecular endotypes, these serological clusters relate to molecular endotypes, and if we can relate that to phenotypic expression. So the final thing I want to talk about before I finish is this study we did led by Dr. Antibo at the Mayo Clinic and myself and the Association of Medical Laboratory Immunologists. We looked at we compared the binding in several kits at 9 clinical labs, 9 different kits from 7 manufacturers, 6 ELISA kits, and 3 from an automated platforms, looking at 100 subjects, 30 of which had APS. And we did this exploratory principal component analysis and cluster analysis, looking at the binding, the differences in binding among the groups. So this is the biplot of the principal component analysis. So this is the biplot of the principal component analysis, and you can see here that these binding vectors here, the active variables in red, are the different kits, and the ELISA kits K1 to K6 all clustered together, or much closer together, while the automated platforms clustered together, A1, 2, and 3, even though A3 was kind of intermediate binding between the ELISA kits and the automated platforms. And when we did cluster analysis, what we found is that the APS patients clustered, this is for IgG ACL, clustered in particular groups. And when we looked at the binding in the different kits among these groups, we found distinct binding patterns, right? So you had a cluster that had binding in all of the kits, seen here, but you had partial binding in a lot of them. And most strikingly is the binding in the, you can see in cluster 5 here, A1 and A2, the automated platforms. You have a lot of patients that cluster that are identified by those kits only. You had a very high K4 cluster, and this other cluster here, partial binding in some of the kits. And what I just want to highlight with this is that, even in the tests that identify the same, are testing the same antigen, you have, variable binding. Presumably these, the binding clusters here are identifying different epitopes, but we don't know. We're going to do further epitope mapping to see. But I mean, this heterogeneity that exists in patients is, I think we need to try to define how this heterogeneity is expressed among the assays, which leads to this, high inter-assay variation. So in conclusion, the take-home message, I want to. So in conclusion, the take-home message is, when we look at our patients, we develop this
so
risk
embarrassing
profile, and
oh my God.
we look at different things, titers, persistence, etc. But we have to keep in mind the purpose of is, I think we need to try to define how this heterogeneity is expressed among the assays, which leads to this, high inter-assay variation. So in conclusion, the take-home message I want to. So in conclusion, the take-home message is, when we look at our patients, we develop this risk profile and we look at different things, titers, persistence, etc. But we have to keep in mind the purpose of the clinical assessment to drive the diagnosis or classification. The interaction between antigenic binding and functional assessment, I think we should keep in mind that, the two things are interrelated. So lupus anticoagulant, the antigenic determinants behind it, the APSBT, the antigenic determinants behind the binding of the different epitopes, and what the different binding can mean in terms of the molecular endotypes. Do these the different epitopes, but the specificities lead to different cell signaling, and does that translate to the different clinical phenotypes? And how can we use that in the future to, identify groups of patients that we can provide targeted treatment to? I think is the ultimate goal. We want to be able to treat patients in a more streamlined way. And so with that, thank you again to the organizers, and have a good day.
Thank you, Rohan, for this thorough presentation on criteria and non-criteria APL tests. So now we move to the area of evolving technologies, and our next speaker is Dr. Ann Thibault. Anne is a senior associate consultant at the Mayo Clinic in Rochester and serves as the co-director of the antibody immunology laboratory at the institution. She has more than 15 years experience in autoimmune diagnostics with research interest in inflammatory myopathies, SLE, and antiphospholipid syndrome. So can we go to Anne's presentation, please?
I'm the co-director of the Antibody Immunology Laboratory in Mayo Clinic, Rochester. The topic for my presentation today is going to be on evolving technologies and antibody tests for antiphospholipid syndrome. The revised Sapporo classification criteria for APS constitutes of a clinical and a laboratory parameters. For the laboratory testing, the antibodies recommended for evaluation include anti-cardiolipin and beta-2-glycoprotein IgM and IgG, as well as lupus anticoagulant. These antibodies must be demonstrated to be persistent, and the clinical features of either thrombosis and specific pregnancy-related morbidities must be present for the diagnosis of antiphospholipid syndrome. Although these criteria are meant to be used for classification purposes, these are largely used in routine diagnosis of patients. There are some major key features of the laboratory criteria that should be understood. Based on the guidance, the anti-cardiolipin antibodies must be of moderate to high titers with a suggested level of more than 40 GPL or MPL levels for anti-cardiolipin, and must be at greater than 99 percentile of the laboratory's testing population for both anti-cardiolipin and beta-2-glycoprotein for both IgG and IgM. Other antiphospholipid antibodies, traditionally referred to as non-criteria antibodies, such as the anti-cardiolipin and beta-glycoprotein IgA and others, were excluded from this guidance document. And for the purpose of categorization of patients, 4 different categories of antiphospholipid antibody positivity were defined. This is beyond the scope of my talk, and I will not be talking about that. But one of the things that most laboratories do face with when talking with clinicians regarding the tests utilized in the laboratory was the reference of standardized ELISA methods to detect these antibodies. Over the years, methods other than ELISAs have been developed for detecting anti-cardiolipin and beta-2-glycoprotein, as well as other antiphospholipid antibodies. The ELISAs can be manual or automated, while the other more automated and closed systems could be either single or multiplex based. And traditionally, while the ELISAs are manual and automated, the newer platforms, which are closed, do offer the possibilities of having extended or extensive analytical measuring ranges for these autoantibodies. Therefore, there has been several challenges in adoption of these antibodies in the lab, as well as in reporting of these antibodies to physicians who have been used to the ELISA methods. Additionally, these various analytical challenges can be associated with the type of antigens used and the calibrators which could be used for establishing the assays. For beta-2-glycoprotein, there are several sources of the protein that can be utilized, which could be derived from bovine, from humans, as well as recombinant. Recently, there have been synthetic epitopes which have been developed for the detection of beta-2-glycoprotein. In order to prepare for this presentation, I used the proficiency testing survey that is offered by the College of American Pathologists as a resource to look at how methods have varied over the years. Based on a 10-year trend of testing, you could identify from this figure that the ELISA was largely used by most laboratories for detection of anti-cardiolipin, IgG, IgM, and IgA antibodies. Over the years, with the introduction of the automated and closed platforms, most laboratories have changed or have adopted either the ELISA, the chemiluminescent-based assay, or the fluorescent immunoassay, as well as others for the detection of these antibodies. And this is also the same for the beta-2-glycoprotein. However, one of the features that can easily be discerned from these two figures is the fact that while most laboratories do test for anti-cardiolipin antibodies, very few labs do test comparatively for beta-2-glycoprotein antibodies. To determine the impact of these evolving trends in methods for antiphospholipid antibodies, we decided to conduct a survey through the College of American Pathologists proficiency testing, and there's an abstract and poster which is associated with this study. So we surveyed the participants for methods used by laboratories to detect cardiolipin antibodies and beta-2-glycoprotein, the establishment of reference ranges, whether these reference ranges were using the kit established reference intervals, or these were laboratory established. We also looked at the reporting of anti-cardiolipin and beta-2-glycoprotein antibody testing based on qualitative and or semi-quantitative reporting. The responses from the participants were categorized and frequencies were estimated. Based on the survey results, we had across board for IgG, IgM, cardiolipin, and beta-2-glycoprotein, IgG and IgM, close to 80% of the responders, of the participants responding. And of the responders, a significant majority of the labs used the laboratory, the kit's recommended reference ranges, while only a few participants establish reference ranges based on their testing population. In the United States, this could be attributed to the challenges that labs may face in establishing reference ranges and changing the regulatory requirements for the assay. For example, if a lab was to change the reference range for a kit from an FDA-cleared kit, that test would constitute a laboratory-developed test, and the lab would be required to establish the clinical performance characteristics of the test based on clinically defined patients as well as specific disease controls. In this survey, we also realized that there were two main categories of solid phase assays, as I have previously mentioned. These included the ELISAs, and some of the labs reported using manual, semi-automated, or fully automated platforms, while others reported using the non-ELISAs, which are fully automated and closed systems. By closed systems, I mean that these methods or this test cannot be used, other analytes cannot be used to test in those systems. And given the variety of ELISAs that are performed, there were some challenges that we identified. So, based on the characterization of the responses, majority of the labs do use ELISAs for testing with the bioplex and the fluorescent immunoassay and the CIA in second and third and fourth places. So the reference interval determination was quite variable for certain manufacturers, particularly those who have established their reference ranges. As mentioned, most respondents reported quantitative rather than qualitative responses, and manufacturers' reference intervals were comparable for within peer groups. For anti-cardiolipin, that was 92.2%, while for beta-2-glycoprotein, that was 94%. Most respondents also reported a simple negative to positive result based on the reference intervals. The use of qualitative responses such as equivocal, weak positive, low positive, varied by analyte and by IC type, and results for strong positive results were not available for this survey. So based on this report, one can infer that the reporting will be very variable based on where testing is performed. And this is nicely captured in this figure here, where the equivocal and weak responses were between 40 to between 38% for IgG and IgM for cardiolipin, and quite variable for beta-2-glycoprotein for those labs that have introduced that concept of weak and equivocal reporting. For labs that had less than 100% consensus for qualitative reporting, you can see that there is a lot of variation for the different antibodies. For example, the Quantalite ELISA had very variable responses based on cardiolipin, IgG or IgM, while for the bioplex, this was kind of very close. And again, you can see that for the TerraDiac, it was very, very low at 50% for labs that use that qualitative response. There was less variability for the beta-2-glycoprotein, which could be attributed to less participants offering the test, or for, based on the fact that this assay may be found more specific than for the cardiolipin assay. So to summarize, the ELISA was the most common method for detection of anti-cardiolipin antibodies based on the survey from the College of American Pathologists. Reporting was most variable for ELISA, given that there were several kits that were available for testing using this method. Most labs report quantitative results based on the IVD suggested kit reference interval, and then qualitative reporting was very variable especially in context of equivocal, weak positive, or borderline positive. There is so much need for consensus for reporting and interpreting antibodies such that patients can be categorized kind of, in a harmonized fashion across labs. In the next part of my talk, I would like to talk about the impact of these different testing methods on antiphospholipid antibody evaluation. For this, we have an abstract, which is with a poster that will be presented. And this survey was carried through the Association of Medical Laboratory Immunologists in the United States. And the main objective was to evaluate the performance characteristics of these antibodies for the evaluation of APS as well as thrombosis, and then to look at the correlation between these testing methods for specific antiphospholipid antibodies. For this, we used a cohort of 100 participants, and this constituted an APS group of 30, 18 of which had primary APS and 12 secondary APS, that is APS and SLE. The disease controls were very diverse and included patients with SLE, diverse autoimmune diseases not related to SLE or APS, thrombosis patients only, and patients with pregnancy-related morbidity, as well as a few ANA-positive patients. And then as controls also, we used 44 self-proclaimed healthy controls. These specimens were split and kits sent to 9 participating laboratories. And assays for using ELISA methods were 6 from the companies listed here: ASCO, Cogenics, Euroimmune, and the Louisville APL diagnostic, as well as 2 ELISAs, 2 of which both had different reference interval, one using the kit recommended reference interval and the other a modified reference interval. For the non-ELISA methods, we have the Bioplex, and then we have the chemiluminescent assay from Inova, as well as the ELIA or the fluorescent immunoassay from Thermo Fisher. The characteristics of the patients is described here. Most of the patients ranged between the age of 39 through 42, and mostly females, and the APS cohorts was largely had thrombosis, with a few of them having pregnancy-related morbidity. Based on the outcome of testing at the different participating sites, you can see that the performance of the ELISA and other methods greatly differed in the sensitivity for APS and thrombosis with comparable specificity. Again, you can see that the IgA results was also very variable for the ELISA methods compared to the other methods, and the specificity for thrombosis was also very dependent on the kind of platform used. Using IgM or IgA, IgG and IgM had comparable sensitivity for APS, and so there was some kind of loss in specificity of when the IgM assay was used. So there was just marginal contribution of the IgA anti-cardiolipin testing for antiphospholipid syndrome. When we looked at the beta-2 glycoprotein, we can see that there is so much variability within the ELISA method for diagnosing antiphospholipid syndrome or APS. Additionally, one would infer that most of the contribution of the antibodies for the diagnosis of APS was coming from the beta-2 glycoprotein IgG for both the ELISA and the other methods, with a marginal contribution of possibly the IgA for thrombosis in this cohort. So when we look at the comparison for the ELISA and the non-ELISA methods for the overall diagnosis of APS or thrombosis, one would infer that the use of IgM antibodies alone is sufficient for the diagnosis of APS with marginal contribution of the IgA isotypes as shown in this table here. Overall, when we look at the correlation between the different methods for analyte and isotype comparisons, we can infer that when we compare the ELISAs to the other methods, such as the chemiluminescent assays or the bioplex and the FADIA assay, there is a lot of variability in the correlation, and this can largely be attributed to the wide analytical measuring ranges of the newer methods to the ELISA methods. Also, it is also evident that there are some ELISAs within the ELISA methods that may have comparable performance to the other assays that are not ELISA, that is the non-ELISA methods. With respect to the cardiolipin antibody assay, there was a very wide variability between the different ELISAs for the IgM and IgA assays. Based on this finding, with the cohort that was used for the different methods, we identified diverse clustering of the different autoantibodies. Here I'm showing you the differential clustering based on the anti-cardiolipin IgG for the detection of using the different detection methods for antiphospholipid syndrome, the disease controls, and the normal healthy donors. Here you can see that you have a cluster 4, a cluster 1, and a cluster 5, which predominantly picks up the antiphospholipid antibody patients and disease controls, which largely have thrombosis here, while in cluster 2, you have a heterogeneity in the clustering of binding. And based on this preliminary data, we can identify that cluster 1 was largely related to antiphospholipid syndrome, while cluster 2 really can pick up patients who have antiphospholipid syndrome in the context of venous thrombotic event, as well as pregnancy-related morbidity. Based on the survey we had of 10-year trending, I thought it would be interesting to show this data regarding the trends in the non-criteria antibody testing. You could infer that over the 10-year period, there has not really been a change in the APS dynamics. However, the APS-PT, IgG, and IgM assays have largely been introduced in some clinical laboratories, with very few manufacturers responsible for the development or manufacturing of these kits. In conclusion, the antiphospholipid antibody assays demonstrate comparable performance for APS within the cohorts that we examined, with variable levels of agreement. The new methods have relatively higher specificities compared to the ELISAs. However, there were certain ELISAs within the ELISA group that really had some comparable performance to the newer methods. And when we publish this data, it is anticipated that some of these analyses would be more transparent. And then, based on the binding characteristics that we've identified in the different cohorts, we see that there may be certain, there's a possible link between certain clinical features associated with some of the kits that would require confirmation in a large, well-defined patient cohorts that can really shed some light on whether certain epitopes are present in certain population of patients with either APS or APS with thrombosis and or APS with pregnancy-related morbidity. Thank you for your time, and I would like to acknowledge my colleagues with the College of American Pathologists Diagnostic Immunology and Flow Cytometry Committee, as well as the laboratory directors who participated in the survey through the Association of Medical Laboratory Immunologists for the evaluation of methods and analytes for the diagnosis of antiphospholipid syndrome. Thank you very much for your time.
Thank you, Anne, very much. So the next speaker will be Dr. Ali Duarte, and we move to a very hot topic on patient stratification. Dr. Duarte is an assistant professor of medicine at the Mayo Clinic, and his research focuses on health services and epidemiologic research on SLE and antiphospholipid syndrome. Could we please have the presentation from...
Isolated lupus anticoagulant more associated with thrombosis, and those are triple positive. Is my triple positive patient at risk of having heart valve disease? I will try to answer those and other questions in this talk. We will review how antiphospholipid antibodies can be used to stratify patients with traditional manifestations like vascular and obstetric manifestations of antiphospholipid syndrome, and also some non-criteria manifestations. First, let's start with the use of antiphospholipid antibodies that are part of the current classification criteria for a stratification of patients with thrombosis and adverse pregnancy outcomes. The first point I want to mention is likely very well known by this crowd, and that is that being triple positive, meaning having positive anticardiolipin antibodies, lupus anticoagulant, and beta-2 glycoprotein that are persistently positive is associated with thrombosis, both in recurrence, but also both in recurrence in those who had already a thrombotic event, but also in those who have never had a thrombotic event. And this graph shows a classic study from Dr. Pengo from Italy. And in this study, he recruited 104 triple positive patients who had no antiphospholipid syndrome clinical symptoms. And I guess you're wondering why these patients were tested for antiphospholipid antibodies to begin with. Well, the majority of them were tested due to prolonged APTT. The second largest group were tested because they had an autoimmune disease like lupus, and a few more were tested due to a family history of thrombosis or because they had migraines. And the interesting thing is that in these patients who only have serologic markers, when they were followed up, it was found that they had a rate of first VTE of 5.3%. At 5 years, the patients, 30% of the patients had had a VTE, and 40% had had a VTE by 10 years. Again, this was observed in patients who had positive antibodies, but no previous thrombotic events. In other words, they were carriers of antiphospholipid antibodies. Now, what is the importance of having an isolated lupus anticoagulant? Well, this has been controversial, and there have been studies that have found that it's associated with thrombosis and pregnancy, adverse pregnancy outcomes, and others that by itself, and others that is only associated in the context of having a positive anticardiolipin antibody or a positive anti-beta-2 glycoprotein antibody. And although this has been controversial, there was a recent study from Austria that showed that in the population, having a positive lupus anticoagulant is associated with death. And while thrombosis is important, death is a more important outcome. And in this study, they found that those patients that, while they were following over time, that had a positive lupus anticoagulant, at 5 years had a 95% survival. This is compared to the normative data from Austria. And at 10 years, they had an 87% survival. Again, this is compared to the normative data from Austria. Now, I have to say this because I'm a rheumatologist, and in lupus specifically, having a positive lupus anticoagulant has been the main autoantibody that has been consistently associated with thrombosis. And also a reminder that although the association with thrombosis in primary APS has been controversial, in the EULAR APS guidelines, this having an isolated lupus anticoagulant was considered to be part of the high-risk profile. Now let's talk about IgM versus IgG antibodies. In general, IgG isotypes have been associated with thrombosis and obstetric morbidity more than IgM isotypes. And I'm presenting this study from Europe that I like because one, it was multicentric, and second, they tested for the 4 solid phase assays that are more frequently used throughout the world. And the data that I'm presenting here is from the assay that we use here at Mayo Clinic. In this cross-sectional study, they included more than 1,000 patients, and 250 of them had APS with thrombosis, and around 120 had obstetric APS. And they tested them for lupus anticoagulant and beta-2-glycoprotein or anticardiolipin, both IgG and IgM. And what they found is in the case of thrombosis that lupus anticoagulant is associated, that the IgG isotypes were associated with thrombosis, but not the IgM isotypes. However, when there was a combination of the autoantibodies, these seem to have a higher odds ratio than when they were found isolated by themselves, including IgM. For example, when IgM was combined with IgG, the odds ratio was higher than IgG by itself. On the other hand, in the same study, they found that IgM was associated with obstetric morbidity, and also similarly to the thrombosis observations, the more autoantibodies that the patients had, they were more likely to have a higher odds ratio. Now, I just want to bring to your attention the PROMISE study that was a landmark study from 10 years ago. This study was a prospective study, and they only found that lupus anticoagulant was the only antibody associated with adverse pregnancy outcomes. So to wrap up the first part of the talk, the triple positivity has been associated with both first and recurrent thrombotic events. The relevance of isolated lupus anticoagulant in thrombosis is controversial, except in SLE, when we know that lupus anticoagulant is the main marker for thrombosis. And also in the PROMISE study, it was shown that lupus anticoagulant was the main driver of adverse pregnancy outcomes. In general, IgG isotypes are more associated with thrombosis and maybe more associated with obstetric morbidity than IgM. So we have heard for several years that there's the new APS criteria coming up, and then other criteria and other disease manifestations will be included, like thrombocytopenia or valve disease. So now I'm going to talk about criteria antibodies for stratification of non-criteria manifestations. And the first that I will discuss is this is systematic review and meta-analysis looking at antiphospholipid antibody profiles and thrombocytopenia. This is a very well done systematic review that was published in 2019. And they didn't include patients with primary APS. They only focused on SLE patients. And the reason for this is that it clearly allowed them to identify patients that were exposed to antiphospholipid antibodies and those who were not. And this study synthesized 53 previously published manuscripts. And thrombocytopenia was found to be associated with lupus anticoagulant, mainly with lupus anticoagulant, but also with IgM anti-beta-2 glycoprotein 1. it was not associated with IgG anti-beta-2 glycoprotein 1. And what this study showed is that IgM isotypes seem to be more associated with thrombocytopenia than IgG isotypes. Now, the same group, but more recently, just a few months, published a similar systematic review, this time looking at hemolytic anemia in SLE. And in this study, they synthesized 38 previously published manuscripts. And similarly, they found that the antiphospholipid antibody that was more associated with hemolytic anemia was lupus anticoagulant. And the second one was anti-beta-2 glycoprotein 1 IgM. There were other associations as well, but again, the IgM isotypes seem to be more associated. So these two important systematic reviews show that at least in SLE, IgM isotypes are associated with increased risk of hematologic manifestations. Now, Dr. Sully has done several systematic reviews, and this one was looking at antiphospholipid antibodies and heart valve disease in SLE. In this study, they used the same methodology. They focused in patients with lupus, and they found that lupus anticoagulant was 6 times more likely to be present in patients who had heart valve disease than those who did not have lupus anticoagulant. Also, they found that IgG isotypes for anticardiolipin were associated with heart valve disease, but not IgM isotypes. This study is from 2012, and at that time there were not enough studies to give a conclusion about the association with anti-beta-2 glycoprotein antibodies. However, after the last ICAPA Congress, there was this publication from my institution. And in this study, they risk stratified patients with APS who had at least one echocardiogram. They included around 400 patients. And in these 400 patients, around 60 had a non-bacterial thrombotic endocarditis, so had a valve disease that is associated with antiphospholipid syndrome. And they found, similarly to Dr. Sully's observation, that lupus anticoagulant and IgG isotypes were associated with heart valve disease, but not IgM isotypes. And they also observed that patients who had more antiphospholipid antibodies were more likely to have valve disease. So those who were single positive had a prevalence of NBT of just 5%, while those who were double positive had a non-bacterial thrombotic endocarditis of 20%, and those who were triple positive had an NBT prevalence of 30%. So in summary of this section, lupus anticoagulant and IgM isotypes are more associated with hematologic manifestations than IgG isotypes, at least in SLE. Lupus anticoagulant and IgG isotypes are associated with cardiac valve disease. This is both in SLE and primary APS, but not IgM isotypes. And the number of antiphospholipid antibodies correlates with the presence of cardiac valve disease in APS. So let's talk now about non-criteria antibodies for non-criteria antibodies for stratification. So the first one that I will talk about is the IgA isotypes. And the IgA isotypes are in generally rarely found in isolation. They are usually found in the presence of IgG or IgM isotypes. And in general, most of the studies have not found association with IgG isotype in isolation with thrombosis or pregnancy loss. However, and this is in primary APS. However, in lupus, IgA isotypes, particularly IgA beta-2 glycoprotein, has been associated with thrombosis. And it seems to have an additive effect to having a positive lupus anticoagulant. And also, I want to remind you that IgA isotypes, although not included in the current APS classification criteria, they are part of the SLIC and the EULAR ACR lupus classification criteria. Now I'll talk briefly about anti-domain 1 beta-2 glycoprotein antibodies. So as you recall, the beta-2 glycoprotein 1 antibodies directed against domain 1 are thought to be pathogenic compared to those that are directed to the domain 4 and 5. And by that I mean that domain 1 antibodies are associated with thrombosis or with pregnancy outcomes, but not those directed against domain 4 and 5. And these, as will be expected, are frequently associated with patients who are triple positive. However, in studies that have either replaced the traditional anti-beta-2 glycoprotein antibodies for the anti-domain 1, or who have added the anti-domain 1 to the the classic antiphospholipid antibodies, have failed to show that these addition improve the risk stratification. So their role is currently unclear. However, they may be helpful and may have currently a role in trying to identify if those patients who are single positive, for example, patients who only have a positive anti-beta-2 glycoprotein, have a higher risk of thrombosis or not, since if you repeat this test after you did an anti-beta-2 glycoprotein and you identify that is the antibody that you're identifying is against domain 1, is more likely that this is associated with thrombosis. So the role is still pending to be defined. Lastly, I will talk about antiphosphatidylserine and prothrombin antibodies. And these antibodies have been studied for the last decade or so, or even longer. And they have been associated with arterial and venous thrombosis. And this association even resulted in their addition to the score designed by our colleagues from Europe. And I'm sure another talk will discuss the GAPS score. Also, another interesting observation is that the PSPT antibodies are strongly correlated with lupus anticoagulant. And Dr. Bengo, even in one of his reports, found that all the patients that he tested for lupus anticoagulant were also positive for PSPT antibodies. But in other studies, this has not been the case. And some patients that are positive for lupus anticoagulant were not positive for PSPT. And this strong correlation between them might be helpful in the setting of patients who are anticoagulated and the reliability of lupus anticoagulant is low. For example, if you have a patient that is anticoagulated and is lupus anticoagulant positive, but you're not certain of that positivity, if this patient is positive for PSPT, you have more certainty that the lupus anticoagulant that you're observing is truly real and not an artifact from the anticoagulation. However, if the PSPT is negative, you cannot rule out a positive lupus anticoagulant. So in conclusions, the antiphospholipid antibody profile helps to characterize risk. I decided to do a visual conclusion that you can take a picture of. It summarizes everything that I mentioned. And also, if you're watching virtually, you can just snip it and keep it in your files. So just to summarize, triple positive antiphospholipid antibodies is clearly associated with thrombosis and heart valve disease. The association with obstetric outcomes is, in the case of obstetric outcomes, is not clear if it carries an additional risk to having a lupus anticoagulant positive. And this is the same in the case of lupus. Now, we know that lupus anticoagulant is also associated with heart valve disease and with hematologic manifestations, at least in SLE. IgG isotypes are associated with thrombosis, and they are associated with heart valve disease and hematologic manifestations, at least in SLE. And IgM isotypes are more associated with hematologic manifestations. I thank you very much for your attention and enjoy your time in Argentina.
Thank you very much, Ali. And we move with the program, and we have the honor to have Professor Krill is with us, who will present his work on in vivo thrombosis model in beta-2 glycoprotein 1 knockout mouse. Professor Krill is a professor of immunology, allergy, and infectious diseases at the University of New South Wales and St. George Hospital in Sydney, Australia. His research has a focus on inflammation, post-translational modification of proteins in age-related macular degeneration, sepsis, and the antiphospholipid syndrome. And he is responsible of seminal work on elucidating the role of beta-2 glycoprotein 1 as the main antigenic target in the disease. We are very grateful to Professor Krillis for making all the journey from Australia to Cordoba.
Thank you very much. Now, for me to get here, I had to fly Sydney because they canceled my flight. So I got, is that working?
Yeah.
Sydney, Auckland, Santiago, Santiago, Buenos Aires, Cordoba. Tw 27 hours. And I got here last night at 11 p.m. So thank you for the invitation. I always wanted to come to Argentina, and they tell me this city is the heart of Argentina. So today I'm going to talk about our recent experiments, but I'll just briefly explain some of the background. You've heard that the antiphospholipid syndrome is associated with thrombosis. But the thing, and some other manifestations, but the very important thing I want to get across is that the thrombosis in the antiphospholipid syndrome occurs in both the arterial and the venous system. So very few conditions do that, where thrombosis occurs in both systems. And most prothrombotic conditions, some of the inherited thrombosis occurs in the venous system most usually. You've heard about the international classification criteria, and many years ago now we published the updated. So you need a clinical manifestation that is either thrombosis or recurrent pregnancy loss, plus one of the laboratory criteria. That is anticardiolipin, like the previous speakers have mentioned, lupus anticoagulant, and/or anti-beta-2 glycoprotein 1. And beta-2 glycoprotein 1 is one of the major autoantigens in this condition. And you've heard that now there are different specificities. So, different patients may have a combination of, these specificities. But today I'm going to concentrate on the beta-2 GP1 side. This is the molecule, 5 domains. And these are amino acid domains that are known as complement control protein domains, because the structure is very similar to other proteins that regulate complement. And the thing I want to concentrate is domain 5. And you'll notice domain 5 has this little extra loop which is hydrophobic and inserts into lipid plasma membranes. And it's highly positively charged. So when you damage a cell membrane, you get flip-flop and you get negative charge on the surface, and the beta-2 binds. And the previous speakers have shown different structures, the circular form, then it opens up and binds on the negative charge phospholipids. Important part of the molecule. There's been a lot of work done in this area, and the biological function of the protein is still not well defined. We know that there's plenty of it in plasma, up to 4 micromolar, and it is highly, through evolution, it's maintained, so in different animal species. So it's an important protein. It has in vitro, it has anticoagulant properties, and these are just 2 papers showing that beta-2-GP1 can inhibit, for example, the binding of platelets to von Willebrand factor, a very important protein that's involved in thrombosis in a flow system in vitro. Also, we've shown that it binds factor 11 and can inhibit its activation by either factor 11A or thrombin. That's in vitro. Now, in vivo, a number of studies, particularly from Flip de Groot's group, have shown that you get, in men mainly, there's an association with myocardial infarction and beta-2-GP1 levels. The first study is decreased beta-2-GP1 plasma levels are associated with MI in men, and high levels decrease MI risk, the opposite. There's a Chinese study which also shows that in certain genotypes that they have identified, there's an increased risk of venous thrombosis in patients that have decreased levels of beta-2-GP1. So we did, Frida Passam from my group, who also worked with the Furies in Boston, she brought back this technique where we induce a laser injury. And for this, we use the mouse. So you have to use male mice. You get the cremaster muscle and you distend it. You put it over a little plate system, and to introduce antibodies that bind either platelets, neutrophils, or fibrin, you put a cannula into the jugular vein of the mouse, you intubate the mouse, and you put it on a little respirator, and then you stretch the mouse on this system with a confocal microscope. In real time, you have lasers with excitation, and you can see the image analysis and thrombosis formation in real time. So so we use beta-2-GP1 deficient mice and their wild-type littermates. And as you can see here, the red is the deficient mice, the black is the wild-type mice. And RFU are relative fluorescent units, how bright the binding is. And as you can see, both for platelets and fibrin, you get more in the knockouts compared to the wild type. And this is just a frame from 0 second to 150 seconds, the knockouts and the wild types. And this is just published this year. That's for the arterial. Very similar for the venule, because in the system you can look at venules and arterioles. So the mice that are deficient have bigger thrombi. This is a nice study. There are a number of in vivo thrombosis models, and one has to be careful because each different in vivo thrombosis model initiates thrombosis differently. And this very nice study shows you that with the laser-induced damage to the endothelium, the first cells that come and bind to the endothelium are the neutrophils. And then the platelets come along and they stick on the activated neutrophils and endothelium. And here they've done electron microscopy through certain sections. And as you can see here, the E is endothelium, the N is neutrophils, and the P is platelets. And this is a 3D reconstruction where the red is the neutrophils and the green is the platelets. So we looked at, and as the previous speaker, I think it was Dr. Knight, was talking about importance of neutrophils and nets in thrombosis. And as you can see here, we looked at the number of rolling neutrophils over a 20-minute period in the knockouts in red and the wild types in black, and elastase activity using a fluorescinated system. And as you can see, there's more rolling neutrophils in the knockouts and more elastase activity in the knockouts, implying that the neutrophils are being affected in the beta-2-GP1 deficient mice. This is a study we published a few years ago where we looked at cardiac ischemia reperfusion injury, where you tie off, you put a little ligature around the left main coronary in the mouse, then you untie it, and you look at the injury after reperfusion. And here, here you can see that sham is, you do the operation, you open the chest, but you don't ligate the artery. And you can see very few neutrophils, whereas the positive control with buffer only had many neutrophils. And this is an antibody that, so all the little brown dots are neutrophils. When you infuse recombinant human domain 5 of beta-2-GP1, it affects neutrophil infiltration, shown here. So we did the same experiment in the mice that had laser-induced injury. And you can see here, this is pre-domain 5, after domain 5. Pre-domain 5, after domain 5. So infusing domain 5 inhibited thrombus formation and fibrin in the knockouts. And interestingly enough, the same thing happened in the wild type, implying that the domain 5 that I showed you earlier binds damaged cell membranes, inhibits thrombin formation and thrombus formation. Domain 1 and 4 do not inhibit in this system. And you'll notice pre-domain 4, post-domain 4, pre-domain 4, post-domain 4. That's in the knockouts, the same thing happening in the wild type. So, so basically, what I've shown you is that beta-2-GP1 knockout mice have higher thrombus, and more neutrophils. So what does that mean? It means that beta-2 has a anticoagulant effect in this mouse model. And there are a number of mechanisms, and perhaps more than one mechanism. We know that beta-2 is positively charged and can inhibit negatively charged macromolecules. We know in the cardiac ischemia reperfusion model, you get upregulation of chemoattractants for neutrophils. And we know that it inhibits factor 11 activation. So since we're running low on time, I will stop there. Thank you.
Thank you very much, Professor Krilis. So can we have the other speakers on the screen? We are grateful to Antibor, Rohan Willis, Ali Duarte, and Jason Knight, who join us today for the session. Unfortunately, we have run out of time for questions, but if you don't mind, and if there is any question, they can send it to us, and we will forward it to the speakers and establish the contact. So before we finish this session, and just very quickly, we had a prize-giving ceremony yesterday where seminal work in APS has been recognized. And this recognition included 3 of the most important moments on APS. The first one was the seminal work on the description of the syndrome, where Professor Graham Hughes received a Lifetime Achievement Award. The second was the development of anticardiolipin assay, and Professor Nigel Harris received a Lifetime Award. And the third one was the recognition of beta-2 glycoprotein 1 as the cofactor for anticardiolipin antibodies. And I want to take advantage to give this award to Professor Stephen Krilis, who unfortunately arrived late yesterday, so he couldn't be with us. And please, a round of applause for this prize. Yeah, of course.
Thank you. I'm truly humbled and with this award. And there's many contributors to this field. And in science, we all learn from other researchers. And I want to accept this on behalf of my research team, because you can't do good work without good people working for you. So this is for me and mainly for my research group. Thank you.
Thank you, everyone. And I think we move to the next session. Yeah, I think there is 10 minutes for coffee, and then we will reconvene for the ISTH session. Thank you very much for the speakers again for being connected at this time.
I'm very delighted to be with you here. I want to thank you organizers for inviting me. And also, I want the organizers to give us the opportunity to do a joint session with the International Society of Thrombosis and Hemostasis Standardization Subcommittee on lupus anticoagulant and antiphospholipid antibodies. And we are very glad that we got the opportunity to present some topics where our subcommittee is involved in. My co-chair is Maria Laura Bertolaccini, well known, I think. She is also co-chair of our subcommittee. It was meant to be that Hannah was also chairing the session, Hannah Cohen, who is the new chair of the subcommittee, but unfortunately we think she has difficulties with the connection. So far we will do it, both of us. So thank you, and I hope you enjoy the session.
So we move to the first presentation, that is Professor De Vries, and she's a professor of hematology and coagulation and head of department of Laboratory of Medicine in Ghent University Hospital. She's going to talk about quantitative and qualitative classification of anti-cardiolipin and anti-beta-2 glycoprotein 1 antibodies.
Thank you, Laura. Thank you for the introduction. So I will talk on the quantitative and qualitative classification of the antiphospholipid antibodies, anti-cardiolipin and anti-beta-2 GP1. So as you all know, and you probably heard it already a few times this morning, and also yesterday evening, we have 3 lab criteria, and anti-cardiolipin and anti-beta-2 GP1 are 2 out of the 3 laboratory criteria. Lupus anticoagulant is detected with a totally different method, so the phospholipid-dependent coagulation assays, and anti-cardiolipin and anti-beta-2 GP1 antibodies are detected with solid phase assays. These solid phase assays show some methodological concerns because there are differences between the kits, differences in calibration, but also differences in the assays themselves, and also in the local lab conditions where the assays are performed. So that means that we see a large variability in results. When you look at the agreement between different assays for anti-cardiolipin and anti-beta-2 GP1, you can see that the agreement between the assays is not always optimal. In a multi-center study, we analyzed a large cohort of APS and non-APS patients with 4 different solid phase assays, indicated here. So these, the pointer is not working very well. So we analyzed all samples with 4 different platforms, and I show you here the results for the 4 parameters. And you can see that the agreement is good to very good. That are the green indicated figures. So for some parameters and also for most of the solid phase assays, the agreement is good, but you can also see that agreement for some comparisons is really bad. And this is especially the case for anti-cardiolipin EGM for most of the comparisons, but also for some for anti-beta-2 GP1 EGG. So this is agreement. Positivity, negativity, but when we look at the correlation of the titers, this is much better. And when we focus on the systems that I will also use further on in my talk, you can see that the correlation between the titers is around 0.7 for all the combinations, also for the 4 parameters, except for anti-cardiolipin EGM. It is lower, the correlation there is lower, but when we compare, for instance, the Bioplex system with the Quantalite ELISA or the Accustar hemoluminescent assay, that's the same as the BioFlash with the ELISA, the correlation of titers is rather good. But when we look at the quantitative titers, so the titer itself, so the figures of the titers, and we look then at the comparison between the methods as it is done in this study, in this study also APS and non-APS patients were measured with different systems, so ELISA and also automated systems. You can see that, for instance, for anti-cardiolipin, but also for anti-beta-2 GP1 EGG antibodies, that titers are much lower with ELISA. These are the blue dots is ELISA. When you compare it with the automated systems, for instance, the systems that use hemiluminescence, for instance, BioFlash, Actos, these are the green ones for the anticardiolipins and the red ones for the anti-beta-2 GP1, you can see that the titers are much higher with these systems compared to ELISA. The differences in the assays is also very well illustrated in external quality control exercises. And I show you here one example of a strongly positive sample for anticardiolipin EGG from the ECAT exercises. And in the ECAT exercises, you have to respond your titer and also a classification. And you have to classify the samples from negative, borderline, low positive, medium positive, and high positive. And when you look at this example of this strong positive sample, that was measured with 7 different methods, here indicated here. And this is the percentage of labs classifying the samples from negative to strongly positive. And when you look at the first method here, the dark blue one, you can see that the positive sample is classified from borderline, so number 2, borderline positive, to high positive. And this is true for several methods. When you take, for instance, the lighter blue one, they are all samples were all labs classified it as positive, but also some called that medium positive and all other labs called that high positive. So for the agreement between, for anticardiolipin and anti-beta-2 GP1 and the qualitative classification, the ISTH guidelines advise not to report a qualitative classification and just report anticardiolipin and anti-beta-2 GP1 with the titer and the local cutoff, and every value above the cutoff calculated by the 99th percentile should be regarded as positive. But at the other side, we see, based on the EQC results, that classification into borderline, low, medium, high positive strongly depends on the method, but also for the same method on the user. And this is because there are no guidelines how to classify the samples qualitatively. We also know that 40 is indicated in the Sydney criteria as a level for medium to high positivity, at least for anticardiolipin antibodies. At the others, and we know that because of the variation in titers, that 40 cannot be used for all the methods, because we see that there is a large discrepancy in titers. But a qualitative reporting into low, medium, and high could be very useful for the clinician and also for clinical studies, of course. And the classification is done in daily practice, as illustrated here in this review. In practice, many clinicians and labs take 40 as the level for to discriminate between low and medium high, so independent, in fact, of the methodology. So we need further studies how to determine the low, medium, and high positivity. And we performed such a study that was recently published to search for a protocol for a semi-quantitative classification to discriminate between the different levels. And this was based on a clinical approach with data from our multi-center study. And the model for calculating the low, medium, high positivity was applied for different solid phase methods to evaluate whether this model can be implemented for more than one APL platform. And we also checked the levels that we found in a second patient cohort. And afterwards, we evaluated the agreement between the solid phase assays applying a qualitative classification. So we took the cohort of our multi-center study, so over 1,000 samples, including APS and non-APS patients with thrombosis and also with pregnancy complications. And we did this exercises calculation of the qualitative reporting separately for the thrombotic and for the obstetric population. And we used 3 different assays, an ELISA, so the Quantalight ELISA. We looked at the Actos hemiluminescent technique, so that's the same as the BioFlash, and also the Bioplex method. This is a multiplex flow cytometric immunoassay. And we took only the samples that were positive for both systems that we were comparing to eliminate the lack of agreement between the systems. So we first looked whether we could apply the 20, 40, 80 levels as suggested in the Sydney criteria and what is used for ELISA. And a second method to define the different levels. Therefore, we used a ROC curve analysis, and I show you here the results for the thrombotic population. And we calculated a cutoff based on the sensitivity of the assays, because in a former study we found that the sensitivities of the 3 assays that we compared was rather comparable. And here you see the ROC curves for the 3 systems. So what we did was looking at the 20, 40, 80 levels that we use for ELISA, taking the sensitivity in our population, of course, and then look at the corresponding cutoff for another method with the same sensitivity. And with this ROC curve-based analysis, we obtained the results that 20, 40, 80 for ELISA corresponded for the hemiluminescent assay. That's an example for anticardiolipin EGG with 45, 202, and 492. When we look then at all the different results of this first cohort of patients, so measured with ELISA and with the hemiluminescent technique, you can see that there is a spread of results. But when you look, for instance, at the samples, and this is indicated in the yellow box, so the samples that were higher of 80 with the hemiluminescent technique, the orange box are the samples that were higher than 80 with the ELISA. And you can see that there is not a very good concordance there, and that there were a lot of samples that were higher than 80 with the hemiluminescent technique that were lower than 80 with ELISA. And when you look then at the overlap, and this is the green box, so the samples higher than 80 with ELISA and higher than the new cutoff of 492 with the hemiluminescent technique, that there is a good correspondence when you adapt your cutoff for your automated system. And we did that for the 4 parameters and for the CLIA method, so the hemiluminescent technique, and also for the multiplex flow immunoassay. And you can see that for all the parameters that the cutoffs to discriminate between low, medium, high are much higher for the hemiluminescent technique and also for the flow cytometric technique. And especially for EGG, you see that the titers are much higher. For EGM, the titers are also higher, but not in the same trend as for the EGG. And what's also important is that the titers are different for anticardiolipin and for anti-beta-2 GP1, while for ELISA, we do not discriminate for anticardiolipin and anti-beta-2 GP1 to say 40 and 80 to discriminate between the levels. But for the automated systems, the levels are highly different for anticardiolipin and for anti-beta-2 GP1. And when we look then at the agreement between the classification based on the 20, 40, 80 levels or the adapted levels, you can see in the first column here. Oh, does it work? So the first column on the left indicated in red, this is for the anticardiolipin. The second one here for the anti-beta-2 GP1. When you apply the 20, 40, 80 levels also for the automated systems to classify low, medium, high, you can see that there is a very non-existing agreement. But when you take the adapted cutoffs for the automated systems, so the higher levels of 200 and 492, then you can see that the agreement of classification increases when you adapt your cutoff values for the automated systems. So this was for cohort 1, but we also wanted to check whether this is applicable in another cohort, whether these high cutoff levels to discriminate between low and medium also apply in another cohort. And indeed, we found also in the second cohort that there was a good concordance between 80 and a high level of 492. A third method to discriminate or to calculate cutoffs for low, medium, high is the use of standards. And we measured 3 different standards in a dilution series. And then we looked at the levels we obtained with the standards, and this is an example of the Sapporo standards that we diluted. And when you look then at the levels we obtained with the Sapporo standards, also here, when you superimpose that on the patient results, you can see that also with the Sapporo standards, you can well discriminate between high, moderate, and low based on these adapted cutoff values. We also did that for 2 other standards, the Harris standards and the EM6 monoclonal antibodies, and also this is a possibility, although the levels calculated based on the monoclonal antibodies corresponded best with the ROC-based curve analysis. So when you measure your standards, then you can calculate, when you measure a standard with ELISA and, for instance, with the hemiluminescent technique, you can calculate then based on the logistic regression curve what means 40 for ELISA, what means that for my hemiluminescent assay, and so on. And this is what we found in our study. I'm very careful by showing this, but this is what we found in our cohort measured with the samples in our lab. I will conclude that this should be verified, of course, in other cohorts and other labs. But you can see in general much higher levels for hemiluminescent techniques and also for the flow cytometric technique for both anticardiolipin and anti-beta-2 GP1. For instance, when you look at higher than 80 with ELISA, it's more than 400 for anticardiolipin EGG for the hemiluminescent technique, and even much higher for the flow cytometric technique that corresponds to over 2,000. Another way to look at agreement between classification is to look at likelihood ratios. And we calculated likelihood ratios in both cohorts. I show you only the example of the thrombotic cohort based on the 20, 40, 80 levels, and also based on the new calculated cutoff values based on ROC curve analysis. When you look at the low level, so 20 to 40, or the adapted values 20 to 202, you can see that the adapted or calculated cutoff does not influence the likelihood ratio in that range. So in the low range, the likelihood ratio does not change. But when you look at the moderate and high levels, you can see when you use the 40-80 for the hemiluminescent technique, so for the CLIA method, then you have a likelihood ratio of 5. But when you calculate it with your adapted cutoff value, the likelihood ratio becomes much higher. It becomes 15 for the moderate range, and the likelihood ratio goes from 11 to 16 in the high range. So it makes a difference depending on the cutoff values. We also looked back to the cutoffs that we are used to for ELISA, so the 40-80 cutoffs to discriminate between medium and high. And you can see indeed, when you look at the ELISA systems, that the likelihood goes from 6.2 for the medium range to 27 in the high range. So that in fact proves that the 40-80 levels for ELISA is okay, and that the higher the titer is, the higher the risk is. This is only true for EGG. When we look for EGM, for instance, with ELISA, it makes no difference. The likelihood ratio remains the same for the 40-80 range and the higher than 80 range. So the range of 40-80 in our cohort for ELISA only applies for EGG and not for EGM. So to conclude, so the low, moderate, high ranges for the antibody positivity can be calculated by a clinical approach, so the ROC curve analysis for the non-ELISA automated systems. The classification with the adapted ranges shows a higher agreement with the ELISA-based thresholds of 20, 40, and 80. And we confirmed that the ranges that we calculated, we confirmed that in a second patient cohort and also with the reference materials. The calculation of the likelihood ratios confirms that 80 is a good threshold for a high risk for anticardiolipin and anti-beta-2 GP1 EGG only. So you can there discriminate between the risks. And for the EGG in the thrombotic and the obstetric population, so the results were also equal for the obstetric population, increased significantly in the moderate and high range with the adapted cutoffs. So the ranges for classification into low, moderate, and high applied for ELISA cannot be transferred to other platforms and should be calculated per system. So we need further investigations in existing cohorts to confirm whether a threshold for one system, for instance, the ones that we tested, Accustar or multiplex, for instance, so the thresholds for one system calculated in one lab is interchangeable between labs. So we should confirm that with further studies. And with this, I want to thank you for your attention.
Thank you, Katrien. So we move on the program, and the next speaker is Professor Gary Moore. He's going to speak on type and hecarim time, the optimal test for lupus anticoagulant in anticoagulated patients. And please, if we can have Professor Moore presentation.
Well, I'd like to thank the organisers for inviting me to give this presentation. These are my disclosures. Lupus anticoagulant testing starts with low phospholipid concentration screening test to accentuate the inhibitory effects of any antibody that's present. But of course, there are many other potential causes of an elevated screening test. So we move on to a mixing test to distinguish between inhibitors and factor deficiencies. And if an inhibitor does seem to be present, we move on to a confirmatory test with high concentration phospholipid to swamp the antibody and shorten the clotting time. Now, because the antibodies are heterogeneous, no single screening test will detect all of the antibodies. We need at least 2 assays of different principles, and they would almost always be either the dilute Russell's viper venom time and a lupus anticoagulant responsive APTT. So the classic screen mixing test confirmatory test algorithm is very specific for lupus anticoagulants, but concerns particularly about the dilution effect, giving us false negative mixing tests and precluding completion of the algorithm has brought about other algorithms, because in situations, in straightforward cases where there are no other causes of elevated clotting times, we can very often omit the mixing test and just go on to the confirmatory test, and then you may or may not do the mixing test next. Or you can perform the screen and confirm both at the same time in so-called integrated testing. But where there may be other causes of clotting times, in complex cases, we often need the mixing test. Now, therapeutic anticoagulants, of course, are going to prolong clotting-based tests depending on the principle of the assay and the dose of anticoagulant, but essentially we have to treat them as complex tests or complex situations. The multiple acquired factor deficiency of VKA therapy is going to prolong screen and confirm assays, the DRVVT and dilute prothrombin time being more affected than APTT. But all the current guidelines indicate that the standard way of dealing with this is to do mixing tests to correct the factor deficiencies. And they all indicate that this is potentially problematic largely for the potential of false negatives, but occasionally false positives as well. There are some who contend that analysis on undiluted plasma is reliable even if the patient is on VK anticoagulation. And this is largely based on integrated testing, because the screening test is going to be further prolonged if there is a lupus anticoagulant there. And the confirmatory test clotting time will be shortened even though there is coexisting factor deficiencies. And when you calculate the screen over the confirm ratio, that will be elevated despite the presence of the VKA anticoagulant effect. It does tend to work quite well, but there can be problems with weaker antibodies. So one approach to this is to elevate your cutoff for VKA anticoagulated patients, as was done in this study. The standard cutoff was 1.3, the cutoff for VKA 1.7, and this did detect most of the lupus anticoagulants, but there was a little bit of a drop in sensitivity. And of course, there are other publications suggesting that no, absolutely not. We got far too many false positives and false negatives. You cannot trust the results on undiluted plasma. And a reminder here that the ISTH guidelines advise caution on mixing tests. So when can you trust the mixing tests? Well, these are some genuine patient results. I've deliberately chosen a patient whose INR is above 3, and you can see that both the screen and the confirm ratios are elevated, but they are discordant. So if we do screen and confirm mixing tests, we can see the screen is elevated because there's an inhibitor there, but the normal confirm test tells us two things. It tells us that the mixing has corrected the factor deficiencies, and the reagent itself has corrected the inhibitor that was prolonging the screen, i.e. a phospholipid-dependent lupus anticoagulant. So in these situations, a positive result is diagnostic, but a negative result does not exclude a lupus anticoagulant. Interference by unfractionated heparin is almost inevitable in lupus anticoagulant assays. So most of our commercial DRVVT and dilute prothrombin time reagents contain heparin neutralizers that will quench therapeutic levels of unfractionated heparin. But of course, APTT reagents tend not to contain the neutralizers because we'll often be using those reagents for other things like monitoring heparin. So what you can do is put the neutralizer in the calcium chloride and just use different calcium chloride solutions depending on what you're testing for. The low molecular weight heparin family are less likely to interfere than unfractionated heparin, but we do see interferences, so we can't just assume there's no interference whatsoever. Do beware that if you're using routine APTT reagents to screen and confirm one sensitive, one insensitive for lupus anticoagulants, they're also going to vary in their sensitivity to heparin. So we have the risk of false positives and negatives. And if the confirmatory reagent has platelet-derived phospholipid, the platelet factor 4 will neutralize heparin and can mimic phospholipid dependence. So how do you know whether the quenching capacity has been exceeded unless you perform an anti-10A assay? Well, again, here are some genuine results. And again, it's the normal confirmatory test that comes to our rescue. If the screening test is elevated, it could be a lupus anticoagulant, it could be the heparin, but the normal confirmatory test tells us two things. One, that the heparin has been quenched, and two, the reagent has corrected the lupus anticoagulant that's prolonging the screening test. I think we're all familiar with the effects of direct oral anticoagulants. The Bigatran prolonged screen, confirm and mixing tests in a dose-dependent manner, and there's the risk of false positives. And similarly for parenteral DTIs like argatroban. The direct 10A inhibitors, again, will prolong screen, confirm and mixing tests in a dose-dependent manner. APTT assays tend to be generally less sensitive, but DRVVTs, not all of them, but a lot of them are markedly affected, and particularly the screen is more sensitive to the direct 10A inhibitors than the confirmed. So there are a lot of false positives, particularly with rivaroxaban, to a fair extent with edoxaban, but a much lesser extent with apixaban. And this can occur even at trough levels of the drug. And false negatives actually have been reported with apixaban. And this is what we are often seeing now at peak rivaroxaban levels. The screen and the confirm are markedly elevated, but they are discordant. And of course, the mixing test is elevated because the drugs are inhibitors themselves anyway. So this is a clear false positive for a lupus anticoagulant. A couple of studies fairly recently have looked at some altered formulation DRVVT reagents. They are affected by DOACs and warfarin, but when they are present, both the screen and the confirm assays will be prolonged to a similar degree. So you don't get false positive interpretations or far fewer false positive interpretations. But unfortunately, these reagents do appear to have slightly lower sensitivity than the more established DRVVT reagents. Alternatively, for the DOACs, we can neutralize them. We can use the antidotes. Idarosizumab works very well in vitro as well as in vivo, but it is expensive and not available as a laboratory agent. But andexanet alpha does not fully correct the lupus anticoagulant assay clotting time, so we can't use that one to neutralize in vitro. But of course, what are now widely available and becoming more and more commonly used are the activated charcoal adsorbents that absorb the DOACs, and they're available either as tablets that you add to the plasma or infiltration cartridges, and they do tend to work very well. And there's been quite a lot of publications on these products, and we do need to be careful, because although they will bind all the DOACs, and in fact argatroban and bivalirudin, they are largely effective with DRVVT and APTT, but less so for dilute prothrombin time. But what has been reported is incomplete removal sometimes, where even if the DOAC level is within the apparent quenching capacity of the adsorbent, there is still some left over. So theoretically, we should be performing a DOAC concentration assay on every patient we're testing. Also, that has been reported in some studies is alterations in the clotting times in non-DOAC plasma. So there's the possibility for false positives and false negatives, although you can reduce the effects of the false negatives if you treat your normal pooled plasma that you're using for your ratio calculations. That may well reduce the numbers of false negatives. So the SSC lupus anticoagulant guidelines for anticoagulated patients note that the DOACs invariably affect the assays, and we shouldn't really be testing for lupus anticoagulants unless those DOACs are removed. But because the absorbents may influence clotting times in other plasmas, we should only be doing DOAC removal in DOAC samples. But that gives us some food for thought, because if the adsorbents themselves can affect clotting times in non-DOAC samples, there's the possibility that those effects are going to remain in some adsorbent treated DOAC samples. So this is why we need to look at the snake venom factor 2 activators as a potential alternative. Now, the snake venom factor 2 activators are classified based on their cofactor requirements, and we use that to our advantage. So we're interested today in the oscutarin C fraction from the venom of the coastal taipan, because it is a group C prothrombin activator requiring both phospholipid and calcium ions to activate prothrombin. So we can dilute the phospholipid to increase sensitivity to lupus anticoagulants to generate the taipan snake venom time lupus anticoagulant screening test. And instead of concentrating the phospholipid in the confirmatory test, we instead use a different venom with different cofactor requirements. This is the echoing fraction of the venom from the Indian saw scale viper. It is a group A prothrombin activator, and it is cofactor independent. So the absence of phospholipid in this assay means that it is impossible for lupus anticoagulants to prolong the clotting times. It's ostensibly the perfect confirmatory test. The snake venom factor 2 activators have some additional value, if you like, because they can also activate the undercarboxylated form of prothrombin that we see in vitamin K deficiency and VKA therapy. But also, because they directly activate factor 2, they have immediately improved specificity over DRVVT and APTT, and also because they directly activate factor 2, they inevitably bypass direct 10A inhibitors, and they have been shown to detect occasional lupus anticoagulants that seem to be unreactive in DRVVT and APTT. Now, the SSC guidelines acknowledge the existence of test procedures that they sort of oddly refer to as reportedly less affected by anticoagulants. And both of the SSC guidelines note that a multi-center evaluation of taipan and echoing is ongoing to validate the assays, and we await those results. But interestingly, the CLSI and the British guidelines don't exclude the use of taipan and echoing in certain situations. Now, that multi-center study has now been published. It was published last year under the auspices of the ISTH SSC subcommittee on lupus anticoagulants. So taipan and echoing are now validated for use in non-anticoagulated patients and those anticoagulated with vitamin K antagonists and direct 10A inhibitors. But there are still interferences, of course, with the heparins and the direct thrombin inhibitors. So let's have a look at some of the results from that study. First of all, we'll start with VKA anticoagulation. And here I just want to make the point that it is established fact that these these venoms are insensitive to the effects of VKA anticoagulants. So here we have 180 patients known to have APS and persistent lupus anticoagulants, anticoagulated with VKAs, and Typan-Ecurin found 87% of those, and of those that were triple positive, 96% were found by Typan and Ecurin, so high sensitivity there. Spiking experiments with other anticoagulants showed that Typan and Ecurin are unaffected by rivaroxaban and apixaban. We did see a slight apparent dose response with edoxaban, but having said that, all the Typans were normal. They were within assay imprecision, and there were no false positive interpretations, but perhaps unsurprisingly, Typan and Ecurin were unreliable in the presence of dabigatran. And in fact, we saw false positives at lower concentrations, but at higher concentrations, Ecurin was more affected, and we ended up with the possibility of false negatives. Unfractionated heparin affects Typan, but not Ecurin due to steric hindrance. So almost ubiquitous false positives with unfractionated heparin, and similar but less marked effect with the low molecular weight heparins. At the lower levels, the Typan screening tests were normal. We did see a dose response with the naproid, which was assumed to be via the dermatan sulfate plus heparin cofactor 2, but Ecurin and Typan were affected to the same degree, so no false positive interpretations. And unsurprisingly, fondaparinux unaffected, or did not affect Typan and Ecurin. Ex vivo samples from patients with antiphospholipid syndrome and persistent lupus anticoagulant prior to anticoagulation, Typan and Ecurin found 75% of those lupus anticoagulants, and of those that were known to be triple positive, again, a very high sensitivity of 96%. We also had a group of non-APS patients who were anticoagulated with anticoagulants with potential to interfere with Typan and Ecurin. And we saw that some of them did in fact have normal screening test ratios, whilst others had similarly elevated Typan and Ecurin ratios, so the interpretation wasn't affected. But as per the spiking experiments, most of the false positives were seen with dabigatran and unfractionated heparin, and there was in fact less interference by enoxaparin than was suggested by the spiking experiments. We didn't do spiking with argatroban, but on the ex vivo samples, as the concentration increased, the Ecurin time became more prolonged than the Typan, so the potential there for false negatives, although there did appear to be 2 genuine positives amongst those data. From over 900 lupus anticoagulant negative plasmas, only about 5% were what I'm referring to as apparent false positives. And I say apparent because there was an unavoidable selection bias by doing what everybody does and using the DRVVT and the APTT pairing as a pseudo gold standard. So it's quite possible that some of those false negatives may well have been genuine lupus anticoagulants, unreactive in DRVVT and APTT, and as I said, these have been reported before. So, are Typan and Ecurin the optimal tests for lupus anticoagulant in anticoagulated patients? Well, they have good sensitivity and specificity for lupus anticoagulants in patients anticoagulated with VKAs and direct 10A inhibitors. Now, bearing in mind that DOACs, particularly direct 10A inhibitors, are these days the first-line agents for acute VTE and first unprovoked thrombosis, they're going to complicate initial laboratory diagnosis. But Typan and Ecurin are insensitive to direct 10A inhibitors, and they are also more specific, and they don't have impaired sensitivity compared to those altered formulation DRVVTs that are available. And of course, VKAs are the preferred anticoagulant for thrombotic APS, and DOAC adsorbents do nothing to mitigate for the effects of VKAs. And DRVVT and APT mixing tests, as we've seen, have reduced sensitivity. So Typan and Ecurin should be the first line assays in patients on those forms of anticoagulation. Currently, there is limited availability of standardized Taipan and Equine reagents, but I can tell you there will be one company launching new Taipan and Equine reagents at the OSTH meeting in July later this year, and those reagents will be available globally. But Taipan and Equine are compromised by direct thrombin inhibitors and heparins, and of course Taipan on its own as an isolated screening test is going to be affected by heterogeneity. So a positive Taipan Equine is diagnostic, and there's no need to look any further with less reliable assays, but a negative result does not exclude a lupus anticoagulant. So this is what we need to be doing when we're testing anticoagulated patients. For VKAs, start off with Taipan Equine, and if that's positive, go no further. You've found what you're looking for. If that's negative and you have them available, you can move on to the altered formulation DRVVT. And if they're not available or negative, you can move on to mixing tests. And if they're negative, your only choice to be absolutely sure is to test off of anticoagulation. For direct 10A inhibitors, again, starting with Taipan and finishing there if it's positive. Otherwise, the altered formulation DRVVT if you have it. Otherwise, that's the point to move on to the DOAC absorbents. And if they're negative, maybe best to test off of anticoagulation. For direct thrombin inhibitors, you can start off with the altered formulation DRVVTs if available. Otherwise, go straight to the charcoal absorbents. And if they're negative, to be absolutely sure, test off anticoagulation. For the heparins, you can hope your neutralizers work in your standard reagents or the calcium chloride. If they still look positive because the confirm is high and there may be some heparin, do the same thing again with mixing tests to dilute out the heparin. Otherwise, you'll have to test off of anticoagulation. Okay, this is me with coastal Taipan in Australia behind 2 inches of glass, and I thank you for your attention.
So we move on for the next speaker. The next speaker is Professor Vittorio Pengo. Professor Pengo is Professor of Cardiovascular Medicine at the University of Padova in Italy. Please, Vittorio.
Very much. This is my presentation of additional testing in antiphospholipid syndrome, a role unknown criteria in antiphospholipid antibodies. These are my disclosures. Okay, when you check for the presence of antiphospholipid antibodies, you can have this kind of antiphospholipid profiles. You can have everything positive, lupus anticoagulant, anticardiolipin, and anti-beta-2 GP1, double positivity with negative LAC, lupus anticoagulant, or single positive test. This is what usually is found when you check for antiphospholipid antibodies. It is important that the anticardiolipin and anti-beta-2 are of the same isotype because they explore the same antigen, that is beta-2 GP1. It's important to confirm the profile after 12 weeks, as we know. But what happened is that triple positivity after 12 weeks is always confirmed. In many cases, most cases is confirmed also double positivity, but single positivity is confirmed only in less than 50% of cases. Another important consideration to be done here is that you have the rate of thrombosis here you have in this slide of normal subject that is less than around 0.5 per 100 patient here. Then you have the incidence of thrombosis in carriers of single positivity that is around 1.5 per 100 patient here, and the carrier of triple positivity that is very high, as it is high for the APS, thrombotic APS patients. What I want to say with this slide is that different profile means different possibility that this patient have thrombosis in the future or recurrent thrombotic event if they are APS patients. So if we have a full profile like here, triple positivity, positive all the 3 tests, but you have also positivity in anti-PSPT, that is the new test that I would like to introduce in the diagnosis of antiphospholipid syndrome. You have a tetra-positive patient with everything positive. The diagnostic value here is very high. Do we need to add anti-PSPT in triple positive patient? Well, we can add this test if we are not sure that lupus anticoagulant is positive, because in my view, anti-PSPT is the real antibody that promotes the lupus anticoagulant activity, and I'll show you why. We have studied several patients with tetra-positive patients, 14 in this paper. And what we did in this tetra-positive patient, we took the plasma of this patient and we passed the plasma through a beta-2 GP1 column. And so we eluted the anti-beta-2 GP1 antibodies and all the anti-PSPT antibodies were in the flow-through of the affinity column for beta-2 GP1. But if you take the eluate from the beta-2 GP1 affinity column, in other words, if you get from this column the anti-beta-2 GP1 antibodies, and you check for the DRVVT ratio, there is no or mild, very weak prolongation of the coagulation time. And this means that the anti-beta-2 GP1 in this system has a very low anticoagulant activity, while the flow-through of the column, where the anti-PSPT are present, have a very high activity, lupus anticoagulant activity. We further go on doing what? Taking the flow-through where the lupus anticoagulant is present, putting this flow-through into a prothrombin column and diluting the anti-PSPT antibody. So we got affinity purified anti-PSPT antibodies. And we checked these antibodies in a thrombin generation assay. And what we found is, as you can see here, we have 3 colors. We have a blue color that is a normal pooled plasma. We have the green color that is normal pooled plasma plus anti-beta-2 GP1 antibodies, affinity purified. And the red line is normal pooled plasma plus anti-PSPT immunopurified antibodies. And as you can see here, we confirm that the anticoagulant activity is important for anti-PSPT. And as you have a very long lag phase, it is comparable with the anticoagulant activity. And while the anti-beta-2 GP1, the green line, has a weak anticoagulant activity with respect to vehicle, to the buffer. Okay, so these anti-beta-2, anti-PSPT antibodies are real lupus anticoagulant antibodies in our view. So when you have a patient with antiphospholipid syndrome and venous thromboembolism, you treat this patient initially with full dose or low molecular weight heparin, and then you use VKA and not DOACs in triple positive patient, because we will see in another presentation that this is not the case. The intensity of treatment should be between 2 and 3 of INR, because we have 2 randomized clinical trials saying that. the duration anticoagulant treatment, generally long-term in triple positive patients. But when we have a patient at the time of the diagnosis of venous thromboembolism, the patient in the emergency room, or if it is in an ambulatory and the diagnosis of VTE is made, usually the patient receives soon anticoagulant treatment, even before the diagnosis sometime, in the suspicion of VTE. And testing, in this case, testing for lupus anticoagulant is difficult because if you check lupus anticoagulant in a patient treated with low molecular weight heparin or anticoagulants, you have probably false positive results. So the possible solution in this patient is to check for lupus anticoagulant when you have the patient on low molecular weight or anticoagulant drug, is to run a type 1 heparin tests. This is currently being studied, or use the dog stop, the carbon material, to absorb the anticoagulants. But my approach, till we are waiting for this new test for the patient on anticoagulants to detect the lupus anticoagulant activity. If I have a young patient presenting with venous thromboembolism, no unprovoked or provoked by mild risk factor, as the pill, for instance, or contraceptives, and treated with anticoagulants. And I would like to know soon if the patient has lupus anticoagulant activity, deciding if this patient is triple positive, so a very high risk patient. I check this patient first for anticardiolipin, anti-beta-2, GP1 antibodies, because these tests are not influenced by the presence of anticoagulants. If these tests are negative, then maybe I can treat also the patient with DOACs, is feasible. If this anti-beta-2 anticardiolipin is positive, the patient might be triple positive. So I would like to test this patient for anti-PSPT antibodies, and if positive, treat the patient with warfarin. But the test I would like to add to the armamentarium for the diagnosis of antiphospholipid syndrome, anti-domain 1, the part of the beta-2 GP1 that is important for the syndrome, and the anti-phosphatidylserine prothrombin antibodies. Now these two tests are excluded, eliminated for those used for the diagnosis of antiphospholipid syndrome. Anti-PSPT possess, as I have shown to you, lupus anticoagulant activity. So they are very useful to confirm or exclude the presence of lupus anticoagulant in your patient. And this is crucial because sometimes lupus anticoagulant may be false positive, but also may be false negative. And you know that may be false positive when the test is reported as weak or borderline. This often happens. If there is the presence of anticoagulant in testing plasma, as I've shown to you before, and if it is the presence of antibodies to specific anticoagulation factors, for instance, antifactor 8 or antifactor 5, if And we know that the isolated lupus anticoagulant is confirmed after 12 weeks in less than 50% of cases. Also, maybe false negative. Why? Because there is a reagent with the concentration of phospholipids high and is not sensitive to the lupus anticoagulant, or because there is the presence of lupus cofactor, a factor that is that prolong the coagulation times in testing for lupus anticoagulant only in the mixing test. So if you have a patient like a young woman with a transient ischemic attacks and moderate level of anticardiolipin, anti-beta-2 GP1 antibodies, but negative for lupus anticoagulant, I would really now like to know if my patient is anti-domain 1 positive, if this anti-beta-2 GP1 are anti-domain 1. And as you can see in the left figure, only part of these patients double positive are anti-domain 1 positive. And I would like also to confirm if my lupus anticoagulant is really negative. And this is the case in this study we did, because all the anti-PSPT in double positive patients were negative. So these are important tools to decide which kind of patient you have in front of you. And also, if you have isolated lupus anticoagulant, the same story, you have to check if this is a real or is a false positive lupus anticoagulant, because this is very important for the treatment of these patients. So in 25 patients with true isolated lupus anticoagulant, all of them were positive for anti-PSPT antibodies. So we have confirmed that that lupus anticoagulant was real. So to conclude my part with this talk, I would like to show you this slide that in which I have gathered my thinking on how to use these new tests in the diagnosis of antiphospholipid antibodies. Indeed, if you have a patient positive for all the 4 tests, the tetra-positive patients, maybe anti-PSPT, no, maybe you don't have to check for any other test because you have everything positive, the patient is there, and so forth. If you have a triple positive patient and you have some doubt on a lupus anticoagulant that may be borderline or false positive, you can use the anti-PSPT and confirm if your patient is a tetra-positive patient, if LA is weak or uncertain or borderline. In the case of double positive patients, as I have shown to you before, I would like to know if my patient, if the anti-beta-2 GP1 are anti-domain 1, because my strategies in treatment, this patient may change. For instance, I can change from antiplatelet to anticoagulants in a patient with transient ischemic attack. And I also want to know if the lupus anticoagulant is real negative doing anti-PSPT antibodies. As far as single positivity is concerned, also here I would like to check for anti-PSPT, just to know what is the lupus anticoagulant I am looking at. And I would like to follow up my patient also, checking for anti-beta-2 and especially for anti-domain 1. And if you have a single positive anticardiolipin, I only follow up this patient because a single anticardiolipin is not an anti-beta-2 and is an antibody directed to other protein. And we have studied this, and we know there are other protein for which anticardiolipin become positive. For instance, complement C4 and other proteins. So for single anticardiolipin, just follow your patient. For single positivity in anti-beta-2 GP1, I would like to know which kind of antibody is this, because we have the experience that in this case, probably, the antibodies are not directed to antidomain 1, but are directed to antidomain 4-5 of the protein. And this is associated not with thrombosis, but with other, with infection, for instance. So it is another story. So I would like in this case to have both antidomain 1 and antidomain 4-5. Let me thank the collaborators in my lab, Genti Andenas, Elisa Bison, Elena Pontara, Maria Grazia Cattini, Chung Yang Cheng, Sina Padayatil, Jose, Giacomo Zoppellaro, Alessandro Banzato. Without the help of these people, I will show you no results today. So thanks to them very much. Thank you for your attention. And I am open for questions.
Thank you, Vittorio, for your talk. And the question and answer are at the end of the session. So keep your questions for Vittorio until the end. Our next speaker is Professor Bas de Laat. He is the General Director of Synapse Research Institute in Maastricht, the Netherlands. And he will talk on the role of thrombin generation in antiphospholipid syndrome.
I would like to thank the organizers for giving me the opportunity to present some latest work on thrombin generation and the antiphospholipid syndrome. My name is Bas de Laat, and I'm working at the Synapse Research Institute in Maastricht, the Netherlands. Some background about thrombin generation. I think a lot already has been said about the antiphospholipid syndrome, but for the background about thrombin generation, I have over here a slide. Well, thrombin generation is an established tool to distinguish between normal conditions from hypo and hypercoagulable states. Thrombin generation is a very sensitive assay because you start coagulation with tiny amounts of tissue factor. The first thrombin generation assay was described in 1953 by McFarlane and Biggs, entitled a thrombin generation test, the application in hemophilia and thrombocytopenia. Later on, more and more people started working on thrombin generation. And I think it's fair to say that Professor Hemker from Maastricht really lifted the importance of thrombin generation in medicine. And every year the number of publications about thrombin generation increases. Like you can see at the bottom, there are now over 30,000 publications on PubMed about thrombin generation. So thrombin generation in hemostasis and thrombosis. Why thrombin? Well, thrombin converts the fibrinogen into a fibrin network, and that prevents you from bleeding when you have a wound. For example, with this kid that went to play soccer and he had a wound on his knee, and thrombin then is activated via the coagulation pathway, and the fibrinogen is converted into fibrin and the bleeding stops. But thrombin also plays a big role in the pathophysiology of coagulation and hemostasis. The more thrombin you have, or the more capacity of thrombin that can be formed, or the faster thrombin can be formed, then you have a higher risk for thrombosis, either venous or also arterial thrombosis, like you can see over here, a man that suffers from myocardial infarction. Then thrombin generation and the antiphospholipid syndrome, because this conference is about the antiphospholipid syndrome. Lately, the last 5 years, 6 years, our group has invested a lot in finding out what the mechanisms are of better detecting patients at risk for thrombosis when suffering from the antiphospholipid syndrome. Well, the antiphospholipid syndrome is characterized by thrombosis, and the thrombin generation assay is sensitive for a procoagulant state. You can see over here a picture of a typical thrombin generation curve. You have on the y-axis the thrombin that is formed, and on the x-axis the time. Slowly you see that thrombin is increased, and when it's increased, that's the lag time. Then you have the velocity index, how fast thrombin is formed. You have the peak height, and of course you have the ETP, so how much thrombin can be formed in this blood. Well, for thrombin generation and APS, a lot of things have been published in the past. Most have been concentrated on the APC resistance, so the resistance against the anticoagulant function of protein C, like you can see over here in the picture, already published in 2009 by the group of Professor De Vreese. Here you can see the baseline curve when there's no trigger formed. You can also see in pink the 5 picomolar tissue factor. It's a nice thrombin generation curve. And when you then add APC, then you can see that the thrombin generation peak and ETP is greatly reduced. If you then look at the yellow curve, you can see then thrombin generation is started with 5 picomolar of tissue factor, and an antiphospholipid antibody is added to it. You see a prolongation of the lag time, and so that's a sort of lupus anticoagulant, and also the peak is reduced. Whether the ETP is reduced, I don't think so. I think it's the same. But when you then add APC, you can see that the APC doesn't have any effect on this curve. So thrombin generation can also be used for detecting APC resistance. And as I already told you, thrombin generation detects a prothrombotic phenotype. We've published in the past when you add anti-domain 1 antibodies, you have a little prolongation of the lag time, but the peak increases, so there's a faster formation of thrombin. So, due to these publications, we think that thrombin generation can play a big role in diagnosis of the antiphospholipid syndrome, specifically detecting a prothrombotic phenotype. So in 2018, we started working on a thrombin generation guidance document within the SSC lupus subcommittee. Well, we found out that nowadays several commercial thrombin generation assays are available, but there's a lack of standardization that largely contributes to the poor correlation between assays and study results. And a major issue in these things is that there are differences in pre-analytical factors that may considerably affect the between laboratory reproducibility of results. For example, the blood drawing, or how many times you should spin down the blood with which type of G. So in 2018, we launched a survey to investigate which thrombin generation assays are used worldwide and how are they being used to clarify the lab-to-lab variability. Well, the survey consisted of 51 questions, and 214 questionnaires were collected, of which 45 were complete. Like I said, the questions were about the blood drawing method, a straight needle or not, the amount of citrate, what people used. Also the reagent sources, how much tissue factor, which source of tissue factor, phospholipids, which source of phospholipids, and the experimental protocols. This resulted in an ICTA's SSC guidance paper that is now published. And we now started with the second project where we are going to send around samples to different laboratories with a standardized protocol, and the people are allowed to use their own thrombin generation protocol to see whether there are differences in the labs between the protocols or something else. So that will start after the ICA's SSC meeting in London. So then the principle of thrombin generation. Over here you can see a typical thrombin generation curve, like I said before. First you have the lag time, and then thrombin really starts forming this velocity index. Then you have the peak, and then you have the decrease in thrombin and the area on the curve, the ETP. Well, our group designed an assay that is based on the conversion of the AMC substrate in an active AMC substrate by thrombin. So here you can see the coagulation cascade, very simple. Like you have a wound, then there's tissue factor, then 7 becomes 7A, and factor 10 together with factor 5 become 10A and 5A, and then prothrombin is converted into thrombin. And when thrombin is converted, then the thrombin generation starts. But when the thrombin generation is inhibited by antithrombin, mostly and alpha-2M, but also by fibrinogen, or fibrin protects thrombin from other inhibitors. So thrombin generation is the result of a complex balance of coagulation factors and their inhibitors. So we went on further searching how can we get more information out of a thrombin generation curve than only the lag time, the peak, and the ETP. Here you can see thrombin generation production and inactivation. Here you can see normal hemostasis, you have production on one side of the balance and inactivation of thrombin on the other side of the balance, and then you get a thrombin generation curve. When you are bleeding, your thrombin is less formed mostly. So then the thrombin generation curve is lower, and the inactivation has a more weight on the coagulation than the production, and your balance goes to the inactivation, and you have more bleeding. But what if the production is higher and inactivation is lower? Then you have a way higher thrombin generation curve, like you see over here, and then you have more chance of bleeding. So then we went on to see how we get more information out of this. So we wanted to quantify the production and the inactivation. And that's the principle of the thrombodynamics method that we've now published several times. So we went on to look how we can quantify the thrombin inactivation. So we quantify the inactivation separately by antithrombin and alpha-2M. Here we can calculate the thrombin decay constant. But also we looked at the prothrombin conversion, so how much thrombin is converted. So then we could calculate the maximum prothrombin conversion rate and the total prothrombin converted. Now here you can see that we published this method, the thrombin dynamics method, in many different articles. Like for example in COVID, but also in cardiopulmonary bypass. We showed by using the thrombin dynamics method that we were able to tailor the effect of antithrombin on hemophilia A. So when the method to treat patients by lowering the antithrombin in hemophilia A, there is a method to monitor the effects. But today I want to talk about another article that we published in Blood Advances, where we looked at the prothrombin conversion that's accelerated in the antiphospholipid syndrome and is insensitive to thrombomodulin. So why did we do the thrombodynamics in this group of patients? Well, over here you can see the thrombin generation, which is a balance between the prothrombin conversion and the thrombin inactivation. But when you do a normal thrombin generation curve, like you can see at the upper panel, then the APS and the control are really overlapping. And the lag time is a little bit different. The peak is a little bit higher of the APS patient, but there's not much difference. If you then look at the lower bottom, you can see the prothrombin conversion. Over there, you can see there's already a larger difference between the control and the APS patient. And we looked then at population. What could be the case? Well, we thought maybe also the thrombin inactivation is hampered in these patients suffering from the antiphospholipid syndrome. But we found that there's no difference in thrombin decay capacity. So then we went on and we looked at the PC max, and we saw there's a large difference between controls and the APS patients in the maximum prothrombin conversion. And we also found that the inhibition by TM is almost diminished by looking only at the prothrombin conversion in APS patients. So the thrombodynamics method showed a larger difference between the controls and the patients suffering from APS. But we still had a problem or a challenge that still the groups are overlapping. So still it's hard to use this in clinic because you cannot really distinguish between controls and APS patients for 100% or 90% or 80%. So that's why we went on further with thrombin generation in the antiphospholipid syndrome. We used artificial intelligence. Well, artificial intelligence is really a broad field. For example, with Tesla, they have self-driving cars, you have chess computers, you have Google and YouTube, but also medical imaging uses artificial intelligence. But artificial intelligence is not widely used now within coagulation. But we wanted to see whether it could help us and which artificial intelligence method can predict thrombosis in patients using the medical and laboratory data. So we looked at artificial neural network. What is an artificial neural network? Well, you have an input layer in blue, you have a hidden layer, that's the computer, and then you have an output layer. So if you put something in, the computer will also use all the neurons that you've programmed or that you've chosen, a number of neurons, and then it will say whether it's a control and APS patient. So what did we put in? We put in the thrombin generation data. We put in a history of cardiovascular diseases and coagulation effects. All those things can be put in a neural network. And then it can say whether you have thrombosis or not. And this is very general, not only for APS patients. We also have done this for general thrombosis patients. So what did we do for the antiphospholipid syndrome? Well, our input layer was thrombin generation, lag time, peak, ETP, time to peak, thrombodynamics, so the total prothrombin conversion, the maximum prothrombin conversion, and the decay. And also the effect of thrombomodulin on the TG peak and also on the prothrombin conversion. So this was our input layer. So here you can see this input layer, and our output layer was not thrombosis, that we later on, but only is it an APS patient or a control. Here you can see that our prediction model, we do this usually 10 times and take the average, was quite accurate. In the green you can see that in reality about 31 patients had APS, and the prediction was also almost always correct. And also for the control, we had almost 100% score. Here you can see the positive predicting value is 100%, and the negative predicting value, I think it was around 98%. So using this neural network, we can predict who has APS and who has not. But doing that with completely healthy people is maybe a little bit easy. So we also looked at other controls, like hospital controls. They have other diseases, not APS, but non-specified. And over there, we had an accuracy of about 80% that could distinguish between APS and a control. with a positive predictive value of a little bit low, 62, but a negative predictive value, and I think that's the most important value, is at 95%, and a sensitivity of 91 and specificity of 75. We also did it for autoimmune disease controls, like lupus-like disease or SLE. Over there, we had an accuracy of 87%, a positive predictive value of 83%, and a negative predictive value of 91%, and a sensitivity of 90%, and a specificity of 84%. So we thought that is quite nice, because sometimes there's an overlap between SLE and APS, of course, with secondary APS. So we were quite happy with these results. With the thrombosis controls, we had a little bit lower accuracy of 72%, with an 68 positive predictive value, an 86 negative predictive value, and a sensitivity of 91%, but the specificity was 53%. And I think that makes sense because our model was based on APS patients, so it also looked at the occurrence of thrombosis, because APS is diagnosed by either pregnancy morbidity or thrombosis, and I think that's why there is a big overlap between the thrombosis controls and the APS patients. So in summary, well, we are looking already for a few years on thrombin generation with APS. And I think thrombin generation has high potential within the antiphospholipid syndrome, but especially thrombodynamics analysis is helpful in APS. Last 3 years, really looking into artificial intelligence and thrombosis, not only in APS, but today I only showed with APS. And for that, we usually use neural networks, and the principle and the application in the field of thrombin generation and thrombosis, I think it can be of high value in the future. So I would like to acknowledge not only these people, because many people were involved in our studies, but of course the people of our own institutes, but also the Genk Hospital, the Graf de Jong, Professor de Vreese from Ghent, Dr. Feinier from Meander, Professor Zuli from Nancy, Professor Waal from Nancy, and Professor Ignatovic from the University of Melbourne. I would like to thank you for your attention, and hopefully next time we meet in person.
Thank you, Bas, for your presentation. And we can move on to our next speaker. Our next speaker is Professor Hannah Cohen. Hannah is a hematologist and professor of hematology at the University in London. She is also the chair of the SSC subcommittee on lupus anticoagulant antiphospholipid antibodies, and also the founder, member, and co-chair of the APS Action. Please, Hannah. Hannah will talk on APS-associated stroke, diagnosis, and antithrombotic treatment.
Hello, everyone. I'm Hannah Cohen, and I'd like to start by thanking the organizers of this Congress for including this joint ICAPA-ISTH session in the program. My topic today is APS-associated stroke, diagnosis, and antithrombotic treatment. Here are my disclosures. First, some facts about stroke and APS patients. Stroke is the second most common cause of death worldwide and the most important cause of adult complex disability. Systematic reviews suggest that 13.5% of patients with stroke or TIA have antiphospholipid antibodies, and in the under 50s, the prevalence of APL appears to be higher, at 17% and 12% in stroke patients and TIA patients, respectively. In the Europhospholipid prospective cohort study in 1,000 patients, 30% of the patients had stroke or TIA, and 10% developed stroke or TIA over 10 years of follow-up. APS patients can have cognitive dysfunction, and a recent systematic review found that this was common, and also associated with white matter hyperintensities, ischemic lesions, and cortical atrophy. The optimal strategy for the diagnosis of APS after acute stroke is undefined. The optimal antithrombotic treatment approach is also undefined, and this is due to a lack of appropriate and adequately powered RCTs, with the uncertainty reflected in variation in recommendations. We performed an ISTH REDCap stroke survey, with the main focus of the survey to capture and collate views on the diagnosis and antithrombotic treatment of APS-associated ischemic stroke, TIA, and other brain ischemic injury, with the purpose to identify the current status of diagnosis and antithrombotic treatment. We had 107 responses to the survey. The report is currently being written, and I will show some of the data in this talk. When we test for antiphospholipid antibodies in stroke patients, we need to ask who, which, how, and when. So first, who to test for antiphospholipid antibodies. The ISTH guidance recommends that we should test younger patients, that is under 50 years, with ischemic stroke, transient ischemic attack, or other evidence of brain ischemia. And it is particularly pertinent to test the patients if they also have a history of autoimmune disease, venous thromboembolism, or obstetric morbidity. So let's look at which antiphospholipid antibodies to test for. In this study on the diagnosis of APS in routine clinical practice, what was found is that if any of the 3 criteria antibodies were not tested for, then the diagnosis of APS would be missed in a proportion of patients. So for example, if LA testing wasn't done, then the diagnosis would be missed in 15% of patients. In accordance with current international consensus criteria, we should be testing for all 3 criteria APL, and also for IgG and IgM. So which antiphospholipid antibody tests were requested in the ISTH survey? The majority requested all 3 criteria APL tests, including IgG and IgM, ACL, and A-beta-2-GP1. A minority performed only IgG, ACL, and beta-2-GP1. So this calls into question the role of IgM in APS. A multi-center study addressed this and included over 1,000 patients. This study found that IgM had no diagnostic value for thrombotic APS, although it was useful for risk stratification. It should be noted that stroke patients comprised only 55 of the 259 patients with thrombosis. In a retrospective study, isolated IgM showed an association with stroke. And the story of IgM and stroke is not yet complete. A minority tested for IgA as well as IgG and IgM, anticardiolipin and anti-beta-2-GP1. And IgA may be important. For example, in a recent study, IgA anti-beta-2-GP1 was found to add to thrombotic risk in SLE. Now, how to test for antiphospholipid antibodies? And here we focused on lupus anticoagulant. 81% asked for a DRVVT to be done, and this is in non-anticoagulated patients, and 55% a sensitive APTT. So how does this concord with the ISTH guidance? The guidance recommends that we should be doing 2 tests based on different principles, with the DRVVT the first test to be considered, and the second test a sensitive APTT. With LA considered positive if one of the two test systems gives a positive result in the 3 steps: the screen, the mix, and the confirm. So when should we test for antiphospholipid antibodies? And you can see here that the majority wanted to test quite soon after the event. So 64% anytime after acute thrombosis, 37% during the acute hospital admission, and 29% as soon as possible after TIA. And only 1/4 overall would defer testing for at least 12 weeks after the event. We do need to interpret LA results in the acute post-stroke phase cautiously, because raised factor VIII levels can shorten the APTT, leading to a falsely negative lupus anticoagulant, and a C-reactive protein, when raised, may interfere with phospholipid in the reagent, leading to prolonged clotting times and thereby a potentially false positive lupus anticoagulant. There may be potential benefits of early APL testing. First, it will ensure that testing patients is not missed. And secondly, it might benefit patients through early institution of anticoagulation, although it must be said that the influence of early versus later initiation of anticoagulation on the outcome following acute stroke is unknown. Now, turning to antithrombotic treatment after a first APS-associated acute ischemic stroke, the recommended options in the EULAR guidelines are standard intensity VKA plus or minus low-dose aspirin, or high-intensity VKA, considering the patient's bleeding and thrombosis risk. And here, what we found was just under 50% would treat with standard intensity VKA alone, and just over a third would treat with standard intensity VKA plus low-dose aspirin. 15% would treat with high-intensity VKA, and 10% with single antiplatelet agent, and other options by smaller proportions of respondents. And so there's quite a variety here of treatment options that are being used for thrombotic APS, presenting as a first APS-associated acute ischemic stroke. Brain ischemic lesions can develop despite antithrombotic treatment. And here we see an example. So here's the baseline MRI, where there is a basal ganglia infarct. And at a follow-up MRI 3 years later, there's two. There's one on the other side and a small white matter hyperintensity. And by 10 years, the ischemic brain burden has increased further. We did a study looking at the progression of brain ischemic lesions, and this was a relatively small study and also retrospective, but nevertheless, we saw new ischemic lesions despite antithrombotic therapy in 44% of the patients. And we also saw that patients on high-intensity VKA were less likely to develop new ischemic lesions. In this systematic review and meta-analysis, patients with an initial arterial event were assessed for the risk of recurrent thromboembolism. And what was found was that the risk of recurrent thromboembolism at 2 years was not dissimilar in patients on anticoagulation versus patients on aspirin at around 20%. And so it was proposed that patients with APL and arterial thromboembolism may benefit from a different antithrombotic approach than those with APL and VTE, where the recurrence risk was lower at around 5%. But a possible confounding factor in this study is that DOAC trial results were included. So if we look at the DOAC RCTs in APS, with respect to arterial thrombosis, in the TRAPS trial, there were 7 arterial thrombotic events in 59 patients on rivaroxaban, and 4 of the 7 had previous arterial thrombosis. In the Audi-Ross trial, 9 strokes occurred in 95 patients on rivaroxaban, and it was found in post-hoc analysis that previous arterial thrombosis was associated with an increased risk for recurrent thrombosis. In the ASTRO-APS trial, 6 strokes occurred in 23 patients on apixaban, and of these, 5 had had previous strokes, 1 a myocardial infarction, and 1 another type of arterial event. A further review and meta-analysis focused on recurrent arterial thrombosis in APS. And recurrent arterial thrombosis was found to be reduced with VKA and a single antiplatelet agent, as you can see here, versus VKA alone. And recurrent arterial thrombosis was also reduced with dual antiplatelet therapy versus single antiplatelet therapy. And so it was proposed that combined antithrombotic therapy may be more effective than single agents for secondary prophylaxis in APS patients with arterial thrombosis, and also that dual antiplatelet treatment may be more effective than single. And I'd like to draw your attention here to the ISTH registry on augmented antithrombotic treatment regimens for patients with arterial thrombotic APS. And this has been developed by Professor Sam Schulman, with the details on the ISTH website in the LAAPL SSC section. And we would be very grateful and would urge you to look at this, read the protocol, and consider entering your patients into this registry. Now, what about DOACs and arterial thrombosis in regard to recommendations by the ISTH and the 16th ICAPA Treatment Trends Task Force? They both recommend against DOAC use in APS patients who have arterial thrombosis. They also recommend clinical trials on the use of DOACs for APS, and in this regard, we are doing such a trial, the RISAPS RCT, which is looking at high-intensity rivaroxaban, 15 milligrams twice daily, versus warfarin at a high intensity. And this is in APS patients who have ischemic stroke, TIA, or other brain ischemic injury. And so, to conclude, with regard to APS-associated stroke, there is variation in the diagnostic approach and also the antithrombotic treatment. The ISTH survey will identify the current status of diagnosis and management and should inform the development of a multidisciplinary consensus approach. I would like to acknowledge everyone who has been involved in the ISTH survey, including the respondents who are the study group. Thank you for your attention.
So we move on with the program, and I welcome back Professor Catherine De Vries, and she's going to update us on the guidance and recommendations from the ISTH Lupus Anticoagulant APL subcommittee.
So, ladies and gentlemen, for the last presentation of this session, I will give you an update on the guidance and recommendations from our subcommittee on lupus anticoagulant antiphospholipid antibodies. And most of the recommendations and guidelines have already been mentioned during the presentation, so they will look familiar to you, I suppose. So our subcommittee has its focus on the standardization of the existing assays for detection of antiphospholipid antibodies, and also in evaluating newly developed assays and advising on diagnostic criteria for APS. I will give you an overview of the recommendations and guidances that we made over the last 5 years. And you will notice that the recommendations and the guidances are collaborations of the chairs and the co-chairs of the subcommittee, but not only them, also we collaborate with other experts in the field. So the first guidance I want to propose is the guidance on laboratory criteria for antiphospholipid syndrome, and this guidance was published in 2018. So why did we make this guidance? The laboratory criteria for APS dated from 2006, so the so-called Sydney criteria. And since 2006, there was a huge amount of publications on the topic. So which test to use, what are the criteria, and there's also a lot of discussion and also contrasting information in all the publications. And there was also discussion on the role of the current criteria, but also on other antiphospholipid antibodies. And this was a great concern of the chair at that moment and also the past chairs of the subcommittee. And we wanted to give a summary on the consensus. And what we advise in this guidance is that indeed we have 3 lab criteria: lupus anticoagulant, antikaryolepin antibodies, and anti-beta-2 GP1 antibodies, IgG and IgM. That lupus anticoagulant should be tested with a 3-step methodology, so screening, mixing, and confirmation. The cutoff of antikaryolepin and anti-beta-2 GP1 should be higher than the 99th percentile. And we also did not restrict it to ELISA testing. What was done in the Sydney criteria, there it was advised to use standardized ELISA, but in this guidance of 2018, because meanwhile there were also other methodologies available, we included not only ELISA, but also automated system to test for these solid phase antibodies. It is also important that lupus anticoagulant, antikaryolepin antibodies, and anti-beta-2 GP1 antibodies, if they are positive, that there is a confirmation after 12 weeks. And also a comprehensive interpretation is important, so making the antibody profile based on the results of the 3 assays. In 2018, it was also important to indicate that other antiphospholipid antibodies, so the anti-domain 1 and APSPT, who were already popular also at that time, are not included in the criteria. The next guidance I want to propose is on the use of direct oral anticoagulants in APS. This is published in 2020. So this was shortly after the ISTH meeting in 2019, where it was obvious that more clarity and guidance was needed for the use of DOAC in APS patients. There was in 2019 the recommendation of the European Medicine Agency, who advised against it. And there was also discrepancy in recommendations in international guidelines and limited evidence. And we made that guidance in association with the Subcommittee of Control of Anticoagulants. What was clear, and what we also described in this guidance, is that high-risk thrombotic APS patients, so the triple positive patients, or the patients with arterial small vessel thrombosis or organ involvement, should not be treated with DOAC. And also, DOAC is not indicated in recurrent thrombosis, while on therapeutic anti-vitamin K therapy, or when poor adherence to VKA. But there were also areas of uncertainty, so where there is no answer at that moment. For instance, what to do with single or double positive patients, so the non-high-risk patients. Can we extrapolate the results that were based on rivaroxaban to all DOACs, for instance? And we also did not know how many APS patients are treated with DOAC. So this guidance was also the basis for further clinical research. And one of the initiatives of the SSC subcommittee was a registry on the use of DOAC in APS that is currently still running. The next guidance is on lupus anticoagulant detection in anticoagulated patients. This was also published in 2020. So why this guidance? because at that moment we felt that we felt the need for more guidance because all anticoagulants interfere with lupus anticoagulant testing, not only the DOAC, but also the heparins and VKA. And there is also no consensus on the type of assays that can be used in anticoagulated patients, as you also heard from Gary Moore earlier in this session. And in the 2009 guidance on lupus anticoagulant, there was no clear guidance for heparins. It was advised to postpone LA testing in patients treated with VKA. And of course, there was no advice on DOAC because at that time, 2009, DOAC didn't exist. So we first did a survey in 2009 to explore all these questions and to have an idea on the clinical and laboratory practice of lupus anticoagulant testing in anticoagulated patients. And indeed, that survey illustrated that there is no agreement. So what have we put then in the guidance? So what is very important is the awareness of interference of anticoagulants. So that we have the information in the lab that patients are on anticoagulated therapy, and also vice versa, that clinicians know that anticoagulants interfere with lupus anticoagulant. We also advised on when and how to test for lupus anticoagulant and how to exclude the interference if possible, and that it is also important to report lupus anticoagulant with a comment and with warnings. No, there is in fact no easy way. When we also explored the literature on that, there is no easy way to a reliable detection of LA in anticoagulated patients, where there are some options that exist if you really want to test for patients during anticoagulant therapy. So this was a guidance specifically on LA detection in anticoagulated patients. And the next guidance was on a more broader guidance, a more extensive guidance on LA detection and measurement and interpretation, published shortly after the previous one. There were already guidance on LA detection. We had the 2009 guidance. We had also the British guidelines, we had the CLSI guidelines. So there were guidelines, and indeed these guidelines already improved the measurement or the harmonization for the measurement of lupus anticoagulant and also in the interpretation. But nevertheless, we felt that we needed to update the 2009 guidelines on lupus anticoagulant with more detailed information, at least on some points. We also did a survey on that to have an idea what is daily practice, and the survey was published before we published the guidelines. So some issues on lupus anticoagulant based on the survey were clear. So for instance, the type of assays to use, the three-step methodology, the repeat testing, also the interpretive comments. That was clear and there was consensus on that. But on other issues, there was less consensus, and we noticed that there was large variability in daily practice. For instance, on the cutoff values for lupus anticoagulant, but also on the expression of the calculation of the results and the interpretation of the results. So that's why we made then the lupus anticoagulant guidance in 2020, and we searched for the best fit. So we based ourselves on the results of the questionnaire, but also on a review of the literature. And I invited, in fact, all the people who were involved in the 2009 guidelines, who were still active in the field, and additionally experts, clinicians, and researchers that were active in the field of APS at that moment. And we came to a consensus amongst all co-authors. That's, of course, very important for a guidance. And we stressed also in this guidance the changes since the 2009 guidelines. So we addressed a lot of topics in this guidance. So the patient selection, sample preparation, choice of assays, calculation and expression of results, the cutoff values, the confirmation of persistent lupus anticoagulant, and also the interpretation of results and how to report the results. But that guidance was, in fact, a practical guidance For laboratory scientists and for clinicians, that's very important. We addressed, in fact, both groups of people involved in APS. This guidance is certainly not the end of the story, because when we made this guidance already, we had some research issues, a research agenda. For instance, on the timing of subsequent and repeated testing, on cutoff values in obstetric APS patients, the fluctuation of APL titers over time, for instance, the optimal testing in stroke patients, further evaluation of the taipan snake venom assays, a universal cutoff would be interesting, and also on the pathology. And some of these issues are already addressed in projects of our SSC. The next guidance of last year, 2021, is the guidance on measurement of thrombin generation. This is also already mentioned by Bas in the former presentation. So here we described recommendations for measurement of thrombin generation. So why was that necessary? Also here we based our results for the guidance on a survey. Bas already mentioned also the survey. And to see what protocols and what pre-analytical variables are present and differ between the laboratories. So if we want to use thrombin generation as a diagnostic tool, so not only as a research tool, but also as a diagnostic tool, we need more inter-laboratory standardization, and that's why we wrote this guidance. And what's in the guidance? So thrombin generation is a useful tool for not only for the hypercoagulability, but also for bleeding disorders. And the guidance is based on the results of the survey, but also on a review of the literature. And we address several topics again. Sample preparation is important, the reagent concentration that we use, also the source of the reagents, the analytical conditions, the calibration, replicate testing, and so on. So the aim of this guidance is harmonization between the methods, because there are also many different methods for thrombin generation. So the aim is to harmonize the methods and the laboratories to support the application of thrombin generation in patient diagnosis. Also, this is a guidance, and we want now to start up a second project. Bas already also mentioned it. And this is a more practical survey by sending around samples, and we will ask for the laboratories to test these samples with their own method and following the protocol that we advise. And I hope we see more harmonization when you follow, of course, the guidance. So these are the guidance so far. And now also our SSC has a lot of projects still running. Here are 3 registries. Some are also already mentioned. The first registry will be started soon. This is on the current treatment practice in women with obstetric APS, but also women that do not fulfill the current criteria for obstetric APS. A second survey is on the APS diagnosis and antithrombotic treatment in patients with ischemic stroke and brain ischemic injury. That is what Hannah Cohen presented, the first results of. And another registry is also what Hannah mentioned, is on augmented antithrombotic therapy in arterial thrombotic APS. All the projects that are currently running you can find on the website of the ISTH SSC. Other projects are the search for uniformity in reporting of qualitative results. So I presented one study, but we need more studies on that, and also based for the qualitative interpretation based on EQC results. This is also a project that is currently running. And a last project that will be started soon is the exploring the discrepancies of INR measurements between the INR when it is measured on venous blood versus the point of care assays. So this is an overview, but you can find more information on the website of the ISTH. Also, the publications and the communications are on the website, along with the descriptions of all these projects. I hope we see each other in July in London during the ISTH meeting, and I want to thank you for your attention.
Can we please have Professor Pengo and Dr. Moore on the screen? They have joined us live. Hi, Gary. Hi, Vittorio. This is Laura speaking. Thank you very much for joining us today.
Yes, I think we have time for a few questions, one or two, because we are run out of time, but we also started later, so we have some time for questions for Vittorio, for Professor Pengo, or Professor Moore. Are there questions from the audience? Yes, please.
Can we have the microphone, please?
For me? Okay.
Thank you very much for all the presentations, also for the colleagues from outside this country. All were very interesting, but I am an obstetrician working in high-risk pregnancy. And this is one of the reasons because I am here, because antiphospholipid syndrome have a relation with obstetric problems. But my question is about your presentation, Professor Deprez, about the future, that you think that they are thinking for future recommendations. In that recommendations, I see that they include obstetrics problems that no have all the criteria according to Sapporo problems or according to laboratory problems. I imagine that are APS laboratory test negative or just one test positive and the other negative. That means, which is the reason for continuous including these patients in some future recommendation? Because there's, for the criterion that the syndrome is clinical syndrome and laboratory syndrome, that is the reason because it's a syndrome. If there's not laboratory test positive, what is the reason to continue including this obstetrics patient? Because maybe just thinking about the baby that is inside of the mother, there is epigenetic, and epigenetic means that all the drugs that you are giving to the mother can go through the placenta and make some changes in the fetus life for the future. And that means, why do I thinking that maybe this is another problem in obstetrics, not related with the APS syndrome?
Yes, indeed. One, as you notice, one of the project that will be started very soon is the CORA registry. So to have an idea on APS, probably APS patients or patients with pregnancy morbidity, let us say this way, that do not fulfill the current criteria. How do deal obstetricians or other MDs in the field with these patients? So to have an idea what's daily practice. But as what Laura also yesterday said, we have to discriminate between the classification criteria and the diagnostic criteria, because also now the classification criteria, and I think Doruk is also on the program in one session, and he will explain how they made or are making the classification criteria. So classification criteria are always much stricter than the diagnostic criteria. So even if some obstetric complications or pregnancy morbidities are not included also in the new classification criteria, this will be coming the next years, the next months, the next years. Then, of course, you have to, you have your patient before you, and you have to decide whether you consider it as an APS patient or not, and how to treat it. And I think that will be still a difficult issue, even if we have the new classification criteria, but I suppose also in the new classification criteria, some obstetric complications will not be included. But that's also only for classifications, because for classification you want to have a very clear-cut patient populations, especially for clinical studies. But daily practice, it's a totally different story, yeah, and sometimes very difficult, yeah. There is one more question. Oh.
May I talk?
Yes,
May I talk? Yeah. Katrina, I'm pleased you have made the differentiation between classification and diagnosis, because we are still in the infancy of diagnosis in the antiphospholipid syndrome, because we don't know how to classify a patient with only anticardiolipin antibodies. We don't have any instrument to judge if this patient are true antiphospholipid syndrome or not. So the point is that many studies since now have considered patients with antiphospholipid syndrome, even if they are only anticardiolipin or only anti-beta 2 or whatever, or only lupus anticoagulant. So there is a major need to have a homogeneous study, longitudinal study, if it is not possible to have a randomized clinical trial or prospective studies in these patients. This is a main issue. Thank you for comment.
Thank you, Vittorio, for your comment. We have time for one more question.
Yeah, a quick question. Thank you for the wonderful session. I'm Dr. Teruya from Texas Children's, Houston. First of all, I commend your subcommittee very strong work and high productivity. So my question is actually thrombin generation assay. So maybe Catherine, you can answer my question. So two questions. When do you check thrombin generation? Before, because of course the after starting anticoagulation, the you will see very low the amplitude. So the you have to start test before starting anticoagulation or after?
Yeah, yeah. Please go ahead. I will answer. You had two questions.
Oh yeah.
I can answer your first question already.
Yeah. So
yeah, thrombin generation is a very interesting test. It's a global test, so it can give much information, but today it is not yet used as a diagnostic test. It's very interesting, and we have to build more experience with it, and maybe we can use when we have more harmonization between the methods, because also years ago it was the same problem with lupus anticoagulant, and in fact it's still a problem with lupus anticoagulant because you have so much variation in the technology, in the methodology. This is also the same for thrombin generation. So but we hope with more guidance on thrombin generation that at a certain point we can use it also as a diagnostic tool, maybe giving more information than the lupus anticoagulant testing. But indeed it is also thrombin generation, coagulation that you measure. You also have interference of your anticoagulants. And it depends strongly on the reagents that you use. The concentration of tissue factor, for instance, is very important. Also the concentrations of your phospholipids that you use in your reagents, and you will see more or less influence depending on the reagents that you use.
Yeah, thank you. I think you already answered my second question. So the always question is when to stop anticoagulant, and so the if a TG is useful, to how long you should continue anticoagulation. So the I use TGA for other disease conditions, not in this antiphospholipid syndrome, but I use it for liver failure and ECMO patients. So, thank you.
Thank you. So, I want to thank all the speakers for their very good presentations and also for attending live. Gary and Vittorio, thank you so much. And I want to thank all that were here in the room present for your attendance, and I hope you enjoy the other sessions of the ICAPA. Thank you very much.
Thank you.
Because they tried to break into my house.
Gary, can you hear me?
Hello, everyone. Sorry for the delay. So we will commence this session on the cells and APS. I have the honor to have as chair Professor Stephen Krilis, and we also have Dr. Gloria Vasquez online. I'm going to present the first speaker, that is Dr. Chari Lopez Pedrera. She is from the Research Center on Autoimmune Diseases from Cordoba, Spain, and she will be talking about monocytes. Can we have the slides for Dr. Lopez Pedrera, please?
Thank you.
Good afternoon. First of all, I would like to sincerely thank you for your kind invitation to participate in this prestigious meeting. In this speech, I would like to summarize the main studies developed in monocytes as key players in the development of thrombosis and atherosclerosis in antiphospholipid syndrome patients. It has been widely demonstrated that patients with antiphospholipid syndrome have a large incidence of vascular damage involving thrombosis, accelerated atherosclerosis, stroke, or myocardial infarctions, among others. Several mechanisms have been proposed to explain the thrombotic and pro-inflammatory tendency of these patients, mainly comprising synergic effects of autoantibodies with prothrombotic molecules, inflammatory mediators, oxidative stress markers, and a plethora of intracellular signaling molecules in immune cells. Numerous studies have shown that the pathogenesis of both atherosclerosis and thrombosis in APS patients involves many immune system cell types, among which monocytes have demonstrated to play a key role. These cells are, however, an heterogeneous cell type with divergent functions in immunity, atherogenesis, and reparative processes. Thus, in parallel to in the relevant role in innate immunity, monocytes can promote detrimental effects by modulating a lipid metabolism, secreting inflammatory cytokines and chemokines, and producing reactive oxygen species that drive the pathogenesis. Moreover, they produce tissue factor and proteases that contribute to thrombosis and atherosclerotic plaque rupture. In this way, several studies in patients with antiphospholipid syndrome have demonstrated multiple alterations in the activation status and secretory functions of circulating and tissue monocytes associated with the development of thrombosis. Thus, in the expression of tissue factor, the main inductor of blood coagulation in vivo, was firstly described by our group to be significantly elevated in monocytes from APS patients with a previous history of thrombosis and related to the presence of high titers of antiphospholipid antibodies. Thereafter, the molecular mechanisms underlying the enhanced expression of tissue factor and the activation of monocytes in antiphospholipid syndrome patients was delineated by several studies. Thus, it was demonstrated that antiphospholipid antibodies induced the expression of tissue factor through the activation of MAP kinases and the nuclear translocation and activation of NF-kappa B in monocytes, in a process that is mediated by protease activating receptors, PAR1 and PAR2, also overexpressed in APS monocytes. It was also demonstrated that there is a close relationship between tissue factor and vascular endothelial growth factor, so that VEGF might act as a regulatory factor in APN-mediated monocytes activation and tissue factor expression, thereby contributing to the pro-inflammatory and prothrombotic phenotype of these patients. Proteomic studies further demonstrated that antiphospholipid antibodies are also responsible for the altered protein profile of APS monocytes, involving the regulated expression of annexins 1 and 2, row A proteins, heat shock protein 60, and protein disulfide isomerase, among others. These proteins have been shown to be associated with the induction of a procoagulant state, as well as autoimmune-related responses. That general scheme was some years later completed by identifying the presence of a pro-oxidative status in monocytes from APS patients. Thus, we showed that antiphospholipid antibodies further promoted an increased production of reactive oxygen species by monocytes, accompanied by significant losses in mitochondrial membrane potential, which disturbed the redox status and were related to the overexpression of both prothrombotic and pro-inflammatory mediators in APS patients. These pathologic alterations were then reversed by in vitro treatment with coenzyme Q10. Recent advances in gene expression analysis allowed to perform broad-based gene expression profiling. In a recent study, Ripoll and colleagues analyzed the in vitro effects of antiphospholipid antibodies from APS patients either with pregnancy morbidity or vascular thrombosis on monocytes in order to identify different molecular pathways related to the pathogenesis of different clinical APS subtypes. Thus, genes related to cell response stress, MAP kinase signaling modulation, and cell interactions were induced by antiphospholipid antibodies isolated from patients with vascular thrombosis. In contrast, genes associated with cell adhesion, extracellular matrix, and embryonic and skeletal development were modulated by antiphospholipid antibodies purified from patients with pregnancy morbidity, that's suggesting that the autoantibodies from different clinical subtypes of antiphospholipid syndrome patients induced disease-specific genome profiles in monocytes. Using microarray technology, then our group identified in vivo shared and differential genetic patterns related to atherosclerosis and cardiovascular disease in primary antiphospholipid syndrome plus lupus, and lupus patients. The study was developed in monocytes purified from 61 healthy donors, 41 patients with primary antiphospholipid syndrome, 54 patients with lupus, and 31 patients with both pathologies. Microarray analysis showed an altered expression of a differential number of genes among monocytes from patients with each pathology, so that only 38 genes were found to be simultaneously altered in the three diseases, indicating the heterogeneity of each of these autoimmune disorders. Functional analysis of altered genes in the three pathologies showed that at least 30% were directly related to inflammation, atherosclerosis, and cardiovascular disease. Looking deeper into the functional classification of the altered genes in the three pathologies, we observed that there was a specific profile or signature of altered genes when we compare the three diseases, and that they were associated with the altered expression of various cytokines, chemokines, and receptors, molecules involved in angiogenesis, and molecules associated with lipid metabolism. Similarly, we also observed a specific pattern of altered genes related to oxidative stress and mitochondrial function that form specific interaction pathways when combining the three diseases with each other. This specific alteration seemed to be more relevant in patients with primary antiphospholipid syndrome. Taken together, these results indicate that the gene expression profile allows the segregation of these patients with a specific characteristic that explain the pro-atherosclerotic, prothrombotic, and inflammatory changes observed in each autoimmune disorder. Current genome-wide studies have shown that the human genome is extensively transcribed and produces many thousands of regulatory non-protein coding RNAs. Among them, macroRNAs are small non-coding RNAs ubiquitously expressed with a profound influence in the regulation of almost every cellular process investigated. In humans, more than 2,500 microRNAs have been described so far, and the number is still increasing. MicroRNAs have been demonstrated to control a wide range of physiological functions, such as embryogenesis, cellular differentiation, proliferation, cytokine production, and apoptosis. Furthermore, their altered levels have been associated to a number of pathophysiological processes, such as cancer, cardiovascular disease, or immune-related diseases, among others. As for their mechanism of action, they bind by sequence complementarity to the promoter of the messenger RNA of their target gene, promoting its degradation or inhibiting its translation into protein, so that an increase in a given microRNA will imply a decrease in levels of its target protein, and vice versa. the microRNA reduction implies an increase in its target proteins. The first study that intended to characterize the role of microRNAs in the pathogenesis of antiphospholipid syndrome was published in 2011. That study identified two microRNAs as main regulators of the expression of tissue factor. Thus, the expression levels of microRNAs 19B and 20A in monocytes from APS and lupus patients were found significantly reduced when compared with healthy donors, and negatively correlated with the increased expression of tissue factor in the cell surface of monocytes from both pathologies. This study suggested for the first time the potential role of those microRNAs in the pathogenesis of thrombosis in antiphospholipid syndrome patients. In a later study, we identified and characterized a number of microRNAs related to the cardiovascular disease present in two cohorts of APS and lupus patients. The selected microRNAs were recognized on in silico studies. They were main regulators of targets involved in clinical features of antiphospholipid syndrome, such as atherosclerosis, thrombosis, immune response, and oxidative stress. In monocytes isolated from APS and lupus patients, a reduction in levels of microRNAs 124 and 125 was found, while levels of microRNAs 155 and 146 appear increased. Furthermore, the altered levels of these microRNAs correlated with markers of thrombosis, inflammation, and oxidative stress, and were associated to the presence of thrombotic events, as well as with an increased carotid intermediate media thickness as a mark of early atherosclerosis. In vitro, monocytes treatment with antiphospholipid antibodies promoted the same deregulation of microRNAs observed in vivo. Taken together, this result established that specific microRNAs might be considered potential biomarkers of immune activation and atherothrombotic development in APS patients. Antiphospholipid antibodies are directly involved in the deregulated expression of these microRNAs. All these studies have evidence that there have been many advances in the understanding of the molecular basis of thrombosis development in antiphospholipid syndrome. Nevertheless, further research is still needed in many fields, particularly in the study of the relationship among changes in global transcriptomic profiles in monocytes with the positivity of autoantibodies and their involvement in different clinical manifestations. With these premises, we have developed a new study on which an integrated approach was employed by evaluating jointly data obtained by multiple gene and microRNA expression profiling methods in monocytes from APS patients in order to characterize distinctive clinical APS phenotypes and identify novel molecular regulatory networks related to cardiovascular disease. In this study, 40 consecutive patients fulfilling the classification criteria for primary antiphospholipid syndrome and 40 healthy donors were recruited. Clinical and analytical profiles of APS patients were evaluated, including the analysis of microvascular endothelial function, the carotid intermediate media thickness, and the score of thrombotic risk, AGAPS. In parallel, we performed microRNA studies to characterize the whole transcriptomic profiles of monocytes. All the data obtained was then integrated by using machine learning approaches, as detailed later. The study of the gene profile in monocytes allowed us to identify 547 altered genes in monocytes from patients with primary antiphospholipid syndrome in comparison with healthy donors. In the same exploratory cohort, we analyzed the microRNA profile in monocytes by using nanostring technologies. The results of this analysis showed that 22 microRNAs were found differentially expressed in monocytes, including 3 upregulated and 19 downregulated. Functional classification of those altered genes and microRNAs showed an enrichment in functions linked to development of cardiovascular and connective tissue disorders. By using the microRNA target filter function within the Ingenuity Pathway software, we identify predicted or validated interactions between 19 microRNAs and 115 messenger RNAs. In this picture, it is highlighted the specific network integrated by those genes which have an overall impact in cardiovascular disease and their potential regulatory microRNAs. Then we wanted to further evaluate whether said molecular signature would be capable of clustering patients clinically into distinctive profiles according to their cardiovascular risk. By using K-means clustering analysis in the APS cohort, 3 clusters were distinguished, representing different molecular profile groups with respect to the monocyte expression levels of the signature integrated by genes and microRNAs. Additionally, partial less square discriminant analysis confirmed a clear separation between these molecular clusters, where some genes and microRNAs were identified as important variables that contribute to this discrimination. Then the clinical and laboratory profiles of each cluster were evaluated. Consistently, cluster 1 was described by patients that had suffered thrombotic episodes with low incidence of obstetric morbidity, high positivity for antiphospholipid antibodies, and high prevalence of cardiovascular risk factors. On the contrary, cluster 3 comprised the youngest patients with a high incidence of thrombosis and obstetric complications, but low positivity for antiphospholipid antibodies and the lowest prevalence of cardiovascular risk factors. Cluster 2 represented an intermediate clinical phenotype with thrombotic events and obstetric morbidity, and also intermediate positivity for antiphospholipid antibodies and medium prevalence of cardiovascular risk factors. Therefore, when comparing gaps between different clusters, we found prevalence of patients with a high or moderate gaps in cluster 1, while in clusters 2 and 3, more than 70% of patients display an intermediate or low AGAPS score. Moreover, those patients with the highest AGAPS score further display the highest incidence of atheroma plaques. Taken together, our whole data suggested that specific transcriptome regulatory network in monocytes seem to regulate the biological processes related to the pathology of antiphospholipid syndrome. The integrated transcriptome profile allow the identification of central genes, microRNAs, and pathways altered in monocytes of patients with antiphospholipid syndrome, particularly relevant to unique characteristic of the disease and at least partially regulated by antiphospholipid antibodies. As more insight is gained about the pathophysiology of antiphospholipid syndrome and the involvement of receptors, intracellular pathways, and genetic and epigenetic alterations, new treatment modalities have been proposed on which the patient's cellular and molecular profiles are becoming more and more relevant. Thus, in past few years, several potential new therapeutic approaches to APS have emerged, including combination of antioxidants, antimalarials, statins, and B-cell inhibitors, among others. Nevertheless, to accurately define the mechanisms underlying the response or no response of these patients to these therapies, the alterations that happen in such a complex disease cannot be understood as an independent units. Thus, the interaction between these molecular alterations must be evaluated to guide therapeutic decisions. In that way, in a previous study, we evaluated the global effects of fluvastatin on the prothrombotic tendency of monocytes of APS patients. 42 APS patients with thrombosis and 35 healthy donors were included in the study. APS patients received 20 milligrams of fluvastatin per day during 1 month. Blood samples were obtained before the start, at the end of treatment, and 2 months after the end of treatment. It is important to underline that during fluvastatin treatment, patients were not withdrawn from their therapy, so that fluvastatin was always given as an additional treatment. After 1 month of treatment, monocytes of APS patients showed a significant inhibition of tissue factor, protease activated receptors 1 and 2, vascular endothelial growth factor, and FLT1 expression. all of them related to the inhibition of p38 MAP kinases and nuclear factor kappa B binding activity. Proteomic analysis also showed reversed expression of proteins involved in thrombotic development after fluvastatin administration. In conclusion, the data from this study support the belief that fluvastatin has multiple profound effects in monocyte activity, which might contribute to the thrombosis prevention in APS patients. More recently, novel and specific transcriptome regulatory networks in APS, along with inflammatory and prothrombotic profiles modified by effects of ubiquinol treatment, have been identified through the implementation of a prospective randomized double-masked placebo-controlled study. 36 patients with the APS were randomized to receive the reduced form of coenzyme Q10 ubiquinol at a dose of 200 milligrams per day or placebo for 1 month. Treatments were given according to a randomized and crossover design with washout periods of 4 weeks. During this treatment, patients were not withdrawn from their standard therapy. Changes in several parameters related to inflammation, oxidative stress, endothelial activity, mitochondrial function, atherosclerosis, molecular signaling, and mitosis, along with regulatory microRNAs were assessed. The global results demonstrated the high potential of ubiquinol to modulate markers associated with thrombosis and cardiovascular disease in APS patients, highlighting its role as a safe adjunct to standard therapies in this autoimmune disorder. Because of the notable absence of clinically significant side effects and its potential therapeutic benefits, this study suggested that ubiquinol might act as a safe adjunct to standard therapy in patients with antiphospholipid syndrome. Overall, all these studies suggested that the extensive molecular profiling of monocytes in patients with primary antiphospholipid syndrome might help to identify distinct clinical phenotypes, which in turn might facilitate a patient-tailored treatment. Although further wider studies are required to definitively demonstrate that coordinated deregulation in APS patients' monocytes, and even when other molecular actors might influence these alterations, these achievements in our understanding of the disease have opened the door to the possibility of new model-targeted therapeutic options for the prevention of atherothrombotic events in APS patients. Finally, I want to present here our research team. Thank you very much for your attention and greetings for your sister city in Spain.
Okay, thank you very much. The next speaker is Dr. Ray Zhu. He's a clinical assistant professor in the Division of Rheumatology, Michigan Medicine. He's a rheumatologist, and I understand he has a clinical and is a clinical and translational researcher and has an interest in antiphospholipid syndrome. And he's going to talk on neutrophils in APS. So if you
My name is Ray Zhu. I'm a physician scientist and assistant professor in the Division of Rheumatology at University of Michigan. It's a great pleasure to talk about neutrophils and neutrophil extracellular traps in antiphospholipid syndrome. This is my disclosure. First, let's talk about antiphospholipid syndrome and inflammation. The initial concept of antiphospholipid antibody-associated thrombosis excluded the role of inflammation. This is the initial preliminary international consensus on antiphospholipid syndrome classification published in 1999. In this paper, it was specifically denoted that thrombosis should now be accompanied by histologic evidence of inflammations in the vessel wall. While more and more evidence accumulates suggests that intravascular inflammation plays an important role in antiphospholipid antibody-mediated thrombosis. Now we recognize that antiphospholipid syndrome actually is a thromboinflammatory disease. Perhaps the best study example is the complement system in antiphospholipid syndrome pathogenesis. We know now that complement activation by antiphospholipid antibody generates the complement C5a, which includes tissue factor-dependent procoagulant activities. Studies in humans, such as the PROMISE study, also supports the role of complement in antiphospholipid antibody-mediated pregnancy complications. Endothelial dysfunction is a key part of antiphospholipid syndrome inflammatory milieu as well. For example, antiphospholipid antibody can engage with the ApoER2 receptor and cause a reduction in nitric oxide production, including a pro-inflammatory and pro-coagulant endothelial phenotypes. And most recently, recognized the heightened type 1 interferon signatures among primary antiphospholipid syndrome patients further supports the important role of inflammation. And today, I'll talk about another important contributor to the antiphospholipid syndrome thromboinflammatory milieu, neutrophils and neutrophil extracellular traps. Let me first talk to you about my favorite cell, neutrophils. They're known for their ability to be the first responders against many types of infections. Neutrophils, as you know, are the most abundant white blood cells in our circulation. As a neutrophil researcher, I'm obligated to tell you that the human body produces 100 billion neutrophils every single day. That's the number of stars you will find in the entire Milky Way. Because these are cells that come kind of pre-armed, ready to go, they react very quickly. There's this double-edged sword quality to them. They have a lot of very noxious effector mechanisms, which if now properly regulated can cause problems. And these noxious things that neutrophils can do are meant to happening out in the tissue to eradicate some infectious organisms. But when they get turned on irregularly in the bloodstreams, a lot of things go sideways. The relationship between neutrophils and antiphospholipid syndrome pathogenesis has long been suggested. The first detailed look at neutrophils in antiphospholipid syndromes date back to the 1990s when it was shown in this paper, the murine monoclonal antibodies against human beta-2 GP1 activated neutrophils, stimulating them to release their granules and produce hydrogen peroxide. In the early 2000s, a series of investigations into obstetric antiphospholipid syndrome pathogenesis found that neutrophils and the complement product C5a were important mediators of fetal injury. They found that antiphospholipid antibody triggered formation of C5a at the trophoblast surface, which led to neutrophil activation. And furthermore, in vitro experiments found that antiphospholipid antibody-mediated neutrophil activation appeared to be potentiated via toll-like receptor 2 and 4 signaling. All these suggested the potential role of neutrophils in antiphospholipid syndrome pathogenesis. When neutrophils are activated, they can form neutrophil extracellular traps. We abbreviate this as NETs. This was first reported by the Germans in 2004. This is their appearance. So neutrophils can release a network of extracellular fibers and compounds of decondensed chromatin, including neutrophil DNA and high-affinity histones, which are covered with antimicrobial enzymes and granular components such as myeloperoxidase and neutrophil elastase. They are presumed to act as a physical and antimicrobial barrier extracellularly to prevent the spread of the infection and use their antimicrobial peptides to kill pathogens. NETs can also lead to autoimmunity. They expose autoantigens such as nucleic acids and proteins, which can stimulate an autoimmune response in susceptible individuals. Multiple studies have implicated NETs formation in chronic inflammatory process, as seen in lupus ankylosing and rheumatoid arthritis. It was also reviewed in recent years that these NES are prothrombotic. There are a lot of ways that NES cause blood clots. Cationic histones from NES can activate platelet and endothelial cells. NES, of course, contains protease, including elastase, and these proteases might degrade antithrombotic factors such as tissue factor pathway inhibitors. NES can activate both the intrinsic and extrinsic coagulation pathway, and NES can also present tissue factors and serve as a scaffolding for thrombus formation. This is probably one of the first implications of NES in antiphospholipid syndrome, published by Professor Anna Bloom's group in 2014. In this paper, NES generated from healthy volunteer neutrophils were incubated with sera from antiphospholipid syndrome patients. The authors found the sera from approximately 13% of antiphospholipid syndrome patients had decreased ability to degrade NES as compared with controls. They observed another interesting thing in their study. When incubating antiphospholipid syndrome patient sera with preformed NES and then staining for IgG deposition, they found there are lots of IgG decorated NES among antiphospholipid syndrome patients, which they do not see when incubating with a healthy control sera. In 2015, our group was the first to demonstrate the association between antiphospholipid antibody and NET release. This study was led by Shuri from our lab, and it was published in AAR in 2015. Shuri measured circulating NET markers, which is the myeloperoxidase and DNA complex, and found that circulating NET levels were increased in antiphospholipid syndrome patients. She also found that neutrophils isolated from antiphospholipid syndrome patients released more NETs than control neutrophils. And control neutrophils that are conditioned with antiphospholipid syndrome patient sera have more pronounced NET release compared to those treated with the healthy serum. There are some substances that turn on NETosis in APS serum, but can antiphospholipid antibody directly trigger NETosis? She then purified antiphospholipid antibody from antiphospholipid syndrome patients and treated the healthy donor neutrophil with those antiphospholipid antibodies and found that antiphospholipid antibody can indeed potentiate NETosis. It seems that anti-beta-2-GP1 IgG is the best antibodies that are triggering NETosis. You can see that from correlation perspective. We see that circulating marker of NETs remnants, MPO and DNA complex, we can see here, tracks with the levels of anti-beta-2-GP1 IgG. Shuri further looked at which receptor antiphospholipid antibody engage neutrophils to promote NETosis. You can see here at figure A, CL1 is actually monoclonal anti-beta-2-GP1 IgG, and APS IgG are polyclonal antiphospholipid antibodies. The TAK is a chemical inhibitor of toll-like receptor 4. You can see here at both 5 microgram per mil and also 10 microgram per mil concentration, toll-like receptor 4 inhibitor can attenuate antiphospholipid antibody mediated NETosis. So to further prove her observation, Shuri pretreated donor neutrophils with the anti-toll-like receptor 4 and anti-toll-like receptor 2 antibodies. You can see here at figure B. Antiphospholipid antibody mediated NETosis were attenuated when blocking the toll-like receptor 4, but not toll-like receptor 2. So these data suggest that antiphospholipid antibody mediated NETosis is likely dependent on toll-like receptor 4. In the series of papers, our group has also demonstrated the role of NETs in promoting antiphospholipid antibody mediated thrombosis in mouse model. we found that depleting neutrophils can reduce thrombosis. Treating mice with DNAase is also very good at reducing thrombosis, likely by dissolving nets. We also found that blocking neutrophil endothelial interaction can also attenuate antiphospholipid antibody-mediated thrombosis. Since our initial NETs in APS story in 2015, other group has similar observations and dive deeper into the mechanism of antiphospholipid syndrome and APL-mediated NETosis. So this is a paper published in 2018 from a Chinese group who have demonstrated that anti-beta-2-GP1 and beta-2-GP1 immune complex is a much more potent inducers of prothrombotic NETs compared to anti-beta-2-GP1 antibodies alone. You can see from this figure. They also confirm our prior observation that antiphospholipid antibody-mediated NETosis is likely toll-like receptor 4 dependent. You can see here, blocking toll-like receptor attenuates antiphospholipid antibody-mediated NETosis. They further demonstrate in the carotid artery thrombosis mouse model that anti-beta-2-GP1 immune complex promote arterial thrombosis, which can be attenuated when pre-treating mice with inhibitors of NETs, such as DNAase. So these data suggest that immune complex is more potent in promoting prothrombotic NETs formations in antiphospholipid syndrome. This is a recent study from Professor Denise Wall and Stefan Yuli's group, where they recruited 117 patients with antiphospholipid syndrome or other autoimmune disease and find a positive correlation between NETs and activated protein C resistance. So patients with high-risk antiphospholipid antibody profiles, you can see here, such as a triple-positive antiphospholipid antibody patients, had high levels of circulating NETs. And interestingly, they also have a stronger activated protein C resistance. Again, levels of NETs tracks with increased protein C resistance. So these data provide more evidence on the roles of NETs in promoting hypercoagulabilities among antiphospholipid syndrome patients. Furthermore, antiphospholipid syndrome patients can also have circulating anti-NET antibodies, which makes it harder to degrade NETs. So we developed an anti-NET ELISA and measured anti-NET IgG and IgM antibodies in 76 patients with primary antiphospholipid syndrome, 23 with lupus, 11 patients with unprovoked thrombosis but without any antiphospholipid antibodies, and 44 healthy controls. So you can see here, we found markedly elevated levels of anti-NET IgG and IgM among primary APS patients as compared with healthy controls. We further proved that these anti-NET can impair NET degradation. Sera from patients with a primary antiphospholipid syndrome or secondary antiphospholipid syndrome show impaired NET degradation as compared with healthy controls. Importantly, high levels of anti-NET IgG correlate with decreased NET degradation, while depletion of IgG partially restored degradation. We recently validated the presence of anti-NET IgG IgM in APS action cohort as well. Please check out our poster on Friday, May the 13th. Okay, so we demonstrated that neutrophils and NETs likely play an important role in antiphospholipid syndrome pathogenesis. How can we target them? Well, this is now very straightforward. There are not a lot of drugs branded as neutrophil inhibitors. Depleting neutrophil is now a viable solution. We need at least some neutrophils to keep us safe from infection. We do have clues from other disease. For example, we all know DNAase has been used in cystic fibrosis patients, and it could dissolve NETs. In sickle cell field, there's some good evidence on the selectin inhibitors showing they could block neutrophils and endothelial adhesion. The best solution will be to repurpose drugs that are already out there that do have anti-neutrophil properties but have not been branded that way. So this is a particular interest of Ramadan Ali in our lab, who has been focusing on the adenosine and its receptors on neutrophil surface and whether they could be targeted. So let me talk to you about adenosine and its receptors. There are 4 known adenosine receptors expressed in various cells at various levels, and they also have different affinities for adenosines. So for neutrophils, the adenosine A2A receptors are the most abundant type on neutrophil surface. So one thing these adenosine receptors do is converge onto adenylate cyclase. So when activated, it triggers the production of cyclic AMP. And cyclic AMP is good at turning on protein kinase. A higher level of those intracellular cyclic AMP has anti-inflammatory properties. So he tested various adenosine receptor agonists in vitro. You can see here in this figure. I find that adenosine A2A receptor agonist is the most potent blockers of antiphospholipid antibody mediated mitosis. So he showed that activating A2A receptor can actually reduce mitosis in vitro. So the adenosine A2A receptor agonists seem to be a nice target or a nice drug candidate. So he further tested this pathway and adenosine A2A receptor agonists in the flow restriction APS mouse model. And indeed, A2A receptor agonists can reduce antiphospholipid antibody mediated venous thrombosis. Okay, so what are the drugs that are already approved for clinical use that also have adenosine receptor agonist activity? So Ramadan zeroed in on this medication is called daprodamol. Daprodamol is an antithrombotic medication with vasodilatory properties. It also acts as an indirect adenosine A2A receptor agonist by blocking the adenosine reuptake and maintaining the extracellular adenosine halo. Indeed, when Ramadan dropped the daprodamol onto neutrophils in vitro, you can see here, it suppressed antiphospholipid antibody mediated mitosis. He further tested daprodamol in antiphospholipid syndrome mouse model. It also works pretty well. Here showing that mice that were treated with daprodamol can have reduced antiphospholipid antibody mediated thrombosis. At the same time, we see lower levels of NETs among those mouse that were treated with antiphospholipid antibodies. Are there any other drugs that also have adenosine agonism properties? This is a paper published by Professor Ron Asherman and Professor Dror Erkam in 2002 that demonstrated a potential therapeutic role of defibrotide in catastrophic APS patients. So defibrotide is a proprietary mixture of single-strand oligonucleotides purified from the intestinal mucosal cells of pigs. So it's currently approved for the treatment of a hepatic veno-occlusive disease. And defibrotide has been shown to be protective against endothelial cell damage and activation. But Professor Erkam informed our group that it also has anti-neutrophilic and adenosine agonism properties. So we decided to test the defibrotide in APS models. So this work is also led by Ramadan Ali, and this is recently published in AAR. And you can see, indeed, defibrotide is able to suppress antiphospholipid antibody-mediated mitosis in vitro. So we further tested defibrotide's role in vivo. It also worked. Defibrotide is able to attenuate antiphospholipid antibody-mediated venous thrombosis in mouse. And furthermore, while treatment of antiphospholipid antibody increased the levels of circulating landmarkers, such as myeloperoxidase and DNA complex. And you can see here, when you treated those mouse with the defibratides, those circulating landmarkers returns to baseline. In summary, recent advances in our understanding of the relationship between antiphospholipid antibody, neutrophils, and mitosis have provided new context to the thromboinflammatory pathophysiologies of antiphospholipid syndrome. High levels of NES are present in many APS patients. Antiphospholipid antibody can promote mitosis in donor neutrophils. And APS patients seem to have impaired ability to clear the prothrombotic NETs, which could be partially due to the presence of anti-NET antibodies. And suppressing mitosis can indeed alleviate antiphospholipid antibody-mediated thrombosis in mouse models. And when and how to target NETs as a therapy for at least a subset of APS patients certainly warrants further studies. In the end, we think that neutrophils and neutrophil extracellular traps definitely play a role in the thromboinflammatory mediators of antiphospholipid syndrome. With that, that concludes my presentation. Thank you very much.
Okay, we'll move on to the next speaker, Professor Flip de Groot, who's a leader in this area and is published extensively in the area of APS, beta-2 glycoprotein 1, the receptors for beta-2 glycoprotein 1, and he's going to talk about platelets in APS. So good. Please have the next. Thank you.
Many cells has been proposed to be the major target for the antiphospholipid antibodies. Monocytes, endothelial cells, platelets, syncytial trophoblasts, but also coagulation cascade and the complement system. But we do not know, in fact, which is the major target for the antiphospholipid antibodies. There is one study done in mice from the group of Fury who have tried to answer this question. What they found is that when you inhibit platelet activation, it also prevents endothelial cell activation, indicating that the platelets are more important than the endothelial cells. And platelets are probably the first target for the complexes, and products released by activated platelets are responsible for the local activation of endothelial cells. That was their conclusion. They did not study monocytes, they did not study the role of coagulation of the complement system, but it's the first indication of that platelets might be very important in the effects of antiphospholipid antibodies on thrombotic complications. And we have, based on this, two important questions. Is how can antiphospholipid antibodies activate platelets? And the second question is, are platelets only involved in arterial thrombosis and small vessel thrombosis? Because platelets in other situations are hardly involved in venous thrombosis. So we try to study the platelet activation induced by two different antibodies, the anti-beta-2 glycoprotein 1 antibodies and the anti-prothrombin antibodies. And the anti-beta-2 glycoprotein 1 antibodies, we have an interest in these antibodies already for a long time. Our interest in anti-prothrombin antibodies is from a shorter history. And we know already for 15 years that if you want to study the interaction of antiphospholipid antibodies with cells or with platelets, one of the things that is very important is to study the receptor that is involved in the binding of the antibody target complexes to the cells, because the receptors are involved in the signal transduction from the outside of the cell to the inside of the cell where the activation takes place. And knowing the receptor is also important because inhibition of the receptor is much more easier than inhibition one of the intercellular proteins. So if you want to treat based on this information, you can better treat on the receptor than something else. We know already for a long time that for the interbinding of anti-beta-glucan antibodies to platelets, two receptors are involved. That is LP8 and GP1B. LP8, also known as ApoA2 prime, and both receptors are involved. And one of the first questions we ask ourselves, can any antibody do this against beta-glucan? Or are there subpopulations of antibodies that are specific for the binding to platelets? And we studied that in a flow model in which we perfuse whole blood over a collagen surface under conditions of flow, and we add different antibodies just to the flowing blood, and we studied the deposition of platelets to the collagen surface. And what you can see here is that if we add an antibody against beta-glucan that is lupus anticoagulant positive, then you see a strongly increased deposition of platelets to a surface. If you add antibodies against beta-glucan that are not lupus anticoagulant positive, then the increased deposition you don't see. So there is clearly a subpopulation of antibodies who induce this effect, and that are the anti-beta-glucan antibodies with lupus anticoagulant activity. We also studied this in a mouse model, both a venous model and a thrombosis model. And on the left side, you see the venous thrombosis model. It's a pinch model. And what we did there is we studied thrombocytes in mice when they are injected with the anti-beta-glucan antibodies with lupus anticoagulant activity. And on the left side, you see a normal mice which do has LP8, and on the right side, you see a mice which do not have LP8. You can clearly see that when the LP is present, there is a strongly increased in thrombocytes in mice injected with the anti-beta-glucan antibodies compared to the mice injected with the control IgG. And when you repeat the same experiment in an LP knockout mice, this effect is gone, indicating that LP8 is very important in the venous thrombosis formation induced by anti-beta-glucan antibodies. On the right side, you see arterial thrombosis. That is a ferrochloride model, and the message is a little bit different. We measured here the time to occlusion, and you can see that if you have a normal mice and you inject these antibodies, you see a time to occlusion is much shorter than in the mice that you inject with normal IgG. And if you repeat this experiment in LP8 deficient mice, you see that the difference between control IgG and the anti-beta-glucan antibodies is gone. So again, indicating that LP8 is extremely important in the arterial thrombosis model, at least in mice. So, but it was not conclusive for us, for the questions we have, because LP8 is present in endothelial cells and monocytes. So we do not know whether the effect we see is due to platelets, endothelial cells, or monocytes. And moreover, the LPA knockout mice has also a problem in its venous thrombosis model. So it is very well possible that platelets in this case are not important or less important than the other receptors. We don't know. The other receptor which is involved, GP1B, will always result in inhibitive platelet deposition independently of the way of activation. So studying glycoprotein 1B and its role in the antiphospholipid antibodies is not possible in a mouse model, because it will always result in if you inhibit glycoprotein 1B, it will always result in complete inhibition of platelet deposition, independently of the way you activate the cells. A few years ago, there was a very interesting article published by the group of Victorio Pango, in which he compared the treatment of patients with rivaroxaban and warfarin. Rivaroxaban when in his group with 3 patients treated with rivaroxaban, 7 patients developed thrombotic complications. Well, it is 12% of the whole population. Well, in the warfarin group, no patient developed thrombosis. And this has been repeated and confirmed by many studies afterwards. So it's weird, of course, that if you inhibit coagulation with rivaroxaban, you cannot prevent against thrombosis. Well, if you inhibit with warfarin, you can. Interestingly, the thrombotic complications were all arterial. So one of the first questions we have is, are platelets involved? Yeah, because platelets are much more important in arterial thrombosis than in venous thrombosis. An important difference between the use of DOACs and warfarin is that warfarin treatment decreases the level of clotting factors. And one of the clotting factors that is decreased is prothrombin. In a patient stable anticoagulated with warfarin, the prothrombin levels are about 20% of normal. And prothrombin is one of the antigens involved in the binding of antiphospholipid antibodies. And data on the role of antiproton antibodies in the activation of platelets are limited. We did some experiments in the old days in which we could not find any effect of prothrombin antibodies on platelets. But probably that was because we studied the platelet aggregation studies in citrated blood. And citrated blood lacks calcium. And prothrombin binding to platelets needs calcium. So we should repeat these experiments of platelet aggregation antiprothrombin antibodies in the presence of calcium. To do so, we selected a series of antiprothrombin antibodies. All these antiprothrombin antibodies are directed against F1+2. That's the activation peptide of prothrombin. So all these antibodies do not recognize thrombin and do not inhibit thrombin function. And of all these antibodies there were 2 positive for lupus anticoagulant. 3B1 was medium positive, and 28F4 was a strongly positive antibody that induces lupus anticoagulant. All the other antibodies were negative. So we used all these antibodies to see whether they can activate platelet aggregation in the presence of calcium. And when we do this experiment, we found 2 antibodies that were able to induce platelet aggregation and the others didn't. And these 2 antibodies that induce platelet aggregations were the 2 antibodies that were lupus anticoagulant positive. And all the antibodies that were lupus anticoagulant negative do not induce platelet aggregation. So only antibodies, antiprothrombin antibodies with lupus anticoagulant activity induce platelet aggregation. Of course, the first question is, was calcium indeed very important? And here you see an experiment, a very simple experiment. We did the aggregation in the presence or absence of calcium. And you can see the red line is the line without calcium. And it is clearly that in the absence of calcium, no aggregation. But if you add the calcium, you can clearly see the aggregation. So the reason why we never found effects of antiprothrombin antibodies on platelet aggregation is because platelet aggregation is standardly done in citrated blood, which lacks calcium. So you need calcium to see this effect. We also made a dose response of the antibodies because the dose response clearly shows the effect. And here you can see that if you use very low concentrations of the antibodies, there is some aggregation, but it is very weak. But when you increase the concentrations of the antiprothrombin antibodies, the aggregations become stronger and stronger. So there's clearly a dose response of platelet aggregation due to the antibodies. A much more interesting question, of course, is there also a dose response for prothrombin? Because that was our starting question. And indeed, when we do platelet aggregation with different concentrations of prothrombin, and 1 micromolar prothrombin is about the plasma concentration of prothrombin, and 0.2 micromolar prothrombin is about the concentration found in stably anticoagulated patients with warfarin, you can clearly see that if you decrease the prothrombin concentration, the aggregation decreases also. So this could explain why warfarin treatment is better than rivaroxaban treatment, because warfarin treatment decreases the prothrombin concentrations and thereby inhibiting the platelet aggregation induced by prothrombin antibodies. So in the presence of calcium, anti-prothrombin antibodies with lupus anticoagulant activity induce platelet aggregation. The extent of aggregation depends on the antibody concentration, and lower levels of prothrombin attenuates aggregation, probably explaining why warfarin is a better inhibitor in lupus anticoagulant than rivaroxaban. Our next question is, what is the mechanism behind antibody-induced aggregation? Here you see an overview of a platelet with a number of receptors on the surface that are involved in the activation of platelets, and also a number of inside activities that are also involved in the signal transduction. And moreover, by all these receptors, we have indicated possible inhibitors to study the role of this receptor. So we will study the different receptors, and also with using the different inhibitors we indicated here. The first question, of course, is have we really to do with aggregation? So we used an inhibitor of the alpha-2 beta-3 receptor, which is the aggregation receptor that binds the fibrinogen. And you can see that if you add integralin, which is a good inhibitor of this receptor, you see a complete inhibition of aggregation. And for us, that's an indication that we do have aggregation and not agglutination. It's not clumping together the platelets due to the antibodies, but it's really the activation of platelets, and with the whole process with release, etc., which is involved in the aggregation. So it's aggregation and not agglutination. The next receptors, of course, very interesting, are the thrombin receptors. It is possible that it works via the thrombin receptors. So we used both thrombin the inhibitors for both PAR1 and PAR4. And what you can see here is that if you inhibit PAR1 and PAR4, there's no inhibition of aggregation, and the anti-prothrombin antibodies can still aggregate the platelets. So the thrombin receptors are not involved in the activation of platelets by the anti-prothrombin receptors. That is an important conclusion. Next, we looked to the different inhibitors of platelet aggregation that can be used in patients. For example, the prostaglandin synthesis, inhibition of prostaglandin synthesis by aspirin, for example, is a classic treatment in these patients. And when we use, in this case, indomethacin to inhibit platelet aggregation, you can see that you can inhibit the aggregation of platelets induced by anti-prothrombin antibodies with a prostaglandin synthesis inhibitor, indicating that the use of these inhibitors can be in patients will also inhibit platelet aggregation induced by anti-prothrombin. The other, probably more used inhibitor of platelet aggregation are the inhibitors of the ADP receptor P2I12, ticagrelor, for example. So we also use ticagrelor to see how they inhibit platelet aggregation induced by anti-prothrombin antibodies, and you can see also here it almost completely inhibits platelet aggregation. So also in this case, patients that you treated with this ticagrelor or of one of the other P2I12 inhibitors, you will also inhibit platelet aggregation induced by anti-prothrombin antibodies. The next step, we looked a little bit inside the platelet to see, because if you look inside the platelets, you lose the transduction inside the platelets. You learn a lot about the receptors involved in the platelet aggregation. We first used a SYK inhibitor, and the tyrosine kinase SYK, and if you use a tyrosine kinase SYK inhibitor, you see that indeed platelet aggregation is completely blocked by the addition of this inhibitor in the platelet aggregation induced by anti-prothrombin antibodies. So it's completely inhibited by SYK inhibitor, indicating that this SIG is involved in the signal transduction that is necessary for the activation of platelets by antiprothrombin antibodies. To confirm these results, we use also an inhibitor of the SARC family of protein kinase inhibitors, and again you see exactly the same effect. Complete inhibition if you inhibit the tyrosine kinase family, complete inhibition of platelet aggregation by antiprothrombin antibodies. And I think this is important because there are only 3 receptors present on platelets that needs tyrosine kinase for the activation of platelets, and that the 3 receptors are CLEC2, which is a receptor for protoplatin, which is probably important in cancer research. It's GP6, and GP6 is the collagen receptor, but it's also the receptor of fibrin, and it's Fc gamma R2 alpha, which is the receptor for IgG. And if you look to these 3 candidates, number 2, the Fc gamma receptor, seems to be the first candidate because we activate with IgG. So what we did is we tried to block this receptor, and in the upper panel you see if you activate platelets with an antiprothrombin antibody together with an inhibitor of an antibody that blocks the Fc receptor, you can see that you completely block the aggregation of platelets, indicating the Fc gamma receptor is important. To support this observation, we take our antibody and remove the Fc part of the antibody, so we make Fab fragments and Fab2 fragments to see if you remove the Fc fragment, whether you still can activate the platelets. And in fact, you can't. So you need the Fc part, and that supports the observation that if you block the Fc gamma receptor, that you block the aggregation. So the receptor is the Fc gamma receptor. To further support this, we look to the Fc gamma receptor itself to see whether if it is phosphorylated if you activate the antibodies. And you can see in the left panel indeed that if you add the antibody 28F4, then you see a phosphorylation of the Fc gamma receptor, indicating that the receptor activates the receptor. If we use activators of the other receptors, CLEC2 and GP6, you do not see a phosphorylation of the Fc gamma receptor. So indicating that only the Fc gamma receptor is involved in the activation of the cells, and that it is not the CLEC2 and not the GP6. So we know not the Fc gamma receptor. So we have now the idea that what happens in fact with these antibodies is that prothrombin binds to a platelet, where to be discussed, but probably to the negatively charged phospholipids. Then the antibody binds to prothrombin, and next the Fc part of this antibody will activate another platelet or the platelet itself via the Fc gamma receptor. And that will result in aggregation of the platelets. Where have we seen this before? Well, there is another disease, heparin-induced thrombocytopenia, which is known if you treat the patients too long with heparin that it can be induced, and that the reason is that heparin binds to platelet factor 4 complex. The platelet factor 4 heparin complex binds to platelets. This binds the antibodies against this heparin platelet factor 4 complex binds to this complex, and that binds again to the Fc receptor. So that is completely the same as with the antiphospholipid syndrome, antiprothrombin antibodies, binding of a protein, prothrombin of platelet factor 4 to platelets, an antibody directed against prothrombin of platelet factor 4 binds to this complex, and next the Fc part of this antibody interacts with the Fc receptor, and in both cases the result is thrombosis. So in conclusion, both the anti-beta-2-glycoprotein-1 antibodies and the antiprothrombin antibodies can activate platelets. The anti-beta-2-glycoprotein-1 antibodies induce platelet aggregations via LRP8 and GP1B. Anti-prothrombin antibodies can induce platelet aggregation via the Fc gamma receptor. For prothrombin antibodies, the presence of calcium is essential. The titer of antibodies is important. And low prothrombin levels attenuate the effect of the anti-prothrombin antibodies. So platelet aggregation due to prothrombin antibodies could be one of the explanations why DOACs do not protect against arterial thrombosis in patients with the antiphospholipid syndrome. And the fact that DOACs do not prevent against arterial thrombosis suggests that the antiprothrombin antibodies are only a risk factor for arterial thrombosis, because the DOACs do prevent for venous thrombosis. So antiprothrombin antibodies are more important for arterial thrombosis. I would like to thank all the people who have done most of the work. Walid Shawa is in Maastricht, did most of the work in the lab of Bas de Laat. Birmingham was extremely important for the studies. The group of Steve Watson helped us enormously, and in Amsterdam we erased all the antibodies against prothrombin. Thank you very much.
That was a very interesting talk. So the next speaker is Professor Pierluigi Meroni from Milano. He's a full professor of rheumatology at the same university and head of the Department of Rheumatology and director of the Immunorheumatology Research Laboratory in the Istituto Oncologico Italiano. So if we could have that next talk, please.
I'm really happy to attend the meeting and to discuss with you the role of endothelium in antiphospholipid syndrome. I don't have any disclosure. I'm going to discuss why, in my opinion, endothelium could be the key player in the antiphospholipid pathogenesis, in spite of the fact that beta-2 glycoprotein 1 dependent antiphospholipid antibodies may target different cell types in addition to the endothelium. I will then review which kind of receptors we have on the endothelium for the beta-2 glycoprotein 1, which kind of cell signaling can be triggered, whether or not there are additional players that can be able to increase the endothelium perturbation, and finally what the animal model taught us and how we can translate the information from the animal models to our patients. So no doubt that beta-2 glycoprotein 1, which is the main target antigen for the antiphospholipid antibodies, can be a sort of the bridge between circulating autoantibodies and different cell types expressing the molecule on their surface membrane. This is the case for the endothelium, of course, but not only, because also monocytes, activated platelets, neuronal cells, decidual endometrial cells, trophoblast cells, fibroblasts, and even neutrophils, and in particular the neutrophil traps can expose beta-2 glycoprotein 1, which at the end can be recognized by the specific autoantibodies. But let me start underline some key points in the setting of the vascular APS. Clotting is usually very well localized in common APS. This is not the case when we are dealing with a systemic coagulopathy, such as the catastrophic antiphospholipid syndrome, which is an autoimmune systemic microangiopathy. So in our mind, this finding do support the idea that the endothelium play an upstream key pathogenic role. and probably endothelium is much more important at the beginning than other cell types, that definitely in the second steps can be also involved in the pathogenesis. I mean, the circulating monocytes, neutrophils, and platelets. And I wouldn't like to forget also the involvement of fluid phase components of the coagulation cascade, which of course can be involved. So why we started with the endothelium? An idea that the endothelium could be involved in APS started just at the beginning of the APS story, when in 1995, two different groups, our own in Milan and another one in New York, found that APS sera were able to display an anti-endothelial reactivity. And actually, all these two groups showed in a clear manner that such anti-endothelial reactivity was mediated by antibodies able to recognize beta-2 glycoprotein 1, which was present on the surface of the endothelial cells. And this was carried out by using both human monoclonal anti-beta-2 antibodies as well as polyclonal anti-beta-2 IgG affinity purified from APS patients. So which kind of receptors for beta-2 glycoprotein 1 we have on the endothelium? We don't have just one receptor. We have several structures that just by chance can behave as receptors for beta-2 glycoprotein 1. As you can see in this cartoon, there are several molecules spanning from the toll-like receptor 4 and 2 to the annexin 2 to the ApoE receptor 2, which can be able to uptake beta-2 glycoprotein 1. Beta-2 glycoprotein 1 can also able to bind to heparan sulfate structures on the endothelium membranes because of the positive electric charge in the fifth domain of its molecule. We actually know that beta-2 glycoprotein 1 binds to endothelial cells through its fifth domain. In fact, mutants of the molecule in which the number of lysines can be changed, can be reduced, changed the electric charge, and such mutated molecules are no more able to be recognized by the endothelial monolayers. We also know that there are the story is a little bit more complex because, for example, toll-like 4 can mediate the binding and the signaling inside the cells by assembly a multi-protein complex, which include also annexin A2 and other cell membrane molecules such as calreticulin or nucleolin. All together, such multi-protein complex can be quite efficient in signaling inside the cells once the beta-2 is bound by the specific antibodies which can cross-link the molecule and the respective receptors. So beta-2 binds to receptors on the endothelial cells in vivo. Its binding is independent on the antibody, but the amount of bound beta-2 is very small, and actually we cannot be able to see any staining even in very well vascularized tissues such as intestine and brain in mice. But when we stimulated these animals with a very small amount of lipopolysaccharide to give them a sort of a small inflammatory stimulus, then the beta-2 can be better recognized by specific antibodies. And more importantly, the amount is enough to allow the binding of immunoglobulin and to activate complement in the animals immunized against the beta-2 glycoprotein 1 and able to produce an anti-beta-2 antibodies. This finding is important to understand much better why the antibodies alone are not able to induce any reactivity with the beta-2 on the endothelium and any clotting. This is what we showed in a very old paper study that we published in 2005, in which we reported that the passive injection of beta-2 specific antiphospholipid IgG from patients alone were not able to induce any clot in the microcirculation, in the mesenteric microcirculation of rats. But after the injection of a small amount of lipopolysaccharide, then 30-45 minutes after the passive infusion of IgG, immediately clots appeared very well localized in the microcirculation, meaning that the LPS was able to act as we called second hit, allowing the expression of enough amount of beta-2 glycoprotein 1, which was enough to bind the antibodies and to start the coagulation. So basically, the endothelium is responsible at the beginning of the antiphospholipid-mediated thrombosis, according to the two-hit hypothesis, in which we can explain why the antiphospholipid antibodies are not able to recognize the circulating beta-2, which is usually not offered in a very immunogenic form, likely in a closed form in the blood. So these antibodies at low affinity are not able to bind the circulating molecule. But after the second hit, the amount of beta-2 on the endothelium can be very well increased, and such increase is due to the fact that the second hit, for example, an inflammatory agent, can be able to increase the amount of receptor able to bind beta-2 glycoprotein 1. So there is an increased amount of beta-2 glycoprotein 1 bound to the endothelium, and when the molecule binds to the endothelium, it binds through the fifth domain, opening the molecule and exposing the immunodominant epitope on domain 1, which is much easily recognized by the beta-2 specific antibodies. Once bound, the antibodies can cluster the molecules and signaling inside the cells, triggering an activation of the endothelium, which is responsible for the expression of a pro-inflammatory and a pro-coagulant phenotype. These two phenomena are then responsible for involving additional circulating cells such as monocytes, neutrophils, can favor the adhesion of platelets, and can activate even complement. And complement, once is activated, can crosstalk with the coagulation cascade. So all these steps can cooperate in clot formation. We now know that there are several signaling pathways that can be triggered once the anti-beta 2 antibodies bind the beta 2 on the receptor. Signaling that can involve the YD88 or the P38 MAP kinases going into NF-κB translocation, but more recently it was shown that also the mTOR signaling can be activated by the binding of anti-beta 2 to the beta 2 on the receptor, using such signaling to activate. Once activated, the endothelium can display several functional effects with important biological consequences. There are several in vitro and in vivo models from different groups that reported different effects. Definitely the commonest one was the increased expression of adhesion molecules and the release of the soluble isoforms of the adhesion molecule. The activation can be responsible for the release of pro-inflammatory cytokines and chemokines. Altogether, these two mechanisms can favor the rolling and the adhesion of inflammatory cells. Quite important is the fact that once activated by anti-beta 2 antibodies, the endothelium can increase the expression of tissue factors, so directly involved in the coagulation cascade. There is an increase in the release of small extracellular vesicles. The same antibodies can increase the production of ROS, of endothelin-1, can reduce the nitric oxide synthesis, can be responsible also for apoptosis and or autophagy in a different manner. There are also some reports showing that the binding of the anti-beta 2 glycoprotein 1 antibodies can be responsible for the impairment in vascular remodeling and angiogenesis. All these biological effects can contribute to the APS pathogenesis and to the clotting. So the question is, do we have any strong evidence that all these biological effects, well shown in experimental models, can be reproduced or can take place also ex vivo in our patients? Actually, the answer is yes or not, because we have only two papers, two studies, one published in 2010, showing that at least some of these circulating parameters specific or very suggestive for endothelial perturbation can be found increased in APS patients in comparison with normal controls. This is the case of von Willebrand, which is much more release from activated endothelial cells. The same for the tissue plasminogen activator, for some soluble isoform of the adhesion molecules, such as ICAM1. There is an increased number of circulating endothelial cells. And there is another paper, another study, which found additional biomarkers, such as some pro-inflammatory cytokines, but also the vascular endothelial growth factor or soluble tissue factor, which were significantly elevated in a comparable group of APL positive patients compared with normal subjects. So going back to the beta 2 and the vessel in the tissue, usually normal tissues, normal vascularized tissue don't express beta 2 glycoprotein 1, and in a condition in which there is no any inflammatory stimulus. The question is, what is going on in vessel, in patients in which we had a clot in affected vessel? This is the case of the popliteal artery of this lady, a primary antiphospholipid lady, who presented a clot in her popliteal artery. And was obliged to undergo a surgical bypass. We had a chance to collect the affected vessel, and we could demonstrate the presence of the beta-2 glycoprotein 1 on the wall of the affected vessel. It's interestingly to show that in the same area, we could find a deposition of IgG as well as complement components. Another aspect which is quite intriguing is that to detect such beta-2 glycoprotein 1, we use the human monoclonal MBB2, which react only the immunodominant domain 1. So basically, the beta-2 that we can see in this affected vessel was actually a beta-2 glycoprotein 1, which was open and which was expressing the domain 1. Complement deposition, where the antibodies are reacting with the beta-2 glycoprotein 1, is the new entry, and complement activation can be activated till the terminal complement complex C5b9. We saw it, for example, in the patient I showed you before. It's nice to underline that the terminal complement complex could be also not necessarily cytolytic. And when it's not cytolytic, it can activate endothelial cell to express adhesion molecules and tissue factor, as shown in a very old paper published in 1997. So maybe the endothelium can be activated by the antibodies, which recognize the beta-2 glycoprotein 1 on the cell membrane, but also by the byproducts of the antibody reaction, such as the C5b9, which can deposit in the same areas. So endothelium, in our mind, seems to be the real first step in the pathogenesis of the vascular antiphospholipid antibodies. Thank you very much for your assistance, and thanks for all the other people that collaborated in collecting the data that I presented you.
Thank you. As you can see, it's nearly 20 past. Is there any burning questions from the audience? Anybody would like to ask a question? No? Okay. Thank you, speakers, for excellent presentations. We're running extremely late, so there are no burning questions from the audience, but I have one for my old friend, Flip de Groot. How are you? Burning questions from the audience. So tell me, have you done those experiments with affinity purified antiprothrombin antibodies from patients with APS? I can't hear you. I can't hear you. Are you on mute? Still can't hear you. Are you on mute?
Yes, we have seen that also with patient antibodies. Purified.
Purified prothrombin antibodies.
Yes.
Yeah. It's lovely work, Flip. Thank you for that.
Thank you.
Any other questions? So what do you think, Flip, in situations where you have patients and they have multiple autoantibodies, because these are not monoclonal in vivo, in humans, and they have anti-beta-2, anti-prothrombin. What do you see the future in terms of how you treat patients that have, say, lupus anticoagulant activity that has both beta-2 and anti-prothrombin?
What we do up till now is we treat the thrombotic complications. And for example, with warfarin, it works quite well. I think it's important to realize that probably the patients with thrombotic complications has both antibodies. And the both antibodies probably stimulates each other to really got the thrombotic complications. So inhibiting one type of antibody is probably not enough. We have to use the combination. And probably we have to still have to inhibit coagulation with the classic way.
Okay, thank you very much. And thank you again. Sorry, we've run out of time. If anybody has any questions, we can send them to you and you can reply, if that's okay. So thank you. Professor Pier Luigi Moroni, how are you?
I'm still alive. What about you? But you look well.
Thank you. I just had a 27-hour trip from Sydney to...
I know. I knew. I was listening you when you received your prize.
Oh, yes. Thank you.
Okay.
Thank you,
I'm
all
a good
speakers.
scholar.
Ciao.
Yeah.
Thank you, everyone. Coffee should be available.
Sorry about you only got 9 minutes for coffee.
Okay. Hello, everyone. Welcome to this session. My name is Yuichiro Fujieda from Hokkaido University. So today I'm moderating this session on behalf of Professor Atsumi. So this session is what clinicians should know laboratory test of antiphospholipid antibodies. We have 4 speakers, and after all the presentation are over, we will have a Q&A session at the end. So now we are starting this session. The first speaker is Dr. Massimo Landini. He's belongs to the Department of Clinical and Biological Science degree in nursing. The title is, should we include non-criteria APL as a routine panel? Please start.
Thank you very much for the kind introduction, and thank you very much for the organizing committee for inviting me to have this presentation today. It's a great honor. So I have no disclosures. These slides resume the current criteria APL testing that we have. We have lupus anticoagulant, anti-beta-2 GP1 glycoprotein 1 antibodies, and anticardiolipin antibodies. And as we all know, a patient must be persistently positive to at least one of these testing to be classified as having APS. But what is the true definition of an APL positive? We know that these kind of antibodies are very heterogeneous, both in function and in specificity, and individual tests may recognize various subtypes of autoantibodies, some of which may be pathogenic. We know that several antibodies shown to be directed to negatively charged phospholipid other than cardiolipin. For example, to proteins of the coagulation cascade, for example, prothrombin and or antibodies, to specific domains of beta-2 GP1, or to interfere directly with the anticoagulant activity of annexing A5. And we also have to consider other EG subtypes, mainly EGA isotypes. So when we look at the laboratory testing available in APS, the spectrum is much broader than only classification APL. And these slides only resume some of them because new antibody specificities are discovered through the years. So how can we choose which of these antibodies to include in the routine panel? So the first question that we have to ask ourselves before answering the main question is, why do we test patients for APL? And the main reason is, of course, for diagnosis. So patient can be found either positive and having APS or negative. But when we think about APL as a diagnostic tool, we have to remember that the diagnostic accuracy of a laboratory test is its ability to correctly identify patients that are affected by the disease. And when looking at the diagnostic accuracy of current criteria APL testing, it seems that most APS patients can't be successfully identified. This is an example of a work by Shasha that analyzed a cohort of both patients that had APS and patients that were suspected of having APS but were negative for criteria APL panel. As you can see, if we test this cohort only for cardiolipin IgG specificity, we found only 50% of patients that are positive to the testing. But when we add on more autoantibodies, almost all patients are found to be positive for APL, both criteria and non-criteria. However, we have some problem in APS. Mainly, we don't really have a gold standard to determining which patients are truly affected by the disease, because by definition, patients have to be positive for the laboratory testing. And the selected population in which we use the laboratory testing affects its outcome. For example, the prevalence of the disease directly affects the diagnostic accuracy of a diagnostic test. the higher the prevalence, the higher the positive predictive value, and the lower the prevalence, the higher the negative predictive value of a test. This has a direct implication in APL testing because if we test in selected population, for example, patient classifying as having seronegative APS with a high suspicion of APS, the rate of positive testing of non-criteria APL deeply increases. Of course, also depending on the tested non-criterion APL. In these slides, there are some examples. For example, Trulli and colleagues found out that in a cohort of 114 seronegative APS, 60% of them tested persistently positive for non-criteria APL. Similarly, Zuhui, in a cohort of 68 seronegative APS, found out that a third of these patients were positive for APL. And Liu, in a cohort of 90 seronegative APS, found out that 61% of them were positive for at least one non-criteria APL. So the rates were rather high. So we can propose non-criteria APL not as a first-level screening test, but as a second-level specialized test in those patients that are negative for criteria APL and with a high suspicion clinical of having APS. But we have to always remember the applicability of a test when we are trying to learn if implementation as an alternative of a pre-existing test, and some variables needs always to be remembered. Mainly the diagnostic accuracy of the new test that we are presenting, but also the possible harm to the patients, the cost, and a hot topic of discussion when talking about non-criteria APL, the technical challenges that these new tests represent, mainly regarding reproducibility of the test and, of course, the standardization. This is why patients, when are diagnosed with APS, the story of the patient doesn't end there, because clinicians, after the diagnosis, have to treat and follow up the patients, mainly to avoid the recurrences of the disease and to treat extracriterial manifestation, and also to distinct two main phenotypes of APS, mainly thrombotic, of pregnancy morbidity patients. So when looking at the reason why we test patients for APS, it's true that they can be either positive or negative. But in reality, patients might have multiple positive APL tests, and also they can be high positive for APL testing or low positives. This allows us to bring another player into the game and to risk analysis these patients. So patients that are at high risk of developing new clinical manifestation or low clinical risk. This is important because subjects positive for APL have a low risk of developing thrombotic events, less than 1% a year. But after a first episode, the risk of recurrences increases by 10 to 67%. An important application of the risk scoring analysis is scoring. Here are two of the main examples, which are the GAP score by Shasha and the APL score by Otomo, and both scores uses non-criteria APL in their equation. And both scores were validated in prospective cohort and can predict those patients that are at higher risk of developing clinical manifestation of APS. But what are the unmet needs and what can we do with APL testing? We can better characterize the patient that we see in our clinic. So we know that there are different phenotypes of disease. We know that main phenotypes are pregnancy morbidity and thrombotic, but we can go deeper than that. We can distinguish patient as having a venous thrombosis or arterial, extracriterial manifestation, And we can also identify patients that are at higher risk for specific organ manifestations, such as stroke. This is the example of Volkov, of an important study that identified through the use of APL testing, both criteria and non-criteria APL, different phenotypes of disease. So as you can see, they can identify arterial thrombosis, but also central nervous manifestation through the use of an extended panel of APL. Another example is the study by Kikinzola, where they used the positivity of domain 1, glycoprotein 1, to distinct patients with pregnancy morbidity through early pregnancy morbidity and late pregnancy morbidity according to the positivity of domain 1. So, in conclusion, extra criteria APL should be considered as an added tool, and while experts currently are debating if evidence is sufficient to include them in the classification criteria, some guidance should be considered. Extra criteria APL testing should be considered as a diagnostic tool when other criteria APL are negative and the suspicion of this patient as having APS is high. And they can also be used to better characterize the clinical risk of developing clinical manifestation of APS, and mainly avoid recurrences. And in the near future, different APL profiles might help us to characterize different phenotypes of disease. Thank you very much.
Thank you for your presentation. So we'll move on the next presentation. Next speaker is Dr. Ricardo Forastiero. Yes. Yeah, he is a professor and investigator of Universidad Favoloro. Okay.
But the slides?
No slide?
No, okay.
Okay. Professor Ricardo, please start.
Thank you very much. Okay. Well, good afternoon. Well, we are trying to explain a little short this issue. Well, as you know, early this morning and also tomorrow, LA testing includes, at the present time, the performance of routine coagulation test, as indicated here, plus a specific LA-specific test. The ISD8 guideline recommends performing two different types of tests or clotting tests, DRVBT and APTT-based clotting assays, and using the three-step procedure, screen, mixing, and confirmation, and using for paired APTT and paired DRVBT, this is a list of different assays you can see as a screening, as a confirmation, LA-sensitive tests and LA-insensitive tests. The different antithrombotic drugs affect or interfere with almost all assays, clotting assays. And for example, for those assays used in LA testing, you can see that, for example, as a summary, that classical heparin prolongs APTT mainly, well, APTT and thrombin time in a dose-dependent manner. Low molecular weight heparin slightly prolongs APTT and TG, or thrombin time, but silica clotting time and DRVBT is only prolonged if heparin or concentration exceeds heparin neutralizers. In the case of vitamin K antagonists, all assays are affected depending on the level of INR. And for the last antithrombotic drugs, the direct oral anticoagulants, all of them, in different ways, modify or interfere with all clotting tests, depending on their antithrombin or anti-TNA drugs or inhibitors. In this case, the thrombin time, for example, is only affected or prolonged in the case of the patient is treated with dabigatran or the only antithrombin inhibitor. Here you can see the effect of direct oral anticoagulants on the various coagulation tests. In these figures, you can see, for example, for dabigatran, apixaban, and rivaroxaban, how prolonged and altered DRVVT, APDT, and PG in a concentration-dependent manner. And in the table shown below, you can see the percentage of the prevalence of abnormal results in patients treated with dabigatran or rivaroxaban. Almost 100% of different screening and confirmatory tests are affected by this drug. This new test, the trypan snake venom time as a screening and the heparin time as a confirmatory test, has been recently validated and evaluated in an international multicenter study. This was explained in detail early this morning in a session. The results of this test are expressed as a ratio, trypan, heparin, and you can see here only as a summary how these new assays showing a good correlation with the classical LA test, DRVVT, and APDT. This assay shows a sensitivity of 78% and 95% specificity, and the validation of this study, or the conclusion is this is useful and have been validated for using in non-anticoagulated patients, in patients treated with vitamin K antagonists or under anti-TNA inhibitor or DOACs. And it's not useful, it cannot be used in patients treated with antithrombin direct oral anticoagulants or under heparins. This is only a title of the last recommendation of the ISDA guidelines, the 2020, where whenever possible, blood for LA detection should be collected in patients not receiving any anticoagulant treatment, perform testing when patients are not on anticoagulant therapy, at least 48 hours after ceasing DOACs or 1 week after ceasing vitamin K antagonist. In patients treated with heparins, the recommendations are that heparins interfere with LA clotting assays. However, although classical heparin and enoxaparin affect the DRVVT at supratherapeutic anti-TNA levels, they may not lead to false positive LA in a 3-step procedure as recommended. Some reagents contain heparin neutralizer, but it's important to verify the levels of heparins that are quenched in these reagents. Samples should be taken, when feasible, at least 12 hours after the last dose of low molecular weight was administered or as near as possible to the next dose. So in this case, thrombin time and anti-factor Xa activity will help to identify LA if possible. And in any case, in any of the both assays, thrombin time is prolonged or anti-TNA is positive, LA testing must be stopped. If the patient is on vitamin K antagonist, consider performance of LA as a mixing study. Note, however, that although this was identified as a recommendation in the 2009 ISDA guideline, it is not a recommendation in the last guidelines because of the potential to miss weak LA. Although in vitamin K antagonist treated patients with an INR less than 3, LA testing is discouraged. If attentive, results should be interpreted with care. Trypan heparin tests show good sensitivity to LA in patients anticoagulated with vitamin K antagonists. You all have to know that this test in isolation cannot detect every LA, so a negative result does not exclude the presence of a LA, but a positive result is diagnostic for LA. In this case, with patients, it's important that DRBBT and APTT classical LA tests must be interpreted with care, and it's very useful mixing study and also the type 1 hecarim test. When patients are under direct oral anticoagulants, it's feasible LA testing should be progressed after a brief introduction of DOACs on a pragmatic empirical basis at least 48 hours after the last dose, and longer in patients with renal impairment. It's required to test while on anticoagulant therapy, test anadir levels, test samples taken before next dose of DOAC. However, be aware that even at trough DOAC levels, a lack of DOAC effect on LA tested cannot be guaranteed, even if a DOAC neutralizer is used. When using a direct oral anticoagulant neutralizer, testing the DOAC level before and after the neutralizer will provide some evidence of DOAC-free LA testing. In the case a patient is treated with antithrombin inhibitor, the thrombin time is very useful. If thrombin time is prolonged, the LA testing must be not evaluated. In the case of patients treated with anti-10A inhibitors, if this is positive before the analysis, only the type 1 hecarim test can be used. There are several studies in the last years reporting about the DOAC removal or neutralization in vitro with using different devices or strategies, DOAC stop, DOAC remove, and DOAC filter. But in general, all of them reduce DOAC interferences in LA tests, but as incomplete direct oral anticoagulant removal may occur, DOAC measurements should be performed after removal, filtration, or neutralization. So, in conclusion, all anticoagulants, all antithrombotic drugs affect the safe use to investigate LA, but to a variable extent. If possible, investigation of LA will occur at a time when patients are not on an anticoagulant. However, should this be unavoidable, there are several strategies available to mitigate anticoagulant interferences, including the use of various anticoagulant neutralizers. Thank you very much.
Thank you for your presentation. Next speaker is Dr. Angela Tinkani. This is virtual online presentation. So, Dr. Tinkani is Associated Professor in Rheumatology, University of Brescia, and Deputy Director of Rheumatology and Clinical Immunology. Please start your presentation.
I am Angela Tinkani, and I am very pleased to present at the 17th International Congress of Antiphospholipid Antibodies. Our task for today is to speak about the fluctuation of antiphospholipid antibody over time, at least what the clinician should know about this phenomenon. First of all, the importance of antibody titers in APS. This is well known from the time of the classification criteria. In fact, both in 1999 and in 2006 classification criteria, it is stated that laboratory criteria are antibody, anticardiolipin or anti-beta-2-GP1 antibody at medium or high titer measured by a standardized enzyme-linked immune sorbent assay. In other words, by a standardized ELISA. So we have used all this year this assumption, and in fact we have seen that vascular APS is associated to antibody at medium high titer, and obstetric APS is also associated to antibody at medium high titer, although some people, some women with low titers can also have obstetrical problems with related to antiphospholipid antibodies. But more than this, in fact, we have observed that not all the patients with antiphospholipid antibodies have thrombosis or pregnancy losses, and that many patients with thrombosis or miscarriage do not have antiphospholipid antibodies. So, antiphospholipid antibodies are not really a diagnostic tool, but can be considered a risk factor. If antiphospholipid antibodies are a risk factor, we need to quantitate the risk. In other words, to define the risk profile. In the EULAR recommendation for the management of antiphospholipid antibody syndrome in adults that were published in 2019, there are overarching principles, and the first one is, in fact, the risk stratification. And in the risk stratification has a great importance the titer of antibody. And again, anticardiolipin antibody are classified at medium high titer, are classified as antibody with an GPL or MPL titer more than 40 units, like in the classification criteria. And for anti-beta 2 GP1 is used the 99th percentile. All the test has to be measured by a standardized ELISA. And in fact, in the high risk profile, one of the criteria included is the positivity of antibody persistently present at medium high but better high titer. So this is part of the risk profile, and risk profile is important for the clinical judgment. And as a matter of fact, practically the management of obstetric APS pass through the quantification of risk, because patients with obstetric APS with high risk profile have a treatment different from patients with low risk profile. This is true for obstetric APS during pregnancy and also for antiphospholipid antibody carriers during pregnancy. Low and risk profile change our practical care of patient, our practical management of patient. So this is really very important. And now we go to the titer variation. Generally speaking, antiphospholipid antibodies are stable during the time. And in fact, this is a recent paper published by APS Action, including 4,072 patients with clinical meaningful APL profile, and that were followed for a mean follow-up of about 5 years. And nearly 80% of these patients remained stable during the time. So with a stable antibody titer during the time. And the fact to have at baseline a triple antibody positivity decreased the risk of having an unstable title, and the presence of an isolated lupus anticoagulant increased the risk to have an unstable titer of antibodies. Here was seen no effect of drugs, time, and autoimmune disease. However, long-term treatment with hydroxychloroquine can decrease antiphospholipid antibody titers. As you can see here in the picture, we have studied 114 patients with primary APS. for a long time, for a time of about more than 5 years as mean follow-up time. And you can see here in the red area the measurement before and after the follow-up in the patient exposed to hydroxychloroquine, while here are patients not exposed to hydroxychloroquine, and the effect is quite visible. Looking in detail to patients with medium high APL titers, we can see that the exposed patient had a decrease almost in all tests and in all the isotype. The decrease was much less or not existent in patient not exposed. And this can also lead some patients that were high positive, like those in the black bar, that can become medium positive or also negative. So they change category. And this is important, as I said before, for the problem of treatment. This result was confirmed by a recent paper from the group of Maria Tectonidou that have seen that in 3 years treatment with hydroxychloroquine, for sure, the titer of anti-beta 2 GP1 in IgG and IgM decreased, while for anticardiolipin, she saw only a trend for the IgG and nothing really for the IgM, like we have also seen in our previous experience. But other drugs can also decrease the antibody, the antiphospholipid antibody titer. As an example, here we see belimumab. Belimumab is a drug very much used in lupus patients, and it has been shown that in a time of about 2 years is able to decrease the antibody titer of anti-beta 2 GP1 IgG and anticardiolipin IgG, much less of the IgM. There were also about 30% of patients that became negative. This is a result of a work done in our unit, but there are also other authors that had almost the same results. So it's possible that patients become negative. This is called seroconversion. And seroconversion was studied, interestingly, in sleep patients, because, of course, these patients are those that are most exposed to immunosuppressive drugs. And this study done by the group of Padova included 513 lupus patients, of which 55 had vascular APS. 16 of these patients became negative during a follow-up time of 2 years. Of course, a predictor of positivity was immunosuppressive therapy, but a negative predictor was again triple antibody positivity, like in the paper that we previously mentioned, the one of Erkan. So this should be something real. And in fact, Professor Pengo is saying this since a few years. So if these 16 patients that became negative, 13 had a discontinuation of their treatment with oral anticoagulant. And they were then followed for 45 months, an average of 45 months, and no thrombosis were seen. Although this patient, 2 of these patients, had previously an arterial event. Despite this, no thrombosis was seen. Again, this seroconversion was also mentioned, was also found by other groups. Therefore, we wanted to look in the phenomenon and understand what people was thinking of it. So we did a survey among 30 Italian experts of the Italian Society of Rheumatology. And we found a substantial agreement on the definition of seroconversion or negativization. So it was agreed that it was the case of two negative determination, 1 year apart, one from the others. And also this expert considered very seriously the withdrawal of vitamin K antagonist treatment. But it was taken into account several problems like the concomitant presence of cardiovascular risk factor, modifiable and non-modifiable. It was considered the age, the size or the gravity or the intensity of the clinical event at the beginning of the story, and also the presence of extra criteria manifestation or autoimmunity. However, it was considered possible to withdraw the vitamin K antagonist treatment. Now we go to the third part. We have seen that antibody titer is important. We have seen that can vary, and is also important to understand how and if it varies. And now we have to define how to measure the titer of antiphospholipid antibodies. And for this, I prepared 3 short clinical cases. Are 3 female, 2 50 years old, and 1 31 years old. The first one had, at the beginning of the story, a pulmonary embolism and a stroke. The second one had paresthesia of the right hemisome followed by a stroke, and also it was seen a mitral valve big vegetation that was disappeared with warfarin treatment. The third one is the case of a lady, 52 years old, that in 2001 had 2 transient ischemic attacks, and in 2016, 1 stroke. She came to see us from the neurology department, and she was always treated with antiaggregant. All these patients were studied with antiphospholipid antibody, both with our historical ELISA method and with the new CLIA method. And here are the results. Minus means weak positive or negative, and plus means medium high positive. As you can see, the first lady has medium high positive results both in ELISA and in CLIA, although there is some difference in the isotype, but in any case, high titer were seen in by both methods. On the other hand, the case number 2 was completely negative in ELISA and had IgG anticardiolipin and IgG anti-beta-2 GP1 in CLIA. The third case was completely negative in CLIA and was positive, high positive for anti-beta-2 GP1, IgG and IgM, but only by ELISA. So this can be a problem, a real problem in the management of this patient. All the 3 patients were lupus anticoagulant positive, and here you can see also the current treatment that they are doing. I must say that case number 2 is a girl who wanted herself absolutely discontinuate warfarin treatment, so there was nothing else to do. However, you have seen how different performed the two tests to measure anticardiolipin and anti-beta-2 GP1. So how we define medium high titer in the two tests? Well, for ELISA, according to the classification criteria, GPL, MPL, more than 40, 19.9 percentile, and so forth. For anti-beta-2 GP1, the 1990 percentile was done by our old ELISA method that in which we have a great experience, I must say more than 30 years of experience, and we can fix the low, medium, high titers defined as you can see there. Regarding CLIA, we had to follow the kit instruction, and so the cutoff is 20, and with empiric decision, we decided to put the high positive more than 40, so 2 times the cutoff, more 40 units. Is written MPL and GPL, but is wrong because they are CLIA units. So, how to attribute medium high titer? Here you can see the result of 46 patients that were studied both with ELISA and with CLIA. These patients, as you see in these patients, by ELISA, we had five medium high positive IgG anti-beta-2 GP1. Of these 5, only 1 was medium high positive by CLIA, while in CLIA there were other 6 high positive that were low positive or negative in ELISA. This means a kappa, a coefficient of Cohen correlation that is 0.046, only a slight agreement. The same story was done for anticardiolipin, and for anticardiolipin, we found no agreement between the two tests. And for IgM, the agreement was a little better because there were 2 patients seen by both the method for anti-beta-2 GP1, and as a matter of fact, CLIA didn't find any other high positive, while medium high positive in ELISA were many more because there were 8 more medium high positive. However, the kappa of Cohen was better, and for the IgM, there was a substantial agreement. However, this is a bit of a problem because using one or using the other method, you can classify patient in one way or in another one. And this was also the opinion of an important group of the ISTH Society that recently published the interpretation of the semi-quantitative anticardiolipin and anti-beta-2 GP1 antibody measured with various analytical platforms. And the conclusion is that using the new assay, the threshold of medium high positive need to be assessed by clinical approach or using monoclonal antibodies as reference. The clinical approach is something, but as I say, if we started to use our ELISA in the 90. So it's about 30 years of clinical approach. For CLIA, we started to use it 1 or 2 years ago. So the clinical experience is not so huge. So the problem is still a little bit open. In conclusion, what the clinician should know of this fluctuation? First of all, the clinician should know that the antiphospholipid antibody titer is one of the main criteria to quantify the risk of clinical events. So it's important to know the level, the titer of the antibody. The titer of antibody is generally stable in the time, over the time, but can decrease or become negative after immunosuppressive treatment. And this can, of course, influence the patient management. Then it is important that clinicians know that using the new assay that probably their laboratory use now because are more, automatic, modern, and so forth, using this new assay is necessary to assess in each lab the level of medium high titer that are the significant titer of antiphospholipid antibodies. With this, I want to show you many international antiphospholipid antibody meeting during all this year that were always very satisfactory, and I'm sure that this will be also a great success. And I want to thank all of you and thank all the people that work in my unit for their enthusiasm in the study of antiphospholipid antibodies, and in particular Stefania Bertocchi, who helped me to gather all this information. Thank you very much for your attention.
Thank you very much, Dr. Tinkani. So last speaker is Dr. Robert Rube. He's also a virtual online presentation.
Hi, this is Robert Rube,
Yes.
and I'll be speaking today on how we define triple APL. I have no conflicts. So triple positivity on the surface is a quite simple concept. There are three different antibody tests in the established criteria for classification of antiphospholipid syndrome, which are anti-cardiolipin antibodies, IgG or IgM at medium to high level. Similarly, anti-beta-2 glycoprotein 1 antibodies, IgG or IgM at medium to high level. And lupus anticoagulant generally is defined by the ISTH Scientific Standardization Committee. It's important to notice, however, that these criteria and what makes up triple positivity are based on these tests. They are not based on antibody specificity. So that can lead to some confusions, I think. So this is a diagram I've shown multiple times in the past, but I do think it's worth showing again to sort of refresh the association between these antibody tests, the actual specificity of the antibodies that are detected in these tests, and then the clinical associations with antibodies to these targets. So the anti-cardiolipin test detects antibodies to cardiolipin, which are typically associated with syphilis, with certain infections, and may occur in otherwise healthy individuals, but are probably not associated, at least strongly, with antiphospholipid syndrome. In contrast, we now know that anti-cardiolipin tests also detect antibodies to beta-2 glycoprotein 1, primarily bovine beta-2 glycoprotein 1. Historically, bovine serum or plasma was used as a blocking agent in sample diluent and contains large quantities of beta-2 glycoprotein 1. And with seminal work back in the early 90s showed very clearly that this is the target of most so-called anti-cardiolipin antibodies. And then because of the way the assay is set up, it's certainly possible that antibodies to other cardiolipin binding proteins in serum could be detected. We don't know that this occurs, and we don't know any of the clinical associations that might go along with this, APS or otherwise. We now have anti-beta-2 glycoprotein 1 assays, and we've had them for a long time. They use human beta-2 glycoprotein 1 as the antigen, and they are clearly associated with antiphospholipid syndrome. And then the other major test of the three is the lupus anticoagulant, which has been shown to detect several different antibodies. For one, antibodies to human beta-2 glycoprotein 1, which is present in plasma, can certainly exert a lupus anticoagulant activity. And then antibodies to prothrombin can also be the specificity involved with lupus anticoagulant activity. It's also certainly possible that there could be other plasma antigens that are involved in lupus anticoagulant activity if we find there are lupus anticoagulants with neither, that are due neither to anti-beta-2 or prothrombin. And more recently, the antibodies to prothrombin, particularly antibodies to phosphatidylserine prothrombin, have been shown to be fairly robust indicators of associated with antiphospholipid syndrome, and can be causative of lupus anticoagulant activity. It's fairly clear also, and I'm not going to go into this, that the relevant antigen in that assay is the prothrombin, not the phosphatidylserine. And the assay is designed in such a way that it does not generally detect antibodies to beta-2 glycoprotein 1. This is largely due to the presence of a significant concentration of calcium in the assay, which inhibits beta-2 binding to the phospholipid surface and promotes binding of prothrombin to the phospholipid in a physiological conformation. Most of these antibodies are relatively low affinity, and those are the ones that are associated with antiphospholipid syndrome. There is a very small subset that are high affinity and can be associated with a lupus anticoagulant hypoprothrombemia syndrome, which is actually a hypercoagulable state. I'm sorry, it's the opposite. It's a bleeding state because the antibodies are high enough affinity where the prothrombin is depleted. And anyway, that's a fairly rare complication. So, as we've just shown, anti-cardiolipin and anti-beta-2 glycoprotein 1 tests are both detecting antibodies to beta-2 glycoprotein 1. These are largely overlapping, but not completely overlapping sets of antibodies. The concordance of the two assays in patients with antiphospholipid syndrome is fairly high. By definition, patients who are triple positive are concordant. They're positive in both. There are a number of reasons for discordant results, and these are some of them. Antibodies binding to cardiolipin itself, true anti-cardiolipin antibodies, which are not particularly associated with APS, will not be detected in anti-beta-2 GP1 tests. Another rare but interesting reason is there can be species specificity of patient anti-beta-2 glycoprotein 1 antibodies. As I said before, the main species of beta-2 glycoprotein 1 in cardiolipin assays is bovine. And I have seen a number of patients with antibodies specific for human, but not particularly binding well to bovine beta-2 glycoprotein 1. And these would not be detected in a cardiolipin test or be detected perhaps at very low titer. I don't think this is common, but it does happen. And then another very interesting and perhaps the most important possibility is the epitope specificity of anti-beta-2 glycoprotein 1 antibodies. The two assays probably display the epitopes on beta-2 glycoprotein 1 in different ways. For example, it's generally accepted that it's domain 4 and 5 of beta-2 glycoprotein 1 that bind to the cardiolipin-coated plate. Therefore, domain 4 and 5 may not be available for antibodies to bind to them. Since it seems, as we'll be discussing, that antibodies to domain 1, which are then favorably displayed on the other end of the molecule in an anti-cardiolipin test, can be detected. And this could be an advantage of anti-cardiolipin tests, perhaps over anti-beta-2 glycoprotein 1 tests. So what makes an antibody a lupus anticoagulant? What is lupus anticoagulantness? The general thinking is that anti-beta-2 glycoprotein 1 and or anti-prothrombin antibodies exert LA activity if they can form high avidity cross-linked phospholipid-bound antigen-antibody complexes in the coagulation assays. This inhibits the coagulation reactions because it decreases the available anionic phospholipid surface. And this explains why the various confirmatory tests for lupus anticoagulant do what they do. And again, I mentioned earlier the role of epitope specificity. And here you see in this diagram a rough sketch of beta-2 glycoprotein 1 and what it looks like perhaps when it's bound to a membrane with domain 1 sticking out and available for antibodies to bind to it, whereas domain 4 or 5 are closer to the surface and perhaps not available. So for this reason, antibodies to domain 1 are more likely to have lupus anticoagulant activity as compared to domain 4 or 5. The other very important thing that I think is often overlooked is that it takes a very high concentration of antibodies to influence a coagulation test. It's not a particularly sensitive assay in terms of the analytic sensitivity. So as I was saying, lupus anticoagulant assays are much less analytically sensitive than anti-cardiolipin assays and anti-beta-2 ELISAs. And this is not surprising. ELISAs are exquisitely sensitive and can detect very low concentrations of antibodies. I think a lot of the material I've shown here on the slide are sort of under discussed or advertised, if you will. With monoclonal antibodies, for example, the final in the UK NEQUIS testing program, the final monoclonal antibody concentration in lupus anticoagulant assays was 60 micrograms per mil, which is a very high concentration of a monoclonal antibody. And that's 100 to 1,000-fold greater than the typical level of monoclonal antibody detection in immunoassays such as ELISAs. And going way back into the mid-90s, some of the first antibodies that were looked at, one in particular, EY2C9, were initially reported to be lupus anticoagulant negative. They were easily detectable in ELISAs at less than 0.08 micrograms per mil, and they were originally reported as being LA negative, being tested at 50 micrograms per mil. However, in a subsequent paper, in a somewhat modified APTT, when they were tested at 80 micrograms per mil with a little bit of added beta-2 glycoprotein 1 into the system, they had lupus anticoagulant activity. We actually described the very first monoclonal antibody to beta-2 glycoprotein 1, and that was detectable in ELISAs at less than 0.05 micrograms per mil, but LA activity was seen at 50 micrograms per mil, 3 orders of magnitude greater. This has also been shown limited data with polyclonal antibodies using total IgG purified from 2 APS patients They were strongly positive in ELISAs at 50 micrograms per mil. Again, this is total IgG, but LA activity was seen at 250 and 500 micrograms per mil, respectively. So I just think it's important to keep in mind that LA assays imply high antibody titer. They may also imply other things, but they certainly do that. So one of the things we looked at, and this is actually a slide from a couple of years ago, there are some new data coming out here that I didn't want to share today because it's not published yet, but it largely confirms this. We calculated an APL load, basically very simplistically, just adding together the unit values for IgG, IgM, cardiolipin, and IgG, IgM anti-beta 2, and saw whether that correlated with lupus anticoagulant activity. And you can see in the graph and then in the table, the average APL load was 2 to 3 times higher in LA positive patients than in LA negative patients. So in the original diagram I showed you in the beginning, I talked about the anti-PSPT assay. So one question that has interested me and I think is important to talk about is whether prothrombin-specific lupus anticoagulants are reliably detected in the anti-PSPT assay. And there's been a number of studies looking at this from our own data, which unfortunately is unpublished. We looked at 5 patients who were isolated LA positive, they're LA positive, cardiolipin and beta 2 negative, using a very early in-house version of an APSPT assay. And they were all positive in that assay, 5 of 5. Going back to 2001, Tatsu and his folks showed that APSPT was strongly associated with lupus anticoagulant, both IgG and IgM with very high odds ratios. Laura, back in 2012, showed that APSPT was present in 51% of lupus anticoagulant patients, but only 22% lupus anticoagulant negative patients. There was another study with 14 so-called tetra-positive patients, that is positive in the 3 standard assays plus APSPT. This group, Katani et al., affinity purified antibodies to beta 2 and to prothrombin and showed that the APSPT was clearly associated with LA activity. The next study shown here is the outlier of sorts. They reported on 44 patients with isolated LA, and only 3 had IgG APSPT and only 5 had IgM APSPT. So whether this is something methodologic, perhaps, or these are just different lupus anticoagulants with a very different specificity that we don't know yet, remains to be determined. In a recent study by Egri et al., 25 of 25 lupus anticoagulant patients, this wasn't isolated, but 25 of 25 lupus anticoagulants were positive for IgG APSPT, and 6 of 54 lupus anticoagulant negative patients were positive. Lastly, Tonello et al. Last year, 66 of 86 or 77% of isolated lupus anticoagulants were APSPT positive, G and or M. So whether, how reliable a combination, let's say, of cardiolipin beta 2 plus APSPT would be in detecting the vast majority or maybe all of lupus anticoagulant patients remains to be determined. It doesn't seem like it's going to be 100%, but it may be a very high percent. So why would there be a discordant result? One is, which isn't relevant for isolated LA, but there are clearly, some lupus anticoagulants are beta-2 GP1 specific. And in fact, patients could have a lupus anticoagulant due to both specificities. And again, as I alluded to above, lupus anticoagulant could be due to antibodies other than anti-beta-2 and or APSPT. We don't know what those are or really if they exist, but they could. An important feature, I think, is most of these studies did not look at the antibody level. So it is quite possible that a patient could be positive in the APSPT assay, but not have a high enough antibody level to be lupus anticoagulant positive. And then lastly, we really don't know much about the epitope specificity of APSPT or of antibodies detected in APSPT assays. And there could certainly be some that are more prone to be associated with lupus anticoagulant activity than others. So triple positivity, and in particular LA positivity, are very high risk, are generally known to be high risk APL profiles. Why? Well, lupus anticoagulant-ness, as we just talked about, is related to thrombogenicity. The pathophysiological effects of APL are thought to be associated with their ability to cross-link membrane-bound antigen. And this is essentially the same as lupus anticoagulant activity, or very similar. And in very interesting studies from a few years back, it was shown that dimerized beta-2 GP1 mimics the pathological effects of APL. Then lupus anticoagulant positivity, as I mentioned, is a proxy for high antibody titer. And it's pretty clear, and it's been clear since the 80s, that higher antibody titer is associated with more clinical disease. As we mentioned, there's significantly lower analytical sensitivity in lupus anticoagulant assays, which means that if it's positive due to a lot more antibody. And it's been pretty clear that lupus anticoagulant has a higher predictive value and diagnostic sensitivity than the immunoassays. Another reason may be that LA tests reflect the combined effect, as I mentioned before, of all antibodies in a specimen, be that beta-2 prothrombin or something else, and of all isotypes. It's casting a much broader net than any individual immunoassay. Lastly, the antigens in LA assays are not immobilized on a plate the way they are in an immunoassay, or on a bead. So this could allow for optimal equilibrium configuration of cross-linked phospholipid-bound antigens. What about more recent data on the risk associated with triple positivity? Here's just a couple of recent studies. Lazzaroni in 2019, really the title of this paper sort of says it all. They looked at 62 pregnancies in women who were APL carriers, asymptomatic APL. And they found that they were associated with a significant risk of pregnancy complications. Demetrio Pablo in 2022 looked at 138 asymptomatic APL patients and found that triple positivity was an independent risk factor for the first thrombotic event and for obstetric morbidity with significantly elevated odds ratios. Udry looked at 169 women with primary obstetric APS and found that triple positivity was a strong independent risk factor for the first thrombotic event and for new obstetric events. On the other hand, there are a couple of studies that haven't shown this sort of association. Bertin in 2021 compared 88 triple positive in patients with 73 single positive ACL patients and found an elevated risk in both groups, but it wasn't particularly greater in the triple positive group, and I'm not sure why that was. Lastly, Spinello looked at 163 APL positive pregnant subjects and 785 controls, and found that somewhat surprisingly found the attributable fraction of adverse obstetric events was actually higher with the single positivity. So where are we and where are we going? And I just want to highlight this recent paper from last year by Radin that I think is an interesting model for what was a very well done study. They looked at 122 patients, not a huge study, with broken down among primary APS, secondary APS, APL positive asymptomatic patients, and 30 suspected APS. And what that group was patients that had clinical events but did not meet laboratory criteria for APS. And then they did a full serological panel. They did the standard testing for ACL, beta 2, and LA. They also did a chemiluminescent assay for antibodies to beta 2 glycoprotein 1 domain 1. They also looked at a particle-based multi-analyte system that looked at antibodies to cardiolipin, beta 2 glycoprotein 1, and PSPT, IgG, IgA, and IgM all in one bead-based system. And then they put these together using the global antiphospholipid syndrome score, which was described back in the mid-teens, and in this one used the 6-component version, and these are the point values that were awarded. And you can see they also include in the score 2 standard risk factors, hyperlipidemia and arterial hypertension. Then they used ROC curves, ROC curves, to assess associations with clinical manifestations of APS. So I just want to point out, I think this study did a lot of things right. They had very well-defined clinical phenotypes. They did a comprehensive serological assessment. They included some of the newer antibodies, which are not yet part of the criteria, not part of triple positivity, but are important to consider as we go forward, and that's beta domain 1 and PSPT. And they included a measure of risk assessment. So I think for right now, if we want to assess the whole panel of antibodies, this type of study is a really good model. So I think that's where we are now. So where should we go? So I think the things I just mentioned, we certainly don't want to not do any of those. But then, you know, I have a few thoughts, and I'm really directing these comments at investigators much more so than clinicians, but things that I would really like to see done to help us advance our understanding of triple positivity and beyond triple positivity. So the first thing that I think is sometimes missed in assays, and I've been saying these things for years, I apologize, but anyway, which is if you're doing immunoassays and you have levels, use them in your analysis. Using a single cutoff point and considering these as dichotomous variables, positive, negative, is useful, and it has some practical implications, but you have a lot more data. And nobody, I think, who works in this field would say that a anti-beta 2 level of 40 units is the same as an anti-beta 2 level of 140 units. And we have that information. Analyzing it is not that difficult. You could do it in, because these are actually semi-quantitative assays. Doing it in tiers may be better than using the raw numbers. Next, a point I've made for at least a decade now is focus on a risk, not just on the diagnosis of APS. You got to keep in mind that trying to look at lab tests that will tell you the difference between asymptomatic patients and APS patients may not be the key thing you really want to look at. You have to realize that all APS patients were asymptomatic before they had clinical manifestations. They all had antibodies. That's assuming, which most of us do, and which some prospective cohorts have shown, that APL do not develop as a result of thrombosis. So just keep in mind that everybody whose APS was asymptomatic APL before. And what's important is if we get a panel on a patient is what does it mean for them going forward? And the third thing, which I've harped on for a long time, is also, if possible, try to study large population-based cohorts. Because of our special interest in this area, we have very considerable selection bias when it comes to the patients we're studying. For a patient to get referred to us or come to our clinic is not at all the same patient that is in the general population or maybe detected in groups of patients with much larger draws. For example, studying in a large hospital, for example, or a large clinical laboratory company, studying all of the sera that were or plasma that were submitted for testing might be more beneficial than just the patients that we get in our clinics. And certainly more representative of what's going on in the real world. Another point is consider studying additional non-criteria laboratory tests. For example, as we talked about, lupus anticoagulants not due to beta-2 or PSBT, and there are certainly some candidates out there. And lastly, continue developing and improving scoring systems like the global APS score. And that concludes my remarks today. Thank you very much.
So thank you very much. Can we have the speakers on the screen, please? And also let me introduce Dr. Cecilia Guillermo. She's a co-chair for this session. She's an hematologist, specialist in thrombosis and hemostasis from the Hospital de Clínicas in Montevideo, Uruguay. Welcome, Dr. Guillermo. Apologies for not putting you up before. And we are running very late. The satellite symposium has started in the other room. For those who are interested on treat to target, for the ones who are interested on APL antibodies and this session, please stay. We are going to give some minutes for a couple of questions. So, any question in the audience? Yes, we have a question there.
Hello, this question is for Dr. Angela Tincani. Hello, doctor. I want to know, what do you think, or if there is something evidence about which should be the management or the follow-up in that patients who become seronegative? If we decide to stop the treatment, should we test for antiphospholipid antibodies again? How frequently? And if you know, what percentage of these patients could become positive again?
You are muted, Angela.
Well,
yeah, you're okay now. Oh.
I am okay?
Yeah.
Okay, thank you for the question. Is a number of questions, in fact. So when a patient becomes negative, there is of course, we have to consider him or her very carefully. Especially, it's something that can make us happy if, for example, this patient had a thrombosis for a cause, a known cause, such as, for example, contraceptive pill or something else. And so these. So the analysis of the first event is something important. In any case, if a patient becomes negative and stay negative for at least 1 year, as we have seen, but if you want, you can also think of 2 years, you can withdraw the oral anticoagulant and give him or her, for example, just low dose aspirin if you want. If this patient will become again positive is something that nobody knows. We just have seen some patients that become negative, but that become positive again, we don't know. We have to follow them. In this case, I think that it is wise to do it each 6 months or each year to test again the patient just to be sure. But it's my personal opinion, there is no study in this sense.
Any other question? So I'm going to put a question to the whole of the panel, speakers and Dr. Guillermo and Dr. Fujita. So we have been learning year over year that the relevant anticardiolipin antibodies, the ones that we test in antiphospholipid syndrome, are beta-2 dependent anticardiolipin antibodies. Therefore, by default, a patient who is positive for anticardiolipin antibodies is a double positive. So when we speak about triple positive, shouldn't we be speaking about a double positive? So a beta-2 dependent anticardiolipin plus lupus anticoagulant instead of cardiolipin plus beta-2 plus lupus anticoagulant. And maybe we should change the definition and call triple positive those with beta-2 dependent anticardiolipin, lupus anticoagulant, and APS-PT. And we have this discussion before with Dr. Ruby, so I give him the first answer.
Thank you. I also want to apologize for my talk running a little bit long, by the way. I had actually, I saw that it ran long, and I actually asked to record it again, and they wouldn't let me. At any rate, I don't think the antibodies detected in anticardiolipin assays, for the most part, are beta-2 dependent anticardiolipin antibodies. They're anti-beta-2 antibodies. I don't think there's no evidence that most of them react with cardiolipin. So I don't know if that answers your question or not.
Any other thought from the other speakers? Dr. Guillermo, please.
Thank you very much. The speakers were very impressive, and I am for this question. I agree with Dr. Robert Ruby. And about his presentation, I think it's very interesting the concept about the APL load and the relationship with lupic anticoagulant. And if it's possible, I want to listen his opinion about this concept, because it's very for me, it's very important. The concept of APL load is not very common to use in the clinical practice.
Yeah, I agree. That's part of the reason I think these scoring systems that combine the different tests together may end up being very valuable. Exactly how to do that the right way, I don't know. We're working on some stuff right now with the APS Action Registry, looking more at semi-quantitative levels, because ELISAs in general, they're semi-quantitative. They're not exactly, they're estimates. And so, rather than adding together units, probably having four tiers maybe of the results, and you still have cutoff issues, but that I'd like to see that ultimately come into play. And I think the cool thing about a lupus anticoagulant assay, if you think about it, is it doesn't care what the antibodies are, as long as there's some antibodies in there that are cross-linking something that's a lupus anticoagulant. So it doesn't discriminate. When we do ELISAs, you got to think, well, I want to do IgM to beta-2, and then you're leaving out everything else. So I think bringing them together in some sort of scoring system is going to be the way to go.
So do you think when we speak about antiphospholipid load is more important the number of antibodies rather than the titer? Because we've been hearing that the higher the titer, the more the risk, but we also know that the higher the titer is because we have the bigger number of antibodies. So should we change the concept when we speak about antiphospholipid load to the number or to the titer?
That's a great question. I don't think I know the answer to that, but I think the number is in some ways artificial because you're counting assays, you're not counting specificities. But I think the answer is probably some form of both.
Any other question from the audience? Any other comment from the speakers?
I mean, to answer your question, I think the more possibility we have, the more mathematically we can improve our scoring system. So combining both APL specificities and APL titers, that's the way to go, because we can go more specific and better our risk stratification.
Can we get gaps that will be more quantitative in the future?
Well, I mean, it would be a combination of the gaps and the APL score, which is more precise. And I think we will use it more for research purposes, but that's the first step to open the door also to clinical and to apply it to patients.
Any other comment? Any other question? Yes, we have another question there, please.
Muchas gracias. Muy buenas todas las presentaciones. Le quería hacer una pregunta a Ricardo Forastiero, algo quizás más práctico. Decías que para poder evaluar anticoagulante lúpico en pacientes que están bajo tratamiento con DOACs, específicamente con inhibidores directos de 10 activado, era necesario poder tener absorbentes o tener la posibilidad de utilizar el veneno de víbora de Taipán con erecarín como confirmatorio. Siendo que en Argentina no están disponibles ninguna de estas dos herramientas, ¿qué perspectiva hay de que puedan estar a corto plazo disponibles? O bueno, si no, directamente supongo que la recomendación es tener que suspender el tratamiento para poder evaluarlos.
So can you repeat the question in English?
The question is about taking into account the reality of Argentina, but also in Latin America, about the not disponibility of DOAC strategies to remove, and also Taipan and Icarin test. The answer is we need, as recommended by the ISDH, or switch to low molecular weight 1 or 2 days before, or stop the DOAC treatment before performing the LA testing. I don't think in the next future, in the next time, will be available, at least in Latin America. And the Taipan, I don't know, but I think it's a company from Europe. So in Argentina, I think there is no distributor. So at least for this part of the world, we have to follow the previous recommendation of stop the DOAC treatment.
I think let's hear to Professor Debres with the ISTH recommendations.
Thank you. I just want to add a small comment on the availability of the DOAC adsorbents. So we have the commercial DOAC adsorbents, DOAC stop, DOAC remove, but instead of these commercial reagents, in fact, you can use just active charcoal. That's just the same, and I suppose that this is available. So that's exactly the same as in the tablets of DOAC stop and DOAC remove. We tested it, and it works equally well as DOAC stop as DOAC remove. So that's an alternative for the commercial DOAC adsorbents.
And regarding the Taipan, because you know every single laboratory follow recommendations of established societies, and we know that there is the work from Gary Moore on the use of Taipan and the ISTH endorsement on the future use of Taipan, and also us from APS Action, we are doing some validation. So I think we are getting there. I don't know when this will happen, but there is a lot of work going on Taipan to make it more available, at least for everyone. Any other question, comment? Thank you very much. Thank you, speakers, for being here, particularly those from Europe at this very late time. And it was a pleasure. Thank you, everyone.